To you all. Welcome to Bangalore Shoulder Summit 2025. And I'm really thankful to all the senior faculty. And I don't think I can get better faculty than what I see today. Starting from Sanjay Desai sir, Nilesh sir, Shiri sir, everybody. And our foreign faculty, Professor No, the president of Shoulder Society of Korea. It's a great honor that the president of the KSCS has come to, grace us and to have a great discussion with us. And I'm very thankful to my team, my co-chair, Dr. Prince, and Dr. Ashish Gupta, and my scientific chair, Dr. Hemant Reddy, everybody, and thank you so much. I hope that we'll have a great program today and tomorrow. This program today afternoon is a very niche program. We wanted to have great discussions on the intricacies of the shoulder, debatable topics, and we want to know what the seniors and the great faculties think about this. So I would invite for the lamp lighting and Dr. Sanjay Desai, Dr. Ashish, Dr. Hemant Reddy, and Dr. Prince to join us.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम्
The first agenda in our meeting is the patch meet. The patch is a hottest topic right now in shoulder surgery. Everybody wants to use a patch, and we have a lot of patches in the market, starting from dermal patches and the braces and different types of patches. So I thought it would be a great idea to have an intricate discussion on the patches. Let's find out what each patch is made of. What is the scientific evidence of each patch? So I would like to first invite our research associate, Ms. Priyamvada, who will actually give a brief intro, a very short intro, and then this will be followed by the talk by Dr. Chin on the pitch patch.
Hello, everyone. A very warm good afternoon to one and all present here. I hope you're all having an amazing time. My name is Priyamvada. I'm a research associate at Shoulder and Sports Injury Unit, Manipal Hospital, Whitefield. And today, I'll be giving you an overview of the different kinds of patches that are available for treating rotator cuff injuries. But before we dive into that, let's take a quick look back at how we got to where we are today at treating rotator cuff injuries. So here's a brief history. The first ever description of rotator cuff injury was made by Alexander Munro in 1788. Later, in 1834, John G. Smith detailed several cases of torn rotator cuff tendons. The first ever reported attempt to repair a rotator cuff dates back to 1870 when Hutter performed a repair after a chronic shoulder dislocation. It was in 1978 that Navyasar and colleagues proposed the use of grafts to bridge irreparable tears. They used a freeze-dried sample of cadaveric rotator cuff graft. Over the years, several innovative approaches have emerged. For instance, Ozaki and team in 1986 tried using synthetic grafts like polyester and Teflon. Now, in more recent decades, the shift has moved towards biological scaffolds and minimally invasive options. For instance, graft jacket, that is an acellular human dermal graft. Another novel technique for management of irreparable cuff tears was put forward by Savarasi and Romeo, which provides a less invasive option to arthroplasty. They described using a biodegradable subacromial balloon spacer between the humeral head and acromion. Now, here we have a person who has a tear and he needs surgery. Now, let's look at what are the kinds of patches that are available for him. Now, types of patches and grafts can be classified into many ways. One of the ways is based on species. If the graft is obtained from the same individual, the graft is called an autograft. If it's obtained from another individual but the same species, it's called an allograft. And a different species altogether is called a xenograft. Based on source, again, they can be classified as natural, where biomaterials like collagen and alginate can be used. Synthetic biodegradable, where polycaprolactone and polylactic coglycolic acid are used as biomaterials. And synthetic non-biodegradable, where polyester, propylene, etc. are used to make the graft. Now let's take a look at some common patches and grafts available in the market today. Fascia lata graft, it's a natural autograft or allograft. Regenitin, it's a bioinductive natural xenograft. It's bioinductive because it's able to change the physiology around that area. It dissolves within time and the natural physiology of the body retains function. Then we have pitch patch, which is an entirely synthetic patch. It is non-degradable. We also have some options for dermal patches, like the one from Arthrex and Cironix. These are natural allografts. We have BioBrace, which is a hybrid bioinductive and structural graft. It's synthetic in nature, it's degradable, and it's a xenograft. So not only is it able to have the functionality of bioinduction, but it also provides structural strength. Then we have striker balloon. It is not a patch, but it is a synthetic biodegradable subacromial balloon spacer. It is, as I mentioned before, it serves as an alternative in some ways. Then we have a technique called biceps smash, where the biceps is taken and attached to the area, and it is natural and obviously autograph. Thank you so much. And as we move forward today, I hope the vast expertise that we have here gives us vast perspectives. And thank you so much.
Thank you, Priyam, for that brief introduction. Now I'd like to invite Dr. Hemant Reddy sir, Dr. Pramod, Dr. Lenin Ligu, and Dr. Himanshu Gupta to chair the next session, please. Dr. Pramod. So now we are going to start the patch meet. It's going to be started by international faculty, Dr. Quinn Chin. He's coming from Singapore. So he'll be talking about the pitch patch technique. So Dr. Quinn Chin, sir, please come. Okay.
Hello, everyone. Thank you for inviting me to this fantastic meeting. The first time in India for me, and it's amazing. So I'm here to talk about the techniques for pitch patch. So just a bit of background of myself. I've been a consultant in London, East London, for a couple of years, but I've just recently relocated to Singapore. So my acknowledgement to Jan Loitzanger, who kindly shared the surgical illustration techniques and concepts. I've no financial conflict with any of the companies, including Kairos. So briefly, the idea of using this patch was to reinforce a tendon that we think we can repair, but we shouldn't repair in the past because of the tendon quality. So it's meant to increase the strength of the repair. The pitch patch come in two sizes, standard and large size. 90% of the time, the standard size is enough for a superior cuff. It's a synthetic material made of polyester. It's safe because it doesn't have any risk of residual animals or human DNAs or proteins that can cause foreign body reactions. It's strong. The breakdown strength is about 300 newtons. And it's made simple because there are pre-fashion holes for passing the suture across the patch. So the distance of the suture will be appropriately spaced out. And it depends on where you are. Certainly in England, it's a lot cheaper than other products. So this can be done arthroscopic or arthroscopic assisted, and it's an onlay system in the sense that the graft is onlay onto the tendon after a repair. So the prerequisite is to achieve reductions and repair of the graft. Now this is not meant to be a bridging materials. It's supposed to be reinforcing a repair that we think that we can repair, but the tendons are not so good. Often, two experienced arthroscopic working together is very helpful because of the techniques involved in shuttling. But of course, I appreciate that not everyone has a good assistant, and certainly in my practice, I don't have a senior resident. Often I get a first year resident, so I've modified the technique a little bit to arthroscopic assisted. So if you look at the top left, these are the pictures again from Dr. Loitzinger, is that we have achieved a margin conversions and a double row repair of a rather complex suture, a cuff tear. Then the first step is to achieve passing sutures to the medial tendons at the muscular tendinous junctions. The important thing is to use a curved suture passes with appropriate length and distance. So I find it over the years that the ConMed Spectrum MVP has the best curvatures for me to achieve this. And I learned this, I've been struggling initially to try to put a patch in and try to get a good purchase, but until I visited Dr. Loitzinger, this is the suture passer that he used. It's cannulated, so you pass if you look at the bottom left, you can see that you pass a PDS sutures into the tendon, and then you shuttle it out through the lateral portal. So you need to pass two sutures, one on the anterior and one on the posterior medial cuff. Right, to achieve the one on the front, you go through the anterior portal, and then you retrieve the sutures from a lateral portal, which you should put a passport cannula or any cannula of large aperture, because it's the lateral portal that you're going to shuttle your graft in. So this is an animation. So after achieving a double row repair, you pass two sutures, one on the medial and one on the anterior and one on the posterior of the medial muscular tendinous junctions. These are the 5 portals that we will use: posterior viewing, ASL, anterior, and the Wilmington. So after we've done the front one, we shutter the PDS sutures through the medial side. As you can see, there are 2 sutures. So these sutures will be coming out from the anterior portal, and this will be from the lateral portal. Then we pass it again in the middle pictures. Then finally, we shutter the graft in. We can use a coher or a kingfisher to fold the graft, and then we deliver into the passport cannula. There's one important tips for this is that when you do the posterior, sutures, it's easier to use the suture passer to pass into the tendon. It's easier. It's easier to pass the sutures into the medial tendon via the Wilmington portal. Via the Wilmington portal. And once that's done, you shuttle your posterior sutures out from the posterior portal whilst viewing from the front. This will give you an easier line of pull. So this is the animation again. You prepare the graft outside the patients. Once you take the 2 sutures out from the cannula, you tie a knot over the medial patch, and then you prepare 2 more separate patch on the lateral holes. Once that's done, this suture, as I said, from the posterior viewing portal, the standard posterior viewing portal, rather than from the Wilmington. You use the Wilmington to pass the suture, but then you retrieve it from the posterior so that you get a better line of pull. So once you have both of them in, you shuttle them into the tissue, into the shoulder. So once this is in, you tie the knots like so. Use the suture knot pusher, tie it down, and then once that's achieved, you take the lateral side, you put it onto a knotless anchor, and insert as a lateral row, like so. And this is the final construct. After once you put the medial, you tie the medial side down and put the lateral side with the double row, with the knotless anchor down, you are left with 3 holes, the purple one and the orange one. You need to pass them separately, and again, using this suture passer is very helpful. It has the correct curvatures and length. And the little tips I have learned from Dr. Lloyd Zinger is that you put this tip next to the hole, and then you simply move your suture passer slightly to the side, and you will get a nice pass, and it will go through these holes very, very easily. This is a pre-fashion hose, and you'll be surprised when you use this. It's so easy, and once you pass through the tendon, it will just find its way into this hole. Then again, we use the PDS to shuttle the suture down. We tie it down with a knot pusher. We cut the sutures, and this is the final construct. This is not easy because you will be passing sutures, shuttling them. So you need a good assistant who can hold the camera for you or shuttle and take the suture out for you. It's a 2-person job. If you have a good fellows or a very senior resident, it's okay. In my practice, I find it very difficult to find one. So I do it in a slightly different way, from an SCR inspired way. The way I do them is that I use a first pass suture passer. It's big enough for me to purchase the medial side of the muscular tendinous junction. I pass them as a mattress 3 times. So I got 3 sutures on the medial side. Then I put 2 knotless anchor into the greater tuberosity, pass them through the cuff again. I take all of them out, and I tie them outside the patients onto the graft, and I shuttle them down, tie the knots as how Dr. Lloyd Zinger showed it. But on the lateral side, they are all pre-filled, so you just sandwich them into a split bridge fashion and tie them down. This gives me a slightly better compression of the graft, in my thoughts. This is a picture of how it can be done. So the last bit of this I prefer to do via a mini open, and you can see it's essentially the size of 2 Langenbach. This way, when I pass the 2 lateral anchors in, I know it's easy to put in, and it saves me some time, because I really don't have a good residence to show me the area, clean it up, and allow me to put the anchors in. It can also be used in trauma situation. This gentleman has a fracture of the greater tuberosity, where he has a previous cuff repair. So after fixing that, I reinforce it with a graft. These are the evidence. This is a paper from Dr. Lloyd Zinger for 52 months. Follow-up, PET 2 and 3 tests, retear rates of only 14%. One patient has a removal of the graft because of constant clicking. Significant constant score improvements as usual. From this patient where the graft was removed, you can see these are the fibers. The white colors are artifacts from the suture fixation. But you can see the growth of the fibrocytes, ingrowth around the fibers. This is the intraoperative pictures before Dr. Lloyd Zinger removed the patch, and after removing the patch, you can see the heel tendon on the bottom.
Dr. Chin, sorry to interrupt. The time is up.
Yeah,
So if you can finish up fast, would be great.
Yeah, this is the last 2 slides. This is a result from another team, and again they shows the similar results of only on a small 15 group patients. They show only 3 failures and a 30% of a Sugaya grade 5, 50% tear, partial tears on the repair of the tendon. Thank you very much.
We can have 2 questions, sir, and then we'll go on to the next talk.
We'll keep the questions to the last.
We can finish up, sir. Now itself 2 questions and just 2 questions.
Dr. Chin,
Yes, hi.
do you recommend it for an irreparable cuff, or all the cuffs have to be repaired?
They were repairable cuff. So they are cuff that we can repair, but in the past we think we shouldn't repair because of the poor quality, fatty infiltration, retractions, and or on MRI you see the signal changes. They are really edematous, and you know that when you pull this down, the reason why I changed to this graph, it was because I had a lot of medial row failures when I do a split bridge, and I start realizing that I need to protect them beyond the split bridge. So I put a graph medial to the muscular tendinous junctions.
How much of the load sharing happens between the patch and the graft and the tendon?
I do not know the actual data of this, but I knew that clinically they do quite well.
If you say you are crossing the medial, you are crossing the beyond the lateral row, that means you are load sharing.
That's what I was trying to achieve with my techniques, the open techniques. It not just that it goes through the curve, it goes through the patch, and then we compress it down with the two lateral rows, as you can see from the last slides. Whereas with Dr. Lloyd Zinger's technique, it was literally laying onto the graph, onto the tendon.
Thank you very much, Doc.
Thank you.
Next speaker.
Yes. Attention to all the faculties, kindly keep the time to 5 minutes, because after 5 minutes, because we have a long way to go, so we'll be switching off the screen. So kindly and finish off in 5 minutes.
Thank you, Dr. Chin, for this wonderful talk. Next, we call upon stage Dr. Nilesh Kamatsa for his take on the regenetin. Thank you.
Right, so it's a technique-based talk. Thank you, Dr. Ayappan, for the meetings. I'm going to try to stick to time. So we know the standard of care for a cuff repair could either be a single row or a double row. But what you're essentially trying to do is get a healed bone tendon interface. So if you look at this paper from the Lyon Clinic, when you look at patients over the age of 65, the retear rate could be as high as 32%, and then even in the younger crowd could be around 20 to 15%. And these are not acceptable rates. So what is it that we try to do? We want to get that to heal. And that's where you could either optimize biology and provide structural integrity. That's where patches come into picture. So what exactly is a bioinductive implant? Because what I'm going to talk about is not a true patch, it's a bioinductive implant. It is defined as an material or an implant that encourages a favorable biological response from the body. And that's exactly what is regenetin. It is a bovine, highly porous, precisely oriented, reconstituted collagen implant, and it's in a purified form. It stimulates the body's healing response, so allows for collagen ingrowth and disrupts the disease progression, and it gradually absorbs over 3 months and disappears by 6 months, resulting in only tendon out there. So you're not looking at something which is going to stay in the body throughout. How does the delivery kit come in? It comes in at all these disposables. You have a delivery system which is wherein the graft is preloaded. The graft comes in two forms, either a medium or a large. Typically for all my cases, I've used the large, which is 25 by 31 millimeters. You have the PDA staples, you have the peak staples, and I'll talk about that in a bit. So if you look at the animation, you get in a cuff repair. A low tension cuff repair is what is prudent. You put the patch as an onlay, you fix the medial side with PDA staple or sutures or PDA staples, the lateral side with peak. And what it does is over the next 3 to 6 months, it allows tissue to grow into the collagen, and that results in a complete tendon formation out here. So the case in discussion out here, 69-year-old male politician was diagnosed with a painful shoulder for the last 6 to 8 months. His disability was night pain, weakness, loss of shoulder function. Although was diagnosed as a cuff tear 6 months back, has had an injection, has not settling down. So effectively, he's now come with seeking a definitive treatment. Clinically, range of motion practically up to 100 degrees, and has been painful. All the cuff signs have been positive. These are the x-rays, does not show any arthritis. Those are the MR pictures. And if you look at the MR pictures clearly, what you're worried about is not the retraction, it's the duration, because I've spoken about more than 6 months. And if you look at it closely, these are delaminated tears. And all of us get these patients in clinical practice where your tears are not something which are just avulged off, but you can clearly see there's a delamination. And you want this to unite together, and you want this to come all the way to the medial aspect. So The fatty infiltration as such is not significant. You can possibly label this as grade 1 to grade 2, although the tangent sign is positive, but the infraspinatus is looking good. So what are we looking at? So in summary, you have a 65-year-old active individual, you're looking at a surgical repair, but the problems that I'm anticipating is the chronicity of the tear, the thinning of the tendon, delamination, demanding patient, and age. These are his operative findings. And you can see that there's no arthritic change, but when you go around and try to look at the cuff, you can clearly see that there are two laminas out here. And the medial lamina has gone way far behind. When you look at it from the bursal side or the subacromial side, you can see it's a significantly sizable tear. And when you look at it closely, you will see that the entire delamination runs all the way across through the supraspinatus, and that's where your concern is. And these are the ideal cases for me where I would probably think about getting in a regeneratin. You go ahead, do a standard repair, and you put in your medial anchors, you get them across, do a classic transosseous equivalent, and then you're going to get your patch across. Once you put the patch across, this is how it unfolds. You're going to place it in the optimal position. The medial side, you're going to fix it by means of your peak staples, and on the medial side is PDA staples, and laterally on the bone, you're going to come up and fix them with two peak staples. And this is your final construct. How does it pan out later? If you look at your post-op MRs, this is where what you need to be worried about is that there will be an inflammatory reaction in the initial period, but look at the quality of the tendon. The thinned out tendon has now thickened out, and that's something that you would want to look. This is his MR, this was pre-op, and this is post-op, and that's the desirable response that you would want. For want of time, I'm not going to go into further details. So in the true sense, where you want to initiate biology, that's where I would probably be using a regeneratin rather than using it for every of my case.
Just a quick question.
Yeah.
What should be your extent of while putting the patch? Should we go more medial or should we stay more on tendon and slightly on the lateral side?
So just the technical thing here is that when I get my lateral anchors here, I put them far lateral below, and my patch ends typically between my medial row and the lateral row laterally. So because I don't use a medium, so I told you the dimensions, it's 25 by 31. When you put the patch across, if you're keeping it there between the medial and the lateral row, it classically covers the myotendinous junction. I've never had a scenario where the tendon was so big that I could not cover the myotendinous junction. But then I don't want to go far too medially because I want a lateral purchase which has to be on bone, and I don't want that to coalesce with my lateral anchors.
It has to be towards the myotendinous.
It has to cover the myotendinous junction. That's where the tendon is going to reform.
Sir, we'll go for next talk. So we're running slightly late.
Sir, talk.
Next talk. Yeah. Sir,
Sure.
Thank you.
Thank
sir.
you.
Thank you, sir. Big round of applause, please. Please encourage the faculties.
So good evening. So I'll stick on to time. So the message is very clear. We all just want something more than just repair for the tendon to heal well. So we saw the pitch patch. We saw the bioinductive implant. We married these two. We get the bio brace. Yeah. So we'll see quickly about. This has already been talked about. The consensus is from 2020. Most of us want something extra. So a bio brace is like the same indication like Nilesh has already given us. This is a 55-year-old female, exactly the same case like Dr. Nilesh's, but this is the politician's wife. So he's a homemaker. She does yoga. She had a fall 3 months back. All conservative measures failed. She has got a little bit of calcification and a little bit of chafing on the greater tuberosity. Has got all the signs of rotator cuff possible. Wants to go back to yoga, and she is wealthy. So when you see the MRI, you see a grade 2 to 3 patties, and the exact same thing that Dr. Nilesh has showed us with a little bit of subscap there. So the options that we have are everything that we can do, something more. Yeah. So I chose to do the transversus repair with the BioBrace in this patient because of want of biology. You see a torn and subluxed biceps. I let go of the biceps, and then I put a tack suture on the subscapularis and put the subscap on back to the lesser tuberosity. So I put this because we have to be thoroughly sure that we take the basics right and always make sure that all the other things are done. Don't leave anything to the patch. So the patch is only an additional procedure. So that's the subscap done thoroughly, and then go on back to the subacromial space. You have to actually do a good subacromial decompression here, because after the biobrace goes inside, it imbibes water and fluid, and it expands in diameter. It's 3 to 5 millimeter in diameter. It goes up to 8 millimeter, takes up to 180 percentage of more fluid inside it. That's the beauty of the biobrace. Now the transosseous tunnel is done. You get 4 sutures out of the transosseous tunnel medially, and then take 4 bites. The medial bite I let it for the biobrace. So this is as good as the suture anchor technique, the transosseous technique, but as better as the transosseous equivalent. So that's the first anchor, the first transosseous tunnel with 4 bites inside, retrieved it anteriorly, and then comes the second tunnel. Second tunnel is little wider and posterior. We have to cover the whole of the footprint. So that's the first one. This is the second one for the pilot hole. The exact same thing, take the bites all over the cuff, and then once the bites are taken, you do the thorough transosseous repair. Total of 8 bites. You leave the central 2 bites or 4 bites for the biobrace transportation. This is a thoroughly done transosseous repair. Good footprint cover without tension. So this is more than enough for most of our patients. But if the patient wants something extra and you want something extra, you want the enthesis to heal better, the biobrace is a tabletop option. It doesn't have to have a storage temperature. When you take it in hand, it is a 2 by 3 centimeter thermocol like substance with good meshwork. You cannot see the meshwork because it's coated with type 1 collagen. It is powdery. When it goes inside the saline, it becomes little pliable, and then you take those biobrace shuttle sutures off, and then knead those biobrace shuttle sutures through the biobrace, and then pre-suture it on the outside, and then do a double pulley knot on the medial aspect, and then pull the lateral row, so that lateral pulley, so the biobrace goes inside. After it gets imbibed with water, it becomes little pliable. You can use your soft tissue grasper and then push this graft slightly inside your passport cannula. So nothing really happens. It is actually as good as a strong graft. So nothing is going to happen. You just have to push that gently inside and then pull your lateral sutures. So this goes and sits on top of the repair beautifully. Like you said, it has to little overlay on the medial repair that you have done, and then pass point the lateral row. Once the fixation of the medial edge is done, then you pull on the lateral pulley, so the graft sits properly. You can spread the biobrace with the probe, and then once that is done, so the medial row is seated with the sutures that you have pre-made already, and the lateral row is actually, you can finish it off with this, but for the want of good stability, what I did is I took both the medial row sutures and then pushed it back onto a lateral row suture. So that's the lateral row covering the entire cuff properly. So once that is done, you can see that is entirely seated well. I am now rest assured that the enthesis should supposedly heal well. So you can also use an alternative method by soaking it in blood before introducing it, because it has some effect. So this is one of the case report. That this is not my case report. This is one of the case report. This is at 8 months, 3 months and 8 months MRI, and this is at 10 months post-operatively. That has a good cover. So biobrace reinforces, it regenerates, it resorbs in 2 years, and it's a robust compatible handling characteristics, and it dissolves in 2 years time, giving you good outcomes. So in conclusion, we don't have good evidence, but I think this should work. Thank you.
So we can have 2 questions, please.
Sir, one question.
Yeah.
Is it your preoperative decision or an intraoperative decision to use all these?
It is a
patches?
preoperative decision.
Or
of
is there
course.
any certain criteria you see in your MRI so that you demand that this patient needs a brace support?
That is little difficult to answer, but probably Gotelius 3, 4, 2, 3, you can start using it. Retest, definitely you can use something as a substrate for additional healing. Yeah, but it is definitely a preoperative decision, not a post.
How good these patches are when compared to your natural collagen donor like a biceps?
I've never done a biceps before, but it is robust. It feels very robust in your hand. So, and it is PLLA, it is going to absorb, and it has got good measures. You know, some progenitor cells are going to sit inside that, and you're going to get a good transfer. Yeah.
So can with this biobrace, a partial repair is gonna work? So if you're able to do a good infraspinatus repair and a partial repair for supraspinatus and try to put this biobrace, because this puts mechanical as well as the
Yes.
bioinductive
Yes.
quality.
Yes.
Will that work?
Should work, but we do not have the studies yet, but should work. But because it is robust.
It's robust.
Yeah.
Thank you, Prakash.
Thank you.
Great talk.
Thank you, Prakash sir. Now for the next set of moderators. Thank you, moderators. So next is Dr. Anand sir, Dr. Satish Sarvega sir, Dr. Amit Jha, Dr. Preetham Nagraj sir. The next speaker is Dr. Shirish Pathak. So he'll be joining on a Zoom call. His flight got cancelled. So yeah, we're going live. Yeah.
Yeah. Can you hear me well?
Yeah, we can hear, sir. We can hear you, please.
Yeah.
Go ahead, sir.
So, thank you, Ayyappan and BSS team. I'll see you soon, maybe tomorrow morning. So, I'm going to speak about use of a cellular humoral dermal patch augmentation in my cuff repair service. So, disclosures: I have no financial or conflicts of interest with presented material. I have done few cases and still in the stage of assessing my own result for my patients. So we all know the indications: repairable or partially repairable or at times irreparable cuff tears can be treated with dermal patch augmentation. So what is augmentation? You are going to add a patch or mesh to improve strength as well as healing of the tendon tear repair. So indications are typically whatever has been discussed, going to be the same. Addition, there is a big potential that this graft can be used for alternative to HCR or at times as an interposition graft. There is a lot of literature supporting this. So I won't go through this. So there are two techniques: onlay over the repaired tissue, bridging, and third is HCR. So in my practice, I've done few cases with onlay technique where tear was repairable. So what are ideal augment patch characteristics? So it has to have good mechanical properties. It should promote healing, low infection risk. It should be bioabsorbable, easily available, and affordable. So I think in this scenario, dermal patches definitely are emerging as a promising augmentation strategy. It is typically derived from a donor human dermis. It's an allograft. It is processed to remove DNA cellular components, reducing its immunogenicity. And at the same time, we retain the native extracellular matrix structure to support cell infiltration and vascularization. So what we have globally available is probably three types of patches: Orthoflex by Arthrex, Graft Jacket available in UK, and now what is available in India is Novoderm, which is made available by Seronix, a cellular allograft derived from donor human dermis. So it is typically available in two sizes: 5 by 5 centimeter or 7.5 by 7.5 centimeter. Thickness is about 2 millimeter. The beauty is it can be folded once or twice, and they have tested the ultimate tensile strength, which is in the range of 200 newtons or more. If you compare the thickness, more or less all dermal patches, they are in the range of 2 to 3 millimeter in thickness, and probably Regent 10 is the thinner 0.5 millimeter. And typical TFL, tensor fascial at SCR, what we make is 6 millimeter. So these are thinner but can be double or triple folded. So I'm going to take you through a small video.
Audio, just check for the audio, please.
Shirish sir, we cannot hear you actually. Hello? Hello? Yeah, Shirish sir, we can't hear you right now. Can you try reconnecting? Go to the next one.
I think we'll reconnect you to Shirish a little later at the end of this. So next talk, please.
I invite Dr. Bhupesh Karthik sir. Come forward, sir, please. So he'll be talking about the Arthrex dermal patch. Welcome, sir.
Good afternoon. I will be talking on the Arthrex dermal patch, which is not yet launched in India. So, financial disclosure, I have nothing to disclose. And these are what I do. More importantly, the post I hold is I am his friend. So, he said, "You come and talk on this." I said, "I have a family meeting." He said, "Shut up and come. You have no choice." So, I said, "Okay, I'll be here and try to do what I can do." So this is an acellular bioimplant basically. It is a decellularized regenerative dermal matrix. It is processed through this technology called Matra cell. Through this technology, they decellularize the human dermis and they provide us with an allograft, which is a collagen scaffold. This helps in ingrowth of the patient's own tissue. So why this graft? Because it supports cellular repopulation and you have revascularization into this graft and this is supported by this article. So decellularization is the process through which we make an acellular scaffold. Why Arthroflex? Because it is ready to use. It is hydrated, which gives a good environment for healing. It is sterile, off the shelf, can be stored in room temperature up to 3 years. Because it is decellularized, 97% of the DNA is removed, so it is biocompatible, no adverse reactions and no graft rejections. Because it is dermis, it has excellent suture retention and strength and an intact framework which will not cut through. The process of decellularizing is called the Matrahil. This is their patented technique. They remove the donor cells and the DNA without sacrificing the strength or the biomechanical properties of this graft. It undergoes 3 processes, series of washes and soaks to remove the cells. Then antibiotics and detergents are removed by rinsing and it is hydrated so that it can be stored in room temperature for up to 3 years. For the orthopedic mind, this is how it looks. It is a acellular, extracellular matrix, lot of pores, so lot of good tissue can go in and heal into this porous coat. For the non-orthopedic mind, this is how it looks. All the cells are removed and there is extracellular matrix. I don't think we understand a lot of this, but you have to understand that it is porous. Only the ECM is there, cells are removed. Because cells are removed, there are no DNA residues and the first 3 columns show the ECM, the extracellular matrix containing the collagen, and the last 3 shows the growth factors. So there is conductive property and a bit of inductive property with this. One of the patients who had a re-injury, a biopsy was taken and then they found fibrocartilage, blood vessels and tendon-like structure which grows into this graft. This is how it looks. The dermal side will go towards the rotator cuff and the basement side will go towards the acromion for you to use it. It gives excellent security. They have done this study with other meshes and gives good strength. So basically, to summarize, it's a strong collagen scaffold. Fibroblasts of the patient will infiltrate and will deposit, and collagen gets deposited. Neovascularization happens. It can absorb lead and growth factors at the repair site to promote and give you a good healing environment. Arthrex suggests to use this for partial tears where repair of the tear is not done and then you just put on the graft, or for full thickness tears where you repair and then you put it on lay as discussed before. There is remodeling, revascularization and recellularization, and this comes in various thickness. The 3 mm can be used with the maximum strength. I have another minute. So it can be used through the posterior approach or the lateral approach, and you have your meniscal suture like anchors, fiber stitch anchors that will, for the rotator cuff, that will go and secure it medially, and laterally you can secure it with your self punching push lock push lock anchors. So that is how you secure these grafts. Arthrex also asks us to use it as a standalone graft for superior capsular reconstruction with the 3 mm. There is data yet to come to support this, but this is suggested by Arthrex, and that's how maybe it would look. Thank you.
Yes. Any questions, sir? Please.
Bhupesh.
Bhupesh, the question.
Sir, any data regarding aseptic inflammatory response in this?
Sir, of the literature that I studied, because we have not used, it's not in India, of the literature that I studied, there is no, everything looks flowery from the literature, but time should tell us if such things can happen. On a theoretical note, maybe no, because there is no DNA, there is no cells there, it is only a extracellular matrix with collagen, wherein the patient's tissues can grow. It is a beautiful scaffold, that is what literature says.
It can be used as a load sharing as well, what you...
Yes. And because it is dermis, the strength is going to be good. It cannot cut through and come.
Thank you.
Thank you.
Thank you, sir. Next, I invite Major Arvind Rajan for his take on bicep smasher technique.
Very good afternoon to all the dignitaries on and off the stage, and special gratitudes to Dr. Ayyappan sir for giving me this opportunity to stand here and say a few words on bicep smasher technique. So basically, continuing in line with the discussion so far, the indications and the requirements remains the same. So what are we looking for? We are looking for an augmentation to the in a cuff repair with a where the rotator cuff healing is in question and the rates of retear might be high. So in such cases, we have seen so many patches here. So continuing in that, why not a patch which can be obtained from the vicinity of the surgery, which is free in availability and also has got some extra advantages over the conventional patches. So these are my references. So there were some the scaffold studies were done by Tokesh et al., which showed that there were certain changes in the biology of the long head of biceps tendon when they were smashed into stamps. So there was change in the area, the tensile properties, and also the tenocyte viability. So they showed that the area could be increased at a great range to accommodate for the massive rotator cuff tears. The area to which can be expanded ranged from 25 mm in length to 15 mm width and thickness of 2 mm, as less as 2 mm. Even though the tensile strength and the tensile modulus were considerably reduced as compared to the native biceps tendon, but they found that there was tenocyte viability enough to induce further tenocyte production, which helps in augmentation and recruitment of the mesenchymal stem cells, which can accelerate the healing actually. So this was the initial experiments that were done, in which initially they were butterfly slicing of the tendon was done, where the various biomechanical properties were studied, and also initially it was done using a skin measure to study the initial properties. Later on, it was found that the tenocytes derived from these long head of biceps tendon scaffolds actually expressed some soluble signals which initiated the mesenchymal cell differentiation and to make the immature tenocytes phenotype. And it was indicated by increase in certain markers like the scleraxis and collagen type 3 mRNA expression, which ultimately meant that yes, it plays a role in the healing of the rotator cuff tendon. So just briefly going to the technique as such. So yeah. So the technique initially involves the harvest of the long head of biceps tendon, which includes an intra-articular tenotomy followed by a subpectoral tenotomy is done. That is to ensure that we get an adequate length of at least 4 centimeter, following which a tenodesis has been done, subpectoral tenodesis has been done, as you can see, and the harvested tendon is measured and it's placed into a special device to make a stamp out of it. Here there is a measurement device over there which looks for the amount of tension applied, and the usual duration to which it should be done is minimum of 3 minutes. After which you will get a dimension of at least 25 mm into 5 mm with a average thickness of around 2 mm. Here we can see that with the standard medial row repair, using the passport cannula, and there is a separate graft expander is also available, which is not shown in this video, which can be used to expand the graft, fold it, pass it through the passport cannula, and then expand it intra-articularly. Once the medial row repair is done, followed by which we make sure that the sutures are made on the cuff, and then the remaining sutures can be used to fix the medial aspect of the smashed biceps. Following which we can proceed with the lateral, the transosseous equivalent lateral row repair with 2 soil locks. So what are the advantages? This specific system gives you an uniform preparation of the tendon, better structural integrity, and it is easier to insert surgically. And a latest study by Tokish et al. Showed that there is actually 93% tenocyte viability in smashed samples as compared to the 96% in the non-smashed samples, which is adequate enough to provide the initial tenocyte support which can help in biological augmentation of your cuff. Even the MRI follow-up showed that there is complete healing with no patch visible after an average of 4.5 to 6 months. So, but what are the disadvantages? One, of course, as it's also a trick in the surgery to make sure that you have adequate subacromial space so that even though the overall thickness is increased, it does not hamper your repair. Thank you.
We can have a question or two, sir.
Is double row repair is prerequisite to do this kind of patches like smasher or
Sir, there are various techniques established, but these are the popular ones in which a double row technique is used, and especially the coverage of the myocutaneous junction is more important because that's the usual place after the double row repair where the re-tear chances are higher.
Does the idea of taking the biceps tendon change if there is any MRI finding or the arthroscopic finding showing bad quality of the tendon or fraying?
Yes, sir. It is given as one of the disadvantages of this technique. Too much degenerated or fraying of the biceps tendon is usually not ideal for this technique, even though it can be used, but it's not ideal.
Thank you so much, Arvind, and thank you so much, Bangalore.
What is the thickness you got? How thin it was?
So it was 2 mm thin, sir. Thank you, sir.
Thank you, Dr. Arvind. So now we are going to have a debate on and get a consensus on the patches. This is going to be moderated by Dr. Ashish Gupta, sir, from Australia.
Sir, can we have a photograph, Satish, sir? One photograph with the... Thank you so much, sirs.
If we think we're going to get a consensus in 10 minutes, it's a miracle, because in my experience, even with 2 orthopedic surgeons, you can never get a consensus.
Can we have the faculty of the patches onto the dais, please? Dr. Chin, Prakash.
So, Dr. Chin, Nilesh, Prakash,
And
Sirish is
Dr.
online.
Shirish is on
He's online.
online.
Bhupesh,
Yes.
Arvind. Sirish, sorry, we missed the last bit of your
Arvind?
talk.
Arvind.
While we are setting up here, can you just tell us, like we could see the video, it looked very, very impressive. What's your early experience with the graft you're using?
So I think still I'm waiting for my own results, but what I showed was there is adequate literature. Especially I was quoting paper by Dr. Amit Modi,
Yeah.
where he has done more than 400 graft jacket surgeries. And the last paper which the group published from Leicester in 22, they showed 47 patients followed up for 9 years with a very good functional and pain scores. So I think if we have a good dermal patch, it is a very augmentation repair tool, especially with partial repair or even irreparable cuff tears. It can be used as HCR. There is a meta-analysis in 2020 where they have compared TFL versus dermal patch and almost same complication and retear rates.
Okay, thank you. I think so. My biggest problem is I believe all patches are bullshit. So you have to convince me, and then we're going to debate. So I think everybody here agrees. Let's just break a complex problem down. We all believe we need some kind of a reinforcement for our cuff repairs. Basically, we're trying to say that the cuff repair we're doing, no matter how great we think we are as orthopedic surgeons, it's not good enough because there is a God and then there's a patient who wrecks everything else up. So we need something more. So we've got Jan's patch, which is the synthetic patch. You've got pork and bovine patches. I usually like them on my dinner plate, not inside my shoulder. And I would like to ask, because people have asked me this, what is the response of in the Middle East and in India for people to have bovine and porcine patches themselves? We'll talk about that. And then we've got dermal patches. And then we've got the Arthrex patch, which always works. And then we've got the Bicer Smasher from Arthrex because the patch worked. So number one thing is, let's talk about indication. So we want 5 indications before we finish the session as to what is the indication for a patch. So we start with Dr. Chin. You just got to give me one, because I want to get one from everybody. I don't want 5 from you. I just want, what is your one indication in where you're going to use this patch?
So my decision is more preoperative than intraoperative. And the reason why I started to use the patch was because when I got double row failure and when I go back to medial row failure and when I go back to analyze the MRI, I find that those are the people who have really increased signals, edema on the tendon, all the way down to the muscular tendinous junctions. Those are the quality of tendon that's really not that good. Once you put a suture through, it's going to cut through. And those, once I saw that kind of tissue signal, those are the one that I will use a graft.
Okay, so basically what he's saying is, we in Australia we say you can't make chicken pie out of chicken shit. So basically what you're saying is, if the quality of the tendon is crap, we need augmentation.
Yeah, these are in my limited experience. Of course, I'm not as senior as all the panels here, but in my limited experience of what I've seen is that those cuffs, when you intraoperatively, they look fairly normal. It's just the signals on MRI scan that actually.
So this is an MRI finding for you then?
Yeah.
Okay, we'll come to that, but I'll take that. Nilesh, what is your indication?
So I think at the outset I'll give a disclaimer that Regentin is not to be looked at as a patch.
Yes.
It should not be categorized as a patch because it is not a patch. It is something to initiate biology. It's more of an implant. So
I don't want you to talk about Regentin.
So fair enough, because I was talking about that. So I think for me, if I'm using that particular,
if you're going to use an augmentation, yes.
Yeah. So probably I need something which has a blend of biology, because here there's no strength out there with this particular product. But if I'm talking about patch in general, I would still want to do a repair which is a
We're talking about indication right now.
Yeah, so that's where I'm looking at a low tension repair with poor tension or poor tissue quality. So a delaminated tear is where I would probably, if you want one particular indication, a delaminated tear is somewhere where I would think about putting in a patch
But
to protect my
almost
repair.
every supra-infra tear is delaminated. So do we
So-
patch everybody?
I think beyond 65, I don't mind doing that.
Okay, so we've got two indications now. One, and why 60? What about 63, 67?
So I think if you look at literature, 65 is more or less the ballpark. I can't debate on that. That why not 63? Why not 64? But roughly, if you're
Someone
looking
older.
at you look at the physiological age, you assess on a patient come basis, on a one-on-one basis, and then take a call. But roughly, if you were forcing me to get a figure out of my mouth, I would probably put 65 as the ballpark.
Okay, my question, I'll give this question to Bhupesh. Bhupesh, in my brain, a 65-year-old does better with a reverse shoulder replacement than a failed cuff repair with a patch. So is a younger person's cuff an indication in your brain to use an augmentation device? Or do you think it is more for someone who's older? So you have a bad quality tissue in a young patient. Do we patch that? Or do we only reserve this for old people?
In my indication, age will not be a primary factor. Poor tissue quality on arthroscopy will be the deciding factor. Just that one factor.
Okay. Sirish, my question to you is, does medical comorbidities have any role to play? If the patient smokes like the chimney, if they're diabetic, are any medical cofactors when you're seeing these patients with large cuff repairs have any upset to, in your thought process whether you're going to augment or not?
No, I think, see, finally you have to make a decision whether you are going to repair this or you are thinking of a replacement. If I think this is a suitable candidate to repair, then I'm going to do best whatever is possible.
So I will rephrase my question because I'll talk like a politician. If the patient is a diabetic, would you not use a patch because your risk of infection might be higher?
Not necessarily.
Okay.
If he's well controlled diabetic, I would go ahead.
What about the panel here or anybody else in the room? If you have a diabetic patient, would you use a synthetic graft in them or a patch in them? Are you worried about infection in these cases?
I would be a little skeptical to use in diabetic.
What about others?
Others, I think I would beg to differ because I would have because this is the enthesial healing we are talking about. So I think even in a moderately repairable cuff, not irreparable ones, I think if the patient has the financial grounds to support this procedure, I think should be done because we know that we need some biology there.
Okay.
So yeah.
Anyone else? Are you hesitant to do this in someone who's immunocompromised?
I would be a little concerned, especially if you're adding biology, because synthetics and biology, if you look at the post-op MRIs, typically at around the 3 to 4 month time period, there is an enhanced inflammatory response. And I've spoken to a few people where they have actually had to go in and remove a particular patch purely because the it's not a controlled response. I can't promise that this is X amount of inflammation which is going to come up, which might be manifold in someone else. So I don't want to use this as a random one-stop mechanism for everyone. I would be very selective on this, and the patient needs to have that comprehension to understand what I'm doing. So coming back to your question, do I talk to my patient about being a bovine patch? Yes, every patch that I've used, that patient has had adequate literature to read, and we take special consent on that.
Okay. So far we are thinking is that we're basically going to use, so now one of the clear things to understand here, we are using a patch as an augmentation device. This is something you're going to put on top of the cuff. How many people would put this on the bottom of the cuff? Because Mihata and our group in Brisbane has published data now. We call it the cracker repair. I don't do it, my partner does it. But he puts the patch underneath and then puts the cuff on top. And Tiru's been doing that now. So does anyone do that, or does everyone just put the patch on top?
I think it may not be appropriate for the synthetic cuff because of the fibrous action. So for those, I use the biceps, and I put my biceps underneath. So I don't put it on top. I don't do the smash. I do the reverse technique. I'm due to publish that. So on the topics of the diabetic patients, I think there are slightly different indications. So the synthetic patch is a mechanical augment. So for the diabetic patients, they're poor biologists. They need healings. So in such circumstances, if the tendons quality are good enough for me to repair it down, I think there's a place for Regenetem. So for me, in my practice in London, I'm slightly spoiled. I've used every single graft that you have mentioned it today, and there was slightly different preference for religious reason, for patients' beliefs. So I give them the options and say, you choose what you want, what you're happy to pay for. If you can't pay for it, I'll use your biceps.
Sure. So I would like to summarize this because we're going to wrap this up. Basically, what we are saying is we need some kind of biology. There's a lot of work which I'm personally doing on the enthesis, looking at stem cells and how we can get enthesis from the bone to help biology. But basically, we're going to use an augmentation device in someone who might be immunocompromised or diabetic. You could probably use the biceps for that because you're not compromising on a synthetic patch there. You want to use a patch on someone who's got a very large rotator cuff tear where you're not worried that your repair is as good enough, and then Ayapan can show you how to do the slide for that. Or thirdly, we're trying to say in revision rotator cuff repairs, where the primary repair has failed and the tendon quality is not very good, probably that would be a very good indication or maybe an indication to do this. And from what Nilesh is saying is, and my personal experience with this has been, they're not innocuous devices, okay? They cause allergic reactions, they cause an infection. I've probably taken out more patches because they were infected cuff repairs because of patches than not. So please be careful and mindful about the surgical technique. The videos which were shown by everybody today, they were using cannulas to push the patches in. There was fluid which was running. So there's a lot of techniques which need to be employed to make sure that the patch doesn't get infected when you're doing it. So I think we're out of time now. We'll stop at that unless there's burning questions from
Ashish,
somebody.
just one comment.
Yes, Dr. Desa.
Yeah. Just what paper Shirish quoted of Amit Modi, the audience needs to know that that was for SCR. The graph jacket, more than 10 years study, is for SCR. It is not.
It is augmentation. No, so it is not augmentation. It is not a SCR. It is a bridge graft.
It is interposition. It is interposition.
So that is the only graft which has been used as a bridge graft so far. It's a bridge graft. No. It is a then to the thing. So this is the only patch which has been used like that.
It is being so. They've got two studies, or more than one study. One study is an augmentation device, and subsequently is an integration device.
No, I worked in the unit, sir. I did the cases. So no, you're absolutely right. It is not an augmentation device. It is a bridging device.
It's where there is a hole which can't be repaired.
Correct. So you're just giving an extension to your tendon, like you're doing for a lower trap.
Which is totally different from the patch.
Correct.
Can I ask a small question?
Only if it's small.
Yeah, definitely.
Go for it.
So question is definitely small. So we have a very nice panelist and we are discussing the patches, which patch to apply. So the application of a patch is a preoperative decision for you based on the radiology, like Gottlieb 3, 4 or Thomaso more than less than 50% area coverage like that, or it is, as some of you said, that it's an intraoperative assessment of a tendon quality. And if it is yes, intraoperative assessment, how do you assess that this tendon is good or bad?
I said intraoperative, so I will talk about that first. See, I am a very skeptical person and I don't join the bandwagon very fast. I've been doing cuff for 18 years, he's been doing for 25 years. Sir who left and Kapil sir and Nandan sir have been doing it for 35 years. And we had reasonably good results. 30 years, sir? 25 years? So Subra sir, 35
This is
years.
a trap.
So,
This is a trap.
No, the thing is, we have been having reasonably good results with our rotator cuff repairs without the patches for donkey years. And there was a small amount of cuffs which failed. I think these are the indications for the patch. So, and you know it on table that your tension is a little high, you're stretching it a little more.
What specifically do you see about the tendon quality? Like if your tendon is
thickness of the tendon is a primary factor.
Okay.
The amount of fraying that is there. The strength of the tendon, how the suture holds to it is a factor. So, and these are the indications for me. You know, these cuffs are going to be, you know, you're not going to mobilize them very quickly. You're a little scared of your repair. These are the cases. And for a well done repair, I think I will not just augment with a patch, although the patient is affordable. because the quality of tendon is good, it is an acute injury, he's doing well. So those chronic cases where I have a little bit of difficulty, these are my indications.
Okay.
This is not science, and I don't mean to throw
No, fair
science
enough.
at you.
So your
Okay,
decision
we're gonna
is
close.
Okay.
Top.
Yeah.
That was not a small. We had 4 questions now, so you're gonna penalize for the rest of the
Thank
week.
you so much.
Thank you, everybody.
Thank you, panel. Thank you, Ashish.
I think the hall has really gone live now. Thank you, Ashish sir, for this. Now we are going to talk about the striker balloon. And this is by Dr. Sendil Velan, sir. Welcome, sir.
So, thank you very much, Dr. Ayyappan. After the discussion on patches, I think we'll move on to another spacer. So, when we have a patient, where the patient has a massive tear, this is one another option where you can actually now, which is advocated in the subacromial space. So let's look at why do we need an additional solution, because we know that there are so many options, right from deltoid rehabilitation to all the patches. So basically it's an interposition balloon spacer. So this is somewhere in the middle. So, but the criteria is that obviously when you have arthritis, it has got no role because you straight away go with the reverse. But it is a minimally invasive procedure, and it's been shown that the physical rehabilitation is quicker. And the essentials essentially is that you need to have an intact subscapularis and a teres minor, and you need to have a functional deltoid muscle. And basically, because we know from the biomechanics that you need to have a force that is actually acting to keep the, when you have the supra and the infraspinatus is gone, you need to keep the head down, just like a spacer. So to keep the deltoid in function so that the head can be still positioned. So this is the company's video. So I think it's all available, but I'll just go through quickly. Basically, the steps are very simple, where you would actually do the standard subacromial scopy, but the only difference is that you will actually measure the size of the defect. And once you actually measure the size of the defect, you can actually deploy the balloon, and then you actually make a decision, once you're intraoperatively, whether you would want to use two different sizes of balloon are available. And then you actually inject saline, and then you actually turn the knob around, and then you take it off. And the procedure takes hardly about 2 to 3 minutes. So this is one of our cases where you can see that once the procedure is done, you actually measure, and then you actually have the balloon in position. You would actually preoperatively measure, but sometimes you may have to create some space beforehand so that you can actually create a subacromial decompression prior to actually inserting the balloon. And once you actually insert the balloon, you keep it in position, and then you actually insert the saline so that it actually goes up, and then it fills the subacromial spacer, and you turn the knob, it actually has a self closing valve, and then you take it out. So this is I'll probably run. Yeah. So this is a patient who had a massive tear. In fact, in this patient we had actually a combined, where he actually had a biceps SCR, and also at the end we had to supplement it with a subacromial balloon spacer. One second. I guess, yeah. So this is we measure the size of the defect. And then you insert the appropriate size inserter, and then you inject normal saline. Usually you inject subsequently a little bit more, and then you would actually can withdraw slightly so that it is adequately sized, and then it just gets in position. Sometimes you can actually check with using radiology as well, but most often it's not necessary. So we have very limited experience. We've done only 4 cases, and there are enough studies in the literature both supporting and as well as studies which are actually showing that is equally efficacious as that of a partial repair. Recently, there's been again meta-analysis is showing that the 2 years follow-up. And also now there's a very recent paper at 2024 which is showing that there's been like good improvements, but still we have to look at it with skepticism, because most of these patients have had a partial repair as well. Whether the partial repair is what is contributing or the balloon itself is contributing is still a big question that we have to have in hand. And again, there is a cost involved in all of these procedures. Mainly what we see as an advantage is that there's a quickness of the procedure in significantly problematic, anesthetically problematic patient. I think this would probably be an advantage because it's very quick to deploy, and probably it would actually act as a spacer and would help in the functioning of the deltoid. That's where I see it as an indication. Thank you.
Any questions?
As we are doing this in a high anesthesis risk patient, any thought of doing it ultrasound guided, even without doing, because we are measuring the from glenoid to lateral tuberosity that we can measure in X-ray also, and just that amount of thing going in USG guided. Any thought on that?
I think probably the interventional radiologists, once they see the balloon, they'll probably pick it up more quickly than us. I think, I definitely see that can be very much deployed under local anesthesia, under a block. Probably that's where probably most of the indications, at least in India, would be, I think so.
Senthil, what is the clinical prerequisites to if you want to do a balloon? What is the actual indication, the prerequisite to do it, and where you should not do it? Can you tell us that?
So you should not definitely do it when you do not have an intact subscapularis. If you don't have the transverse couple, the deltoid is not going to function. Basically, it's functioning in the spacer so that the deltoid can be rehabbed, and that's where actually it's going to help. So if you do not have a subscap, you should, because there has been reports where the balloon has migrated. So, and you should not do it. And also when there is arthritis, there's no indication for this. I mean, if there is arthritis, the patient is still going to have pain. So there's no indication. Only when you have a massive tear where patient is probably moribund, you want to have a quick procedure, my indication would be that. But obviously in the literature, the expanded indications are to actually use it as a support in addition to a partial repair. Where you have a massive tear, they say you don't even need to repair it, only do a partial repair and still deploy a balloon. So there are results, but still, the skepticism is there because most of these repairs have included a partial repair. So we know that partial repair itself, a lot of patients do get better. So I think we should look at it with a bit of skepticism. So you can combine them, but obviously cost is involved. Two, the rehabilitation is definitely quicker because the patients are now having an additional support mechanism to help in the rehab.
How do you check the migration is happening or not?
The migration, you can actually, at least in the initial period, you can actually use an X-ray immediately, but you can use an ultrasound to check. Usually if you have an intact subscap, usually it doesn't migrate, all across to the front of the shoulder. But there's been reports when you actually have a superior third subscap tear where it has actually migrated from the subacromial space to the anterior aspect of the shoulder. And there's been instances where actually they've burst it when somebody doesn't know, and they do an injection post-op.
Why don't you fix it then?
Senthil, that's what I want to ask you. Spontaneous rupture. What are the chances of spontaneous rupture? And do you have to? Doing a subacromial decompression, is it a prerequisite like a spur or something like that?
It's not a prerequisite. It's not been described.
Subacromial spur.
Yeah, but it is not a prerequisite to deploy the balloon because you can actually inflate it as much as you want. You don't need to hyperinflate it. But you would want some space, so I routinely do a bony decompression to get that space. Yes, sir. And post-operatively, the patient should be counseled because they can't have any injections post-op.
Okay.
How long does the balloon stay?
It is actually a biodegradable balloon. It's 1.5 years is what the company claims, to less than 2 years, and it spontaneously degrades. Then how does it act? How does the patients have 4 years good results? So I think the answer is actually obviously the patient's deltoid is actually rehabilitated in that point.
Himanshu wants to ask a question.
So, does this reverses the pseudo paralysis with the proper rehab sessions alone? Just balloon inside?
I think with the it's the pain relief and the functional outcomes are better. The strength does not become better. I mean, I don't think I can answer that question with my experience, but from the literature you can see that their pain relief is better, and also their movements are better, but the strength, no.
I think it's better for a compensated shoulder, which is irreparable and with pain.
Yeah, it's a decompensated shoulder where you want to rehabilitate the deltoid, and this should be an addendum procedure rather than as a primary procedure.
Pseudoparalysis is a contraindication to operate on the balloon. Pseudoparalysis should not be done.
In fact, you need to have 90 degrees of shoulder movement.
Exactly. And if you, after a subacromial shot, patient should have a significant improvement. For example, 20 to 30 degrees forward elevation should be there. That is the ideal indication to operate.
Okay. I told only one more question. Two questions are allowed, right? Yeah. So since he's a cutlery master, I am really scared.
Ayyapan, just one more question.
Okay.
Yeah. This decompensated to compensate. Will it happen only because of this ballooning?
I don't think that you can actually just put in a balloon and expect the patient to actually get spontaneously better, sir. The deltoid needs to be rehabilitated. It definitely reduces the pain levels because it actually, reduces the deltoid fatigue, and the partial repair, I think, is what is actually helping in actually getting, in addition to the balloon, because it kind of helps in the rehabilitation in addition to your partial repair.
I'll just sum up all the talk that we had. So balloon only brings down the center of rotation of the shoulder joint. Because of proximal migration, center of rotation goes up in massive cuff tears. The balloon brings it down against that center of rotation. Then deltoid starts acting again. So that is what we do in rotator cuff repairs also, and that is what balloon is doing. But since 3 years back, Lancet study came out that told us that after 2 years, there's no difference between no repair or a balloon. And that is probably the reason, because it is biodegradable and it goes away after 1.5 or 2 years, and it is only a temporary measure, and it does not provide any specific power. And as you said, deltoid rehabilitation is very important.
And I think there's more studies which has come up after the Lancet study. There's always this conflict between pro and against. Yes.
Thank you so much. Senthil, great talk.
Thank you.
Yeah. Thank you.
Yeah. Next, I call upon just a minute. Next set of moderators, Dr. Hemant Reddy sir, Dr. Deepthi Nandan sir, Dr. Sanjay Desai sir, and Dr. Subramanian sir. So the speaker for this next session is, we are starting the reverse shoulder session now. It's going to be on mechanics by Dr. Soumyadeep Datta sir. Please come.
Coffee has been outside the hall. Whoever wants coffee can catch one.
So thanks to my dear friend Appan and the chairperson for giving me this opportunity. So don't be afraid, I am not a biomechanic expert. So I am an orthopedic surgeon. So for the next 5 minutes, I will try to keep it simple, how the reverse shoulder function in us. So in a normal shoulder joint, our rotator cuff and a deltoid act synergically to keep our glenoid humeral head over the glenoid. So this is called concentric compression. What happened when the cuff tear happen? The whole thing's superior support goes away, and the humeral head goes up, and the arthritis process starts. So the main thing we are concentrating on is center of rotation. On the left hand side, this is the center of rotation on a normal shoulder. When it's a cuff is torn, it just goes up, and in reverse shoulder, the center of rotation is changed compared to our natural shoulder. It is much more medialized and slightly inferiorized, and that gives whole biomechanical advantage and the function of the shoulder. Though classically the modern shoulder prosthesis has been developed with the reverse shoulder by Grommet in 1985. The initial was two-part, then further modified. The whole principle still date is on his principle of medializing the center of rotation. So what it does, central medialization of the central of rotation does increases lever arm of the deltoid. So the more and more deltoid muscles are recruited, and it facilitates deltoids to work and lift the shoulder up. So if you compare the anatomical shoulder with the reverse shoulder, more and more deltoid muscles has been recruited, and it not only helps in elevation but also the internal rotation and external rotation also. So not only it is medialized, it is also lowered compared to our natural shoulder. What the lowering of the center of rotation does, see the normal shoulder, the vector force acting like obliquely, but it is in a reverse shoulder, it is acting on the line of the deltoid muscle fiber. So giving a more force to occur. So center of rotation, distalize and medialize given also inherent stability to the reverse shoulder. So if you consider the three biomechanical advantage these have giving, first is glenosphere acts as a mechanical stop to convert deltoid force into a rotation, fixed biomechanical fulcrum for better deltoid function, and increased abductor momentum to improve deltoid efficiency. But every advantage on the flip side comes with some disadvantage. What are the disadvantage of these biomechanical changes? It shorten rotator cuffs, whichever it is there, limits some kind of internal and external rotation, elongates deltoid, so leading to some kind of acromial or scapular stress fracture. These are very dreaded complication, and it alters the scapulohumeral rhythm. So nowadays prosthesis, we are aiming at a larger glenosphere with a semi-constant design compared to the previous one. So this is the scapular notching, which is very important complication. So it is graded and differentiated. So to decrease scapular notching, the device has to be flushed with the inferior rim. Slightly inferior overhang can be permitted, and not only too much medialization is not permitted, slight lateralization also helps, and larger glenosphere is increased. Previous design had a neck shaft angle of around 155 degree. It has reduced to nowadays called 125 to 130 degrees acceptable. So some lateralization compared to the Grommet's conventional process is acceptable. It increases deltoid tension. It has residual tensioning of the cuff, and it improves external rotation of the shoulder. So if you, on a nutshell, the primary biomechanical advantage of a larger deltoid abductor momentum, which improves the deltoid efficiency, and it medializes the center of rotation. Thank you for your kind attention.
Any burning question, or we go to the next speaker? Thank you so much. Thank you.
Next, I invite upon stage Dr. Prince Shanawaz Khan. He'll be talking about the lateral approach to RSA, deltopectoral size. Deltopectoral. Yeah.
So I'll be talking about a deltopectoral, and Dr. Harish will be talking about a lateral approach. So as we know, the deltopectoral is the workhorse approach for all anterior shoulder surgeries. So whether it's a trauma, it's a replacement, it's a glenoid fracture, it's an open latager, any procedure, this is a workhorse. So I also do lateral approach. The indication for doing I am not against a lateral approach. So when there is a rotator cuff arthropathy, the cuff for supra and infra is not there. When you are planning for a reverse shoulder, it is a lateral approach. Is a nice approach. So once you cut the humerus, you are directly in front of your glenoid. So that's only indication where I do a lateral approach. Otherwise, I always go for a deltopecular approach. Yeah. So the patient positioning, usually the B chair position, the back is elevated at 40 degrees to horizontal. You can use a table support, arm support, or you can use a free from table support also. And scapular support is a must. Cushion under the scapular spine improves the glenoid orientation towards the surgeon. So the Cooper et al., he identified 4 successive levae. The layer 1 is a deltopectoral interval, the 2 is the clavipectoral fascia, 3 is the subscapularis, and finally the capsular. What's happening? So let's see. So for this is a cadaveric dissection. For this, I thank Dr. Kandame. This is from his collection. So the incision starts from the coracoid to the deltoid groove. The further extension is actually like a anterolateral approach to the humerus. So once you, it's not moving. Yeah. So once you start inserting your skin, then use a cautery for the bleeders. Then once you dissect the subcutaneous tissues, then you reach the fascia which covering the deltoid. Now you should be able to identify your cephalic vein that differentiate. This is a cephalic vein. So on the lateral side you have the deltoid, and on the medial side you have the pectoralis major. So this is the one, that is cephalic vein. So you can take the cephalic vein laterally, you can retract it laterally. Once that is done, you can use a blend dissection. You can use your finger to define the interval, subdeltoid interval. So once that is done, then you can see the coracoid there, and the next step is to incise your clavipectoral fascia. You should incise so that's the pectoralis major. In some cases you can release a pectoralis major in some cases. So that is the clavipectoral fascia I am cutting just lateral to the conjoint tendon. This is the coracoid, this is the conjoint tendon. So once that is done, you can see the conjoint tendon, you can see the coracoacromial ligament here. So that is the second structure. The next structure is the subscapularis management. For that, the lighthouse is the long head of the biceps tendon. So you need to identify your long head of the biceps tendon. When you trace it proximally, you will be able to see the lesser trochanter, and you will be able to see the upper end of the subscapularis. So once that is defined, this is the rotator interval. You can open the rotator interval. You can put a hemostat inside this one. So that will differentiate between the capsule and the subscapularis. So this is between the capsule and the subscapularis. In some cases, like a open labral repair, you need to differentiate. You need to take your subscapularis and the capsule separately. But in your trauma cases, this is what is needed. You don't need to go intraarticularly, except in case of a glenoid anterior fracture. Here, in some cases like a labral repair or anterior glenoid fracture, you need to differentiate between your subscapularis and your capsule. So now I am doing the subscapularis release. You can either do a subscapularis release, or you can take with a sliver of bone. Both are acceptable in case of a shoulder replacement. So this is capsule, and this is your subscapularis. So once that is done, for your replacement purposes, you need to take out your capsule. You need to take your capsule, especially the inferior side. So once that is done, once you external rotate your shoulder, your humerus will come out. So then you can go for your humeral cut. And so this is a dissection of subscapularis and anterior capsule interval. You can repair your labrum back to the glenoid. If you are going for open repair, you can fix your glenoid anterior fractures. or you can take out your humeral head and go with your glenoid preparation. So I am not going into the theory purpose. That's it. Yeah. I think I finished in time.
Any questions regarding nice talk, Prince? Nice dissection.
Can
Any
I ask
questions?
one question?
Yeah.
Yeah, Dr. Prince, very nice talk. And I want to talk about, you said that you do a lateral approach if you don't have an infra.
No. Supra, when the supra and infra are gone, for
Yeah.
reverse shoulder, it's an easy approach. Basically, when rotator cuff is not there, it's an easy approach.
But you need an infra for external rotation. If you don't have external rotation,
You can repair your infra or you can do a latissimus transfer. I'm just
but
giving
you
an overlay.
can't do a latissimus transfer.
No, I am not going about the indication for a rotator cuff. I am just telling that if the rotator cuff is not there, the lateral approach is a better option than a delta. It's an easier approach. That's it. So Harish will talk about more.
Harish sir will be speaking about the lateral approach now.
Hi. This approach basically came in because we had some subscapularis healing issues, and that was the reason why. So it's a very good approach for the reverse shoulder, especially when you're looking at the posterior glenoid, and that's something that's, if you have a glenoid defect, it's a very good approach because your glenoid looks at you face on. So it preserves the supraspinatus, the subscapularis tendon, straight exposure of the glenoid, and whereas in a deltopectoral, like Prince said, you preserve the deltoid and the pectoralis, and it requires resection of the subscapularis. And the failure to heal, again, like what I mentioned, is a subtle dysfunction to complete rupture. And your postoperative subscapularis insufficiency can lead to pain, loss of movement, weakness, instability, and frank dislocations. So the literature reports insufficiency rates as high as 67%, and which is the most frequent indication for a revision surgery. A lot of advantages between the deltopectoral and the superolateral one. You have a direct exposure to the glenoid cavity, preserves subscapularis muscle. Your base plate positioning is in the anterior posterior direction. And of course, when you deal with deltoid, you do have some detriments for neurological or mechanical issues. Poor access to the inferior portion of the glenoid cavity. That's the one thing about the superolateral approach. And risk of scapular spine fracture is also there. So in a superolateral approach to the shoulder, you have a straight incision about 7 to 10 centimeters on the skin. You can also use a strap incision, and you take the deltoid off the anterior acromion, 3 to 4 centimeters lateral to the acromion edge, and the only thing that you need to take care is about the axial nerve, which is about 5 centimeters from the tip of the acromion. So that's where you can put your stay sutures and make sure that you don't breach that level. And following which you do an acromioplasty, and then you facilitate the exposure to the proximal humerus. And once your shoulder is externally rotated, a trapdoor is created in the endotracheal interval. And next step is the release of the long head of biceps in the subclavicular tubercle and tenodesis. And then you place your humeral processes. That's a short video, a straightforward incision there, exposing the deltoid, and then the skin incision on the deltoid, and then you're directly into the capsule and the head. And you can dislocate the head very easily. So not much of soft tissue there, except that the axillary nerve needs to be taken care of. It was an approach previously used for open rotator cuff repairs and kind of things. So once you dislocate the head and then probably cut that head, especially during the rotator cuff, in reverse shoulder, the glenoid looks at you entirely. So you can visualize and position your base plate metaglean accordingly. Well, there's lower incidence of, if you compare papers, there's lower incidence of glenoid loosening compared to the deltoid split, and of course significantly higher rates of scapular notching is present. And some studies have showed higher risk of dislocations in the DP approach, which is the deltopectoral approach, whereas a higher occurrence of scapular stress fractures also present. No significant differences were noted in the radiological outcome between the two approaches. Thank you.
Harish, just one comment, if I may. Over here. Yes. You mentioned that the superior approach was designed because of some problems with the healing of subscap.
Yes.
Am I right? That's what I heard.
Yes.
That's not, I think, entirely correct. This approach was invented or designed by McKinsey from
Correct.
Port Blair in South
Yes,
Africa.
yes.
And it was because of the difficulty in exposing the glenoid with the deltopectoral.
Yeah, absolutely, sir. If you look at that paper also, which they say that they had a lot of subscapularis healing issues also. So that was one reason, and especially, like you said, posterior glenoid, yes, very well visualized. Yeah, that's the point.
Harish, what is the explanation for increased glenoid loosening in the lateral approach?
That's exactly what I said. When you position the glenoid in a superolateral approach, you need to see the glenoid completely and make sure that
The exposure issue.
Yeah, the exposure issue. That's the reason why. Because if you cut, you need to cut that head at that level of the inferior glenoid.
So yes, Harish, definitely subscap sparing is why there is more stability when you're doing a lateral approach. But how do you decide when you see a patient preoperatively? When will you go deltopectoral?
For
When will
me,
you
a
go?
straightforward rotator cuff arthropathy, especially if there's no glenoid bone loss as such per se, and that would be my primary indication for it. Otherwise, the workhorse is the deltopectoral approach. There's no doubt
So
about
there's
it.
one very nice paper which looked at when do you decide, okay? You put traction, vertical traction. If the head is moving inferiorly, even in cuff arthropathy, then only you do it. Otherwise, you'll get stuck. The main reason for
Certainly, sir.
the glenoid loosening is because of the placement. The inferior inclination is always difficult when
Yes,
you're
yes,
doing
certainly.
a deltoid split.
I think that comment which Deepthi has just made is a very, very important comment for the audience. So, in cuff tear arthropathy, when you have a head which is gone up and sitting next to the acromion, you almost have to think of this as like a DDH in a hip. If it's stuck there for a very long time, you will not be able to bring this head down with a supralateral approach because all the inferior structures are really scarred. So you might think, oh, this is a cuff tear arthropathy, this is the one I'm going to do. You have an acromion which is eroded, you have a head which is proximal, and you'll think, okay, this is a supralateral. That is exactly the case which you should not be doing a supralateral approach. So what Deepthi mentioned is very important. If you can pull the head down, and it's a dynamic proximal head migration, it's not a static proximal head migration, then that case for a supralateral approach is an appropriate case. And it doesn't really matter whether you do supralateral or deltopectoral approach, you need to be able to own the glenoid. And if you're putting a glenoid base plate in the wrong position, it's purely a surgical error. It is nothing to do with the patient or what approach you did. So you should be able to achieve the same result with both.
Yeah, I think I think we have finished the time, but I will answer your question quickly. We are waiting for the 2 minutes actually. Regarding the external rotation, the question is that whether you need a more external rotation or internal rotation. There's a paper from Korea in 2020. What they are telling is that especially for the left side perennial care, external rotation is more less important than the internal rotation. The reason is that a patient can turn to that side and take the things. But internal rotation, especially for the perennial care, it is more important. And when you do a reverse shoulder, when you abduct your arm, you get a supraphysiological external rotation. Even without having an infraspinatus also, you get a supraphysiological external rotation. Okay, so even if the infraspinatus is not there also, you can do a reverse shoulder, it will work. It should work.
Just I want to more of a comment and a little bit of a discussion. When we started doing reverses, we used to probably have the discussion about the approaches, about the exposure. Now that we know that even with the deltopectoral with slight modification, you can get a perfect glenoid exposure. Now the whole problem with the deltoid split approach is you're going through the same structure, which is the most important structure for the reverse to function. And any intraoperative nuances cannot be addressed. Any, you want to repair the subscap, you're getting more and more anatomical with your reverses. So in today's day and age, is there a clear-cut indication for anybody that only a deltoid split is ideal for this?
No, there's a paper actually the comparing axillary palsy with a lateral approach and a deltopectoral approach. They told like there is no difference between these two regarding the axillary palsy.
See, let's have a hands-on. How many of you do deltoid splitting approach? Routinely for all the cases of?
No.
Routine.
Not routine.
I was just going to make deltoid splitting I'm asking, not deltopectoral. Deltoid splitting.
Nobody is doing routinely.
Yourself, huh?
So I looked at my results of 100 patients each on each end, and I was biased in the ones I wanted to do deltoid split, which are straightforward cuff tear cases, which I didn't want to repair the cuff because they were older. compared to deltopectoral approach, and we blinded our results in terms of the people didn't know what incision was made, and we just looked at the outcome. There was no difference in outcome. There was no difference in my hands axillary nerve palsy, but I'm a subspecialist shoulder surgeon. I'm not a general orthopedic surgeon. The deltoid split approach was the way Grammont designed a reverse to be done. In France, in Europe, a lot of people still do a deltoid split approach. So I do think once you, for me, I prefer to do a deltoid split in some patients if they've had, because for me, when I go back and do a revision, if I have to do a revision, it's virgin anatomy in front of the shoulder, and that is a big plus for me as a revision surgeon. But my general take to people would be, don't do a deltoid split approach till you've mastered the reverse with the deltopectoral. Do that first, understand your balancing there, and then you might find an indication for deltoid split. Don't do it the other way.
I think Ashish, you've made a very valid point there. And when I started doing reverses, I used to do the deltoid split because having been trained by Steve Copeland, who did all the arthroplasty through deltoid split, you felt it was easier. You got a beautiful view of the glenoid, but it's the high riding shoulders which you struggle to get down, and then you're compromising with the position. But probably a slightly contrarian view on the revisions. If you're doing a lot of revisions, then you like to do one approach for everything, and that is why I stopped doing the deltoid split and went to deltopectoral for all the reverses. And I think you're right. It is a question of getting that good exposure, whichever approach you use. But I think for the occasional reverse arthroplasty surgeon, probably the better approach is to use a deltopectoral rather than doing a deltoid split.
I think as a shoulder surgeon, for those who are dedicated shoulder arthroplasty surgeons, you need to learn how to do a deltoid split. You might have a bleed intraoperatively, you might have a problem intraoperatively, you need to get to the back of the glenoid. It is something which you have to learn. It's like saying I'm a hip surgeon, I don't do the anterior hip approach. But it's for the vast majority of people who are learning how to do a reverse, stick to DP.
Wow, that was a great insight about a simple topic. So next, we now that we've exposed the joint, we'll be talking about the glenoid base plate. Dr. Shirish Pathak sir will be joining online. Please go ahead, sir.
Design. So first of all, we need to understand how do we classify them. So it's a Rautmann classification. So medialized glenoid, even if center of rotation is up to 5 millimeter from the glenoid face, it is still called medialized glenoid. Same applies for lateralized humerus. If humerus offset is more than 15 millimeter, then it is called lateralized humerus. So we know there are two schools of thoughts: medialized Grammont design and lateralized by Mark Frankel. I think it's an oxymoron to say anatomical reverse shoulder. But we need to understand there is only one headmaster of arthroplasty in shoulder, is Paul Grammont. All reverse designs are based on his principles of medialization of center of rotation as compared to normal shoulder anatomy. So-called lateralized glenoids are also medialized with relation to the center of rotation of normal shoulder anatomy. Grammont design has worked really well, shown excellent survival, 20 plus years, but there were certain issues: scapular notching, poor rotations, and altered shoulder contour, which was really minimized and modified by lateralizing humerus without touching much on the medialized glenoid. So neck shaft angle was reduced to 135 or 145, and design from inlay was changed to onlay. So you can see how it was lateralized and we got a good contour. So what are advantages of lateralized humerus with medialized glenoid? We have less scapular notching, less than 15%. We have optimum tensioning of cuff muscles which are intact to give better external rotation. It also gives posterior deltoid a good lever arm so that it is better external rotation even in absence of external rotator cuff muscle, and it shifts humerus anatomy laterally, giving a better shoulder contour. In my practice, my patient profile is elderly, 65 plus, typically females, osteoporotic, small or medium size, a typical Indian female. And 90% of time, I end up using standard glenosphere, which is 36. And that too, sometimes I find it difficult to reduce. And I'm satisfied in the last 15 years, and my patients are also happy. We understand the concept of reverse are evolving. Lateralization is must. and we understand the concept of global lateralization, but that lateralization has to be done on glenoid side or humeral side is debatable. We play between 15 to 30 millimeter of range. If you cross 30, then there are a lot of issues. I know my opponent Purva likes lateralized glenoids, but my job is to make him aware of the risk involved with the same. Remember, this design needs one. It failed because it tried to recreate the normal anatomy with reverse design. So don't make same mistake again. There are a lot of negative effects of too much lateralized glenoid. It reduces the lever arm of deltoid by lateralizing center of rotation. So deltoid fatigue is a big risk. With lateralized glenoid, there are a lot of shear forces which are developing at glenoid and base plate junction, leading to increased micromotion and less of bone ingrowth. And if you see the literature, the risk of loosening is almost 8.8% compared to 1.8% with the medialized glenoid. And to fix this, to reduce this loosening, you need bigger, longer, and more number of screws, which will eventually pose a lot of challenge when you are revising your glenoid base plates. Of course, with lateralized glenoid, you have increased risk of scapular spine and acromial stress fracture. With 10 millimeter of lateralization of glenoid, there is 17% stress increase at scapular spine, which is hardly 2% with lateralized humerus. And if you use a lateralized glenoid, then you have to use inlay designs, 135 or 145. More metaphyseal bone loss due to reaming, glenoid exposure can be difficult because of less proximal humeral cut, and reductions at times are very difficult. So I know my opponent will keep harping on only one point, that it gives better lateral external rotation. But remember, gaining better external rotation is multifactorial. It is not only design, it is soft tissue integrity, subscap repair, deltoid, component version, soft tissue tension, preoperative range of movement, and also age and activity level. So to conclude, for me, medialized glenoid and lateralized humerus is the gold standard. I'm open to newer advancements if they really benefit my patient. Case-based lateralization is a good option than being the fixed rule. Thank you.
Dr. Purnachandra's flight got delayed, so his talk will be later on. I would like Dr. Ashish to contribute to this debate by saying a few words, and then we can go on to the next talk.
You just put me on the spot. I could talk for lateralization for a whole week. I think what Sirish has just said is very, very true. Everybody thinks we should lateralize. I personally think lateralization is bad. I think lateralization is something, and what is lateralization? A lateralization for an Indian patient will be very different from a lateralization for a Scandinavian patient. So we really don't know what is the right amount of lateralization. And where are we lateralizing? Are we lateralizing in the glenoid or are we lateralizing in the humerus? Is it combined lateralization? And then in some patients, Nilesh just showed me a case, they have an acromial stress fracture already. Do you want to lateralize this patient? So I think one of the important things which we will go through as the day goes through is, please take this misconception from your head that every reverse needs to be lateralized. Most of the reverses available in India right now will lateralize because your patients are smaller, your base plates are augmented, then your Morse tapers are 4 to 6 mils, and just exactly as what Sirish was saying, even the 36 clinosphere is too big. So even if you think you're not lateralizing, you are actually lateralizing that joint anyway. But just be careful from implant to implant because one rule doesn't fit all. Whatever implant you're using lateralizes differently as well. And I think there's a big role to play in terms of how your cuff needs to be managed for this. So I agree with you that the maintaining the joint line for the glenoid and looking at medializing the humerus a little bit so that you're not putting a lot of stress so that you can repair the cuff is the way forward. So I can't debate him on that.
Sanjay Desi sir, what is your thoughts on this? And okay, Subramanian sir, you want to contribute? Deepti sir, Hemant sir, kindly contribute because Purna is not there.
I
So we'd
think
like to have a
what
nice.
Ashish is saying is
Yes.
exactly correct because
Yes.
all of the designs that are available in India right now has got slight lateralization, including the diameter of the sphere is not half sphere; it's more than a half sphere, which itself lateralizes to some extent. So that is a current developed design is like that in only in India, which gives a mechanical advantage.
I will incorporate my half a minute in my talk.
Deepti sir, would you like to contribute on this?
It has to be. I think it has to be patient specific. I think one that's more important. If you're doing a lateralized glenoid, I think inlay stems are better. But if you're doing a lateralized glenoid and a lateralized or an onlay system, you are going to overstuff the joint a bit more. So getting your joint line more towards the anatomical side is better.
How do you manage this in your patient? On how do you plan it out when you're doing in a case? So do you have, how do you think about it through the case?
So in the case, you are first doing your glenoid anyway. You do your humeral cut as normal, as the 135 itself, but you can build up on the trace on the humeral side if you want to change that angle on the humerus itself. But on the glenoid side, you don't use the augmented base plates as much. If you are finding it too much of a tension, you can change that.
Sure. Thank you so much.
Which anesthesia do you prefer when you are doing this type of surgeries? A block or only a GA? Does it make any difference?
So there's a lot of people in Europe who do it under sedation and a block. But for me, a patient needs to have a GA and be completely paralyzed. For me, in my hands, a reverse shoulder replacement is a soft tissue balancing operation. And if I have a moving target where the muscles are contracted, I can't balance the soft
Then
tissue.
how do you get the tension right if you are
So I get my tension based on the patient's completely paralyzed.
patient is paralyzed with the anesthesia or with the block? Deltoid paralysis or only the
No.
pain relief?
I don't like any moving targets.
No.
If I could paralyze the anesthetist too, I would paralyze the anesthetist.
I think you are saying GA with block, isn't it?
GA with interscaling catheter. Yeah,
Yeah.
GA with block.
In my practice in London, I try to do a wake block if I can. So most of them, the aim is to get a good blockage and the same anesthetist all the time. You know that you get the same full block. It's not always possible, but 99% of the time, there will be a good block will be totally paralyzed. But I can my anesthetist was so good that I can paralyze just the C5, 6, 7. They're still using the fingers at the end of operations. We have videos that we present in publication or in meetings, but at the end of a shoulder replacement, they can write with their hand.
Right, sir. I think we're running out of time now. We'll go to the next talk. Sorry to cut you there, sir. Next is the talk on inferiorization and tilt by Dr. Nitesh Gahlot. Please.
Okay, good evening everyone. We have very insightful talks on medialization and lateralization. Now come to the second aspect of the glenoid placement, the inferior tilt and the inferiorizations, why they are important and what you should do and what is the extent to you inferiorization and the tilt can you afford. So why tilt was we started doing inferior tilt in the glenoid because it compensates for the native glenoid superior tilt, that is about 5 degrees. A lot of time you will have superior erosion of the glenoid, so you want to compensate that. And secondly, it increases deltoid efficiency by increasing the length of the arm. But the problem that started happening with that, people started increasing the glenoid tilt to 10 or more than 10 degrees. It started causing scapular notching inferiorly. So in the later study that found out that you have a 10 degree inferior tilt and it was compared to 0 degree neutral positioning, it was the same outcome. The range of motion did not change, but when you increase it more than 10 degree, it reduces the exonotation. It reduces the adduction, the impingement-free range of motion of the adduction, and you are removing the 3.2 millimeter of scapular neck length, which is very important for your inferior most screw. So these are the problems that happens when you do too much of the inferior tilt. If you are less than 10 degree or about 10 degree, then you are fine. But if you are ranging about 10 to 15 degree, then you start going into the problems of biomechanics. It increases the micromotion and the shear stress later on, and that can lead to loosening risk. So what are the inferior tilt? Now there are two types that have been described recently by the Korean authors. So what we do in inferior tilting, we over-ream the inferior part. That is the scapular neck that we are reaming. So what happens is that the medialization of the center rotation happens and eventually scapular notching happens. This is what we call as a clinical inferior tilt. Now, This happens that it medializes the center of rotation, but then there is a pure inferior tilt that has come into play. This is the glenoid base plate has inbuilt inferior tilt. You don't need to ream the glenoid inferiorly. So this gives you a pure inferior tilt. The advantage of this is that the center of rotation remains the same. So now, does it make any difference? Because this is just the implant modification that has recently come up. So they studied on cadavers. So they found that the pure inferior tilt of 10 degree made no difference whether you do it or put it a normal way. So it was the same. Whether you are doing an augmented plate, then it's the same way. But then if you are using an augmented base plate, which is inferior tilted, then you are saving the scapular neck. That is the advantage it gives. So whether we need inferior tilt at all, whether we can put the glenoid in the normal position or whether we need it. So this is a cadaverous study published in JSCS. 20 patients, they used different types of simulations, different types of implant configurations of glenoid base plate on them. They found that when inferior tilt was associated with decreased exonotation, decreased adduction, and additional scapular neck length loss, and impingement-free exonotation and adduction was associated with lateralization, increase the range of motion by lateralization, larger glenosphere size that we already know. Neck shaft angle has to be appropriate. Postoperative scapular neck length has to be good. If you reduce the scapular neck length by over-reaming, then you have a problem. Then tilt, inclination, and the RSA angle. So in every simulation, they found that inferior tilt led to more impingement on the scapular neck. So what now? Then comes the inferior translation. That is your saving, that will save you from that. So instead of doing an inferior tilt, if you do an inferior translation, that means you put an eccentric glenoid. Your glenosphere is down a bit. That helps in your, that is basically glenosphere is overhang inferiorly. That helps you in improving the external internotation theoretically. This is all biomechanics I am talking about. It reduces the scapular notching because you have to keep your overhang less than 4 millimeter, not overdo it. Then in a 5-year study, they found that notching was around 14% as compared to the people who had 30% in the flush group where no inferior overhang was done. It improves the range of motion, it significantly improves the flexion and adduction, and internal exonotation increases by 15% if you have a 4 millimeter offset inferiorly. But excess should be avoided. Now there are two types, whether it should be flush or overhang. Now, is there any difference in patient satisfaction? Because this is all biomechanics. Yes, the answer is yes. Definitely there are improved scores at long-term follow-up and you have a better function. So you should do inferior translation. This is eccentric glenoid that we have already talked about. You have to keep it down around 4 millimeter and it clinically restores the arm length and then the function of the deltoid is restored. But what type of inferior translation? Now there are two types. One is you shift the base plate down and put the screws inferiorly. Secondly, you use the eccentric glenosphere, your base plate at the same place. What should be used? We know that the central peg and the screws should be at the correct position with a good hold in the inferior and the superior and the anterior posterior. So the glenoid base plate has to be at the exact same position where you get the maximum hold of all the screws. You put an eccentric glenosphere which puts the center of rotation down 4 millimeters. That is what the inferior overhang, and that will give you the best results. Like in this case, inferior tilt and inferior eccentric glenosphere. That gives you a good function, both external rotation, forward flexion, and complete abduction. Now all these movements are to be done if you have followed and remain within that guidelines of millimeters inside. Don't overdo anything. So my last would be keep around 4 millimeters of inferior offset, not more than 10 degree of inferior tilt. These are the best option. Do not overdo it. And in Asian patients who have smaller glenoid, it is very important to be in a strict guideline of these numbers. Thank you.
Any questions on this? Nice talk, Nitesh.
One question, intraoperatively, how do you judge your angle? Because now your patient, how do you position your patient?
It is morely the eyeballing because I don't have the software as of now.
Okay.
And
no,
we have
the
the
software
zig.
is there, you cannot change what you do in theater. So your software can tell you anything, but what you do in theater cannot be always replicated from this thing because it will only give you entry point. It will not give you anything else. the software?
So we can use an offset zig for that, which has a small offset. You can put an offset guide wire and then ream on that, which has an inbuilt 10-degree tilt if you want to do it. Definitely doing that, we have to assess preoperatively if we have any glenoid defect or not. So preoperative assessment is definitely my first thing to do on a CT scan preoperative, where my ideal position of the entry point of the guide wire will be, and then I try to position it intraoperatively.
No, intraoperative, do you use an image intensifier or anything like that?
Yes, definitely. Yes.
And
AP view.
how do you look for the tilt? How do you judge that on an X-ray?
So I use my reference as the RSA angle, the reverse shoulder arthroplasty angle. That is the base of the supraspinatus fossa. I use that and try to be perpendicular to that.
Even if you look at the base of the supraspinatus fossa, that changes with the way your angle is of your X-ray is. So that it comes back to the same point. How do you position your patient? Because that dictates what happens to the positioning of the
Yeah, I agree. I agree with your point. So I put a bolster just behind the spine, not behind the scapula. So my scapula is not too much anteverted. It's more or less in the horizontal plane. Then I position my C-arm slightly oblique so to get a true AP view. If it is not a true AP view, I cannot get an exact angle. So that I have to see intraoperatively.
Thank you.
Thank you.
Thank you, moderators. Now, Dr. Sanjay Desai, sir, will be speaking about the base plate. Please, sir. The next set of moderators are Dr. Jagdish, sir, Dr. Yashwant, sir, Dr. Yogesh, sir, Dr. Mohan Kumar, sir. Please.
Ayappan, thank you for the invite. And in the next 5 minutes, I'm going to filter the literature through my experience on what is an ideal reverse shoulder arthroplasty as we speak in 2025. So we know this. I'm going to skip because he has given me only 5 minutes. We know what the problem with the original Grimoire design and where the world is moving. This is my own notching about 15 years post-op. The screw is still intact, but it's about to break. Patient is asymptomatic. So we know that the glenoid is the key. And we also know that the world is moving towards an anatomic reverse shoulder arthroplasty. So the flow of my talk is that each step, what is ideal, why should we do that, and what is the proof. So the base plate superior inclination is to be avoided. We all agree, there is consensus. Who says that? It's proved by Lever 2014. Up to 10 degrees of glenoid retroversion is acceptable. Beaulieu 2017. A posteriorly positioned base plate might reduce subcoracoid impingement. Francesco 2023. A glenosphere overhang, as already mentioned, about 3 to 4 mm is desirable. It does reduce the incidence of scapular notching. Proof, Francesco 2023. So the desired backside sitting of the base plate, if it is with a central post, then you need minimum 75% of backside seating. And if you are using a central screw, then up to 50% is acceptable, though you might want more. Martin, Journal of Shoulder and Elbow, 2017. So which one should you choose? Should I use a central screw or should I use a post? The initial fixation is higher with a central screw, but in the long term, both are more or less similar. Should I use unicortical screw or bicortical screw? Bicortical fixation does increase stability of the base plate. Torkan, 2022. How many screws should I use in the base plate? 2, 3 or 4? So if you are going to lateralize, then 4 screws is desirable. If you are doing a typical Grimoire, then you may escape with just 2 screws. Should I use a compression screw or should I use a locking screw? How many? So there is evidence that you must use at least 2 locking screws because it prevents micromotion even with a 10 mm of lateralization, as much as 10 mm of lateralization, 2017 for Miani. Screw length, the lower one, the inferior screw should be as long as possible, and the superior screw I would limit to about 24 or 25, otherwise you run a risk of hitting the nerve. So now we know that what is the placement exact, how many screws, compression screw, posts, etc. How do you achieve this recommendations, as Ayappan was, one of the moderator was saying, that how do you achieve this intra-op? So I use the Arthrex VIP system. It allows me to decide the size, type, placement, and the beauty is it has a reusable targeter. So once the planning is done on the CT, the company tells me that these are the measurements of the targeter, and if I use this targeter, I'll be able to achieve what has been planned preoperatively. And what is the planning? I want up to 10 degrees of retroversion is acceptable. 80% backside sitting is what I aim for. A posterior replaced base plate, bicortical fixation, and I prefer to do somewhere between 2 to 8 mm of lateralization on the glenoid side. So here's an example, a 68-year-old lady, typical cuff deficient arthropathy. She had a native version of -7 acceptable inclination, and I want to correct it to 7, inclination 0. And with the targeter, I can achieve these with a 99% of backside sitting, and these are the screw measurements. These are the pre-op, before and after cutting the glenoid, how it will look. This is where I see that the center of rotation is less medialized. You can see that black spot and the another black spot with the yellow surrounding. So how much I am lateralizing, that I know, and ultimately that is the result. If you look at this study, if you eyeball and pass the guide wire in the glenoid, and if you use a targeter, there is a difference in the angle as well as the millimeter difference is there. So VIP allows me to do it consistently with accuracy. The targeter is reusable. They only need 48 hours to give us the measurements. And if you ask me, what is the ideal, I'll just take these are all various lateralization of all the implants in the market, more or less 80 to 90% overall lateralization. Lateralization on the glenoid side of all the companies, lateralization on the humeral side of all the companies, and what I use is this because it gives me effectively about 8 to 10 mm of total lateralization. So if you understand Wardell and Walsh's study, medialized, minimally lateralized, lateralized, highly lateralized, and very highly lateralized. What is ideal? I think to me, a lateralized RSA, which is about between 10 and 15 mm, if you add the glenoid side as well as the humeral side. So what do I do on the humeral side? So I use 135 degree humerus cut. I use neither onlay nor inlay, I use a half lay, which is the Arthrex model, and a 4 mm of lateralization on the glenoid side. Effectively, I have about 10 mm of lateralization. This is a study which is very nice. How accurate is the VIP? On the Eclipse, it had 100% accuracy. On the reverse, 86 reverse studies, 100% accuracy on the base plate, 98.8% accuracy on the central screw and post. So in conclusion, I think we all accept that glenoid is the weak link. You want perfection, and perhaps a pre-op planning is the way to go. Don't take reverse very lightly. Thank you so much.
Any questions?
So great presentation, Dr. Desai sir. Now, before the VIP planner, as we know, it's a recent addition to our armamentarium. Before that, for a routine case like this, for the benefit of the audience, if you could tell us what were your intraoperative measures to make sure that you are in the perfect center in the vault, you got the perfect amount of purchase. So what are the guidelines? That is the first thing. Second question is, even with this targeter, intraoperatively, you have to rely on your judgment also, because it can actually misguide you based on the placement, based on the osteophytes which are there. If you have not taken out the osteophytes completely, it may not actually go to that location. So how do you make sure that you are accurate with and without?
Okay, so the last point I'll answer first. This targeter is based with the osteophytes. So do not trim any osteophyte if you are using the targeter. Not to trim. It is with the osteophytes that it has been designed and planned. So that's one. Two is, before all this was available, Unfortunately, it was only with experience and eyeballing. The only extra care I would take is not to have a superior inclination of the metaglean and the glenosphere, because that will be a disaster. That will fail in a year or so if it is superiorly. It has to be neutral or slightly inferior. That's the maximum care. Regarding anterior posterior placement is not a big deal. Now the only issue is getting the center for the screw and the post. It was eyeballing and understanding the X-ray CT and visualizing and doing it.
What is your upper limit in terms of correction of retroversion, where you would go with the eccentric reaming versus a metal-backed glenoid or a bio-RSA? What's your
So
limit?
up to 10 mm of retroversion, I'll accept it. I don't need to do anything more except ream. Beyond 10, if it is about 15 or so, then I will use a metal glenoid with a posterior augment. More than that, I have had a few cases where I have taken the head and prepared a bone graft and done it.
Thank you, sir. Okay, next talk.
Thank you.
Next, I call upon Dr. Prarad Kumar Singhi sir for his talk on whether to repair the subscapularis or not.
Good evening, one and all. Thanks, Ayappan, for giving this last moment talk. He just called me to talk upon the role of subscapularis to repair or not to repair. Does it contribute to stability in RSA? So, we all know that this is there are several factors which contribute to the stability, and we have heard all the way till now. So the patient factors, the implant design, but coming to the subscapularis, just been through the literature, and we all know that subscapularis is a very good abductor and internal rotator in a native joint, and it also definitely plays a very important role providing stability following an RSA. So we have seen that most of our hemi or the total shoulder where we don't do a cuff repair, so they failed miserably. So this biomechanical study has shown that whenever they have loaded by doing a subscapular repair, and more force was required to dislocate these kind of joints. So this again, they have shown that there are no much difference in the complication rate whether you repair or don't repair, but definitely they give stability in medialized prosthesis, and in lateralized prosthesis it doesn't matter. So we have been through these lot of several meta-analyses and systemic review, and everyone are of the same opinion that the subscap repair matters if you are having a medialized like Gromont prosthesis, but in the lateralized prosthesis it really does not matter. So this paper by Ladderman et al. Have shown that only 50% of these subscap which have been repaired heals, and those who had better healing had good outcome. So this we saw a debate upon the approach as well, and whenever we are using a deltopectoral approach, they have shown that repairing subscap tendon has better stability. So this is again an approach by Ladderman et al., and they have shown subscap on approach, preserving the subscap and deltoid gives better stability, and you put them on early post-op rehab, don't need to do a immobilization. So they say that it definitely contribute to the stability. So this is again an interesting read from Dongwin Lee, who have tried to analyze the repair of subscap and repairable infra. So when you repair both anteriorly and posteriorly, and they have shown that they assess the joint contract forces, and they have shown that it provides better glenohumeral stability. So this is an paper by Robert J. et al. So they have shown that various techniques to repair the subscap. The over top technique of repair of subscap gives good pain relief, but it doesn't influence the other outcome. And also this comes at a cost of external rotation limitation. So these are the various studies which have shown that there are initial complications of dislocation in the initial design of the prosthesis, but now with the more lateralized, we have seen that there are less amount of dislocations which are seen. So this is a few of my cases, and this lady we did an lateralized, and It's a 2 year follow-up. She is doing good. And this is again very bad curve case, orthopathy, where it was again lateralized. This is trauma. We get a lot of trauma cases where we try to get all the tuberosities in. So repairing them definitely adds. So for me, the take-home message here is the subscap repair. It depends upon the patient pathoanatomy, the implant design, whether you are using a medialized or lateralized implant, and also it depends upon the surgeon's preference and experience. So definitely for me, repairing subscap is definitely advisable, and it gives better internal rotation sometimes and more stability. Thank you.
Any questions to Dr. Prahlad?
Yes, there's one question.
Yes, okay. So your take is that okay, we should or should not?
Pardon?
We should or should not? Can you summarize?
Yeah, so that's what I'm telling. So it depends upon individualization. Suppose if you are doing a trauma case, the pathoanatomy where you have lesser trochlear tuberosity, it's always better to keep them. But you are doing in a cuff arthropathy where there is a bad, then you try to lateralize, use a better implant, so where you can get away without doing the repair.
Just one question. We have seen, particularly in diabetic patient, post-operatively, when you do RSA and you repair the subscap, there is a significant restriction of external rotation and forward flexion. So, any ways by you can increase the excursion of the subscap, or you can do Z lengthening. So, any literature to guide us for that?
To be frank, I don't have that experience of doing lengthening of this thing. Anybody else? Yeah, muscle slide. Yeah.
You can do a muscle slide, but mostly what the most important thing with a subscap repair is, so I repair 100% of subscaps. I will rephrase, I try to repair 100% of my subscaps, but every subscap I repair in 30 to 40 degrees of external rotation. So if you repair a subscap in internal rotation, they have a tenodesis effect. I put them in 40 degrees of, and some those who are tight, I put them in 20 degrees, I repair it, and then I push it to 40 degrees and pie crust the top. Because the muscle fibers always stretch. It's the top bit which doesn't stretch. And for me, I want to avoid excessive lateralization because I want to get the subscap repaired. Yeah. But I'll talk about that. So that was just the answer to your question.
Yeah, thank you.
Dr. Ashish sir, enlighten us about the tendon transfers, when to do, and also the surgical technique of flat dorsal transfer. Thank you.
So thank you for the invite. My slide, please. I'm going to talk about something which is the most important thing in reverse. I run a tech company. You will see the software. The most important thing in a reverse shoulder replacement is exposure. And the second most important thing in a reverse shoulder replacement is soft tissue reattachment. Please don't think if you can go in there, put a base plate and a humeral component in and come out that this operation is done. That might be done for 2 years or 3 years for a patient. But when you're doing an arthroplasty on a patient, a time to revision is what will decide how their future holds. So just because you can do something and it gives you an outcome for 6 months is not the right thing to do. This is a very good example, and I'm going to show you this example throughout my talks. Every single parameter for a reverse thought process has gone wrong here. This is a small patient. They had a 39 glenosphere. She's had an acromial stress fracture. The base plate's high. There's notching. The stem's been fixed like a hip. And this is the X-ray in 18 months after a reverse which was done, which looked like a very good X-ray preoperatively. So everything has gone wrong here. So the shoulder is not a hip. And we should stop talking about this inlay and onlay thing. And I've been saying this for a few years, but the most important thing is that we have to personalize the arthroplasty for each joint. In my experience, if a joint is too loose, it might need an onlay, as Deepthi was suggesting before, depending on how much you lateralize the glenoid. If the joint is really tight, you've got a really arthritic patient or a cuff tear arthropathy patient, then you cannot put an onlay in that. So you need to put an inlay. The problem is that the implants are so big right now that in the Asian population you can't inlay them because they end up becoming an onlay. So for me, the concept of anatomic RSA is different from Marx Frankel's concept of anatomic RSA, where he talks about the center of rotation. I've always done anatomic RSA, and my concept of anatomic RSA is, imagine you could do a total shoulder on this patient, but you're going to do a reverse. So the aim here is you're restoring the joint line, and everything you're doing is to ensure that the cuff can be repaired. The cuff is the key in a reverse shoulder replacement. If you can repair the cuff, you reduce instability, you reduce stress shielding, you reduce pain, and your function is better. So my concept of anatomic RSA is that you have to restore the joint line. So if you look at the glenoid joint line, you need to get it back to zero. I'm not saying you excessively lateralize. Then your lateralization, as Dr. Desai rightly mentioned, is different for different implants. And you have to have an inferior tilt, which has been shown. We've done a study which we're going to publish. So on table, if you have 5 millimeter gap between your jig, whatever jig you use, if you turn it downwards and you have a 5 millimeter gap, I actually just put a Cobb's elevator because my Cobb's is 5 millimeters. 5 millimeters is roughly 10 degrees. If you do 1 centimeter, it's 20 degrees. So if you don't have navigation or planning introp, that's what I use. The number one problem with lateralization is axillary nerve. If you excessively lateralize, you will stretch the axillary nerve and it will actually cause you more pain and more problem than not. And then I call it a hybrid humerus technique. So it's either an inlay or an onlay. It depends what you do. And the aim here is to get cuff repair. So we've all got patients like this. I do not understand how, if you don't have an infraspinatus and you don't repair the infraspinatus, you can get external rotation with your arm by your side. What people suggest on data is you get external rotation because you do a reverse, so you get it abducted. Your reverse abducts your arm, and in this position, you're actually contracting your posterior deltoid. That's not ER1 position. So in a case like this, which has had a failed cuff repair, you have a really bald head. And in this really bald head, for me, this is where the lat dorsi runs. So I look at a lat dorsi in every single patient. So there's your conjoint tendon. Those are your 3 sisters. And everything below the 3 sisters is your latissimus dorsi. And for me, the latissimus dorsi is the most important structure in a reverse shoulder replacement. How do we do this transfer? I'm going to try and show this a little bit in live surgery as well tomorrow because it's a very important trick to learn for everybody who wants to do a reverse shoulder arthroplasty. The rehab is really important. It's not just about doing a transfer as to how and where you put it in place. And then we're going to come to this. So we're going to see this again and again. My Gillies is on the axillary nerve. That's the lat dorsi. See how close the axillary nerve is to the lat dorsi, and look at what happens to the axillary nerve when we lateralize. It gets stretched. And when you lateralize and adduct the arm, the nerve gets stretched even more. So I'm going to play this video again. Look, when we push the arm outwards, your nerve is getting stretched. So excessive lateralization is going to cause a problem in the nerve. And knowing the nerve anatomy is very important when you do a reverse with a lat dorsi transfer. So I'll give you an example of a case. So this is a revision of a revision of a revision. 2 years, non-op sling, hand and arm, no function. Okay, so in her, it's a complex case. So I've done an allograft prosthetic complex. I'm not going to show the thing here, but one of the key things which I do for those who are going to embark on revisions is I cut the bone in half and take the implant out and leave all the tendon attachments with bone inside. I'm trying to show you the concept of this. So the concept here is that that's the subscap, the posterior cuff there. That's the lat dorsi, that's the teres major, and then you've got the deltoid which is attached laterally, and pec major with bone. So it's really, these tendons are the key for you to get stability. This is a complex situation, but the concept is still the same. Once all of these are attached, the radial nerve is there and the axillary nerve is there, and they need to be dissected. This is an APC which we've built for this patient. And the key thing here is just pushing this joint back down. Whether you use dead bone or dead metal, it doesn't matter. The deltoid is going to stretch and you're going to have a flagpole, and this will dislocate in 3 years. So restoring the function is really important with all of these tendons, which you use to transfer them, because this gives you stability. So this is the same lady who could not function, and within 6 months, she's functional. This is another case, instability post RSA. Posterior cuff was not repaired, subscap was repaired, infraspinatus was not repaired, patient was lateralized, comprehensive, with lateralization of the glenosphere, medialized humerus design. Look at this intraop, no posterior cuff. In him, I took the latissimus dorsi, which you can see there, and we add the latissimus dorsi transfer. And in here, you see without the lat, it's dislocating. Now I'm just going to push the lat in position. I'm just pulling on the lat and pulling my hand downwards. It pushes the head down. Look at that. It's a very powerful transfer in unstable shoulders. So the concept that if you don't have an infraspinatus, you don't repair it, you will have instability. Do they give you function? You need external rotation in your life to do a lot of things in life. And if you don't have external rotation in life, you can't function normally. You know, day-to-day stuff, you need, I like to get all my patients to start swimming at 10 weeks. This is 16 weeks post-lat dorsi transfer. He can externally rotate. This is another patient. We start with rehab slowly. And then you can see preoperatively, he can barely get hand to mouth. At 12 weeks, the range of motion is improved. He can get a cup of tea to his mouth, but he can't get 1.5 kilos still. And then at 16 weeks, the golf swing gets better. So for people like Dr. Desai, this is really important. So specifically, I do lat dorsi transfers in patients who've got a weak posterior cuff who need to play golf because it improves their golf swing. So I'm going to stop now. There's a rehab protocol for this. Sean's my physio. He's at the back there. He can show you the rehab protocol. You have to work on the rehab protocol for these patients, but they do get better, and then they do get the functional result as time goes by. So latissimus dorsi transfer, in short, is very important for function and for stability of your reverse. Thank you.
So one of the challenges with the latissimus dorsi transfer is at one end you want it to be biomechanically very strong. So any transosseous technique where you drill a tunnel through which is biomechanically strong has the risk of creating a fracture-like scenario there or weakening your metaphysis there. So what's your technique? What are your tips wherein you get a good biomechanically strong transfer but at the same time protect the bone there?
It's a very good question. So I've been using the old suture anchors for all my tendon transfers for 10 years now. So my tip to everybody is, if you're going to do a tendon transfer on cortical bone, which is a pec major or lat dorsi, use an all suture anchor. One, it's easy. You can put your all suture anchor where it needs to go, and then you attach the tendon. The second thing is that if you look at 5-year x-rays, once your tendon transfer is healed, you get a divot in that bone where you're going to do the tendon transfer. I am concerned with the short stem implants that there could be a potential fracture. So if you look at the Ascent Flex or you look at the smaller implants, I'm agnostic to companies, you know, I'm just trying to say that if you're presuming that you're going to do a lat dorsi transfer on someone, I don't have data to prove it because I've always used a slightly longer stem. My stems are usually 90 mils long. But if you're going to use a perform or a shorter stem and you're going to do a lat dorsi transfer on them, you will have bone which will erode under the latissimus dorsi transfer with time. Could that be a risk for a periprosthetic fracture? Yes. So if you're going to do a transfer, my experience is to use a slightly longer stem.
So your fixation is an onlay fixation, or
fixation varies. So as I said, I don't believe in onlay or inlay. Every implant I use, I vary my height of the implant based on the tensioning I need. So the concept is a hybrid humerus concept. You do your glenoid, you put your glenosphere. If it's too tight, they get an inlay. If it's too loose, they get an onlay.
With regards to your fixation of latissimus dorsi transfer, can you elaborate? So you said all suture anchor fixation, but
Yes.
what is your exact technique? Can you elaborate on that a bit more?
I can show a bit tomorrow. So it basically, you cannot put the lat dorsi more proximally. Basically what you're doing is you're converting the lat dorsi from where it sits anteriorly, wrapping around and going posteriorly. And what happens is with the reverse, you're distalizing by 3 centimeters anyway. Every reverse distalizes by 3 centimeters. So biomechanically, even though the position is coming across the same way, but the net effect is it's actually 2 centimeters more proximal than where it was. And the key bit is when you're attaching the lat dorsi transfer, you have to get the arm abducted and maximally internally rotated because you want an external rotation lever arm. So I put the arm at 30 degrees of abduction and I keep the arm on my tummy, and where it goes is where it goes. Two all suture anchors, 1.5 centimeter apart, and then you use those all suture anchors to take whip stitch the lat dorsi tendon, and then you take the lat dorsi, whip stitch it back down, and then that repairs to bone. But we'll show it tomorrow.
Thank you.
Thank you for an excellent talk, Ashish sir. Now we call upon Professor Kyu Cheol No from South Korea. He is the president of the Korean Shoulder and Elbow Society. Please give a big round of applause for Professor No. Thank you.
Okay, good morning. I'm Dr. Casey No, Seoul from Korea. Congratulations of the BSS symposiums. I talk about the mouse. Okay, I talk about the lapiscoper. Some patients have many severe functional problem. For example, we know the clear combined loss of the elevation and the external rotations. The RSA only can restore the forward flexion, but not active external rotation. That is a problem. So clear patient need to address the RSA with the tendon transfer. So for for the elevations, I always use the bony glenoid lateralization for best range of motion without notching. And for external rotation, I always use the LDTM transfer because in Korea, all the senior the women always the paper thin the LD tendon, so I always tendon and TM transfer together. So LDTM transfer is effective to the restore full active range of motion or not. The preliminary result, and not too many, but 15 cases, mean age is 73 year and mean follow-up in 21 months. So the left side is pectoralis major, and then we pec major sparing, and then we can see the LD, and then the posterior lateral is the pectoralis major together. I always LDTM with a dermal patch augmentation together because we have to release mobilization. We have to make mobilization too long. At the time, the patch augmentation, strong fixation is needed. And also after I repair the intraosseous suture repair techniques. So the tendon suture through the bicipital groove to the posterior lateral tunnel like this, outside in repair. This is a final gross findings. So I already talked about that. The whip stitch from the bicipital groove and then posterior lateral corner, and then repair the all together, wrap around the suture. Left side is LDTM. The mobilization like this is the fully the teres major insertion area. And second, after that, I already finished the lateralization of the bio RSA. Check the range of motion, notching or impingement. After that, final, I repaired all LD TM tendon to the bone. And then external rotation and the internal rotation during the motion, the fixation site is very strong. The post-op X-ray, and then pre-op and the post-op fold elevation is very increased, and the external rotation is very good. The pre-operative, the minus 10 degrees, and the post-operative 13 degrees. We gained 23 degrees. There are no loss of the active internal rotations, and also constant score, other score is improved. And we focus on the external rotation, Adler score related to the external rotation score improved. The radiologic result is the scapular notching is 20%, but no acromial fracture. And the complication is one traumatic dislocation, and we did the reoperation. And the two patients have some neuropraxia, but spontaneously resolved. So when you do some tendon LDTM transfer, we know the some anatomy tendon, the pectoralis major, and the LDTM also we already talked about the neurology, so radial nerve and axillary nerve together. So modified lapiscoper is very good, restore the full active range of motion, especially external rotation, and also patch augmentation in fragile tendon can help making LDTM mobilization and then tendon to bone healing in intraosseous suture repair. Thank you very much.
So any question for Dr. No? So what is your so we have the patients who have weak external rotation, the ones who have a significant lag, where
Yeah.
there's a flap sign, versus the one who are slightly weak, but they don't have a horn blower. So in whom do you feel you can get away without doing a tendon transfer?
After, even though anyway, though we have the TD transfer, but not active external rotation, is tenodesis effect. So anyway, the not negative degrees. So I accept that the degrees. Anyway, they don't have any flap test.
Dr. No has one more talk. I think it will be loaded up now. I would, before he goes on to the next talk, I would really like to tell the audience and also the faculty that contribution of Korea, South Korea, and the professors in Korea has been really great, especially in the development of arthroscopy and shoulder, and let it be not even in orthopedics, even in other fields, even in spine. There are so many of us who have visited there, and it has changed our lives. So I visited many places for fellowships. So what I really found was professors in Korea were very, very humble and very forthcoming with teaching, and they really take care of us because when I went for a fellowship, I could not really afford a fellowship. Means I could not afford a stay or even food at times. So my professors have been very, very great. I think being the president of the Korean Shoulder Society, I would really, thank Professor No and
Okay.
all of us from India should really thank
you
you
very
for
much.
this
Thank you very much.
opportunity, because not only you, so many great professors are there in Korea who have made a mark in shoulder surgery. And
Okay.
today, I think I would say proudly that the reason we have a Bangalore Shoulder Summit is because of Korean professors. Thank you so much.
Yeah, thank you very much. I'm very honored to hear, and then I surprised the BSS symposium is very international, wonderful symposium. So I'm happy to hear. And next topic is navigation in reverse total shoulder. There are racial differences in glenoid size. The glenoid width measurement average according to the reference 29 millimeter, but according to the Asian the paper to less than 25 millimeter. when we do some surgery in small glenoid with severe bone defect, at that time we always think about the vault perforation and screw penetration or size mismatch. So preoperative we think about the 3D planning, and also intraoperative we need a navigation system or PSI system. So you already know that PSI is the guide, and then today I talk about the navigation systems. The navigation system is we need some system, GPS system. So during the surgery we can see the right side, left side. Inside of the whole thing is possible. The navigation there are so many benefits. Definitely one of the most thing is enhanced visualization. During the surgery, sometimes we have to change the decision making. So at that time, the navigation is very helpful for us. So according to the match code algorithm, we divide the two groups. One is the standard reverse total shoulder. Group 2 is navigation systems. The mean age is 72 and mean follow-up is 1 year. There is no significance between the two groups demographics, and post-operative X-rays, glenoid burden and inclination is there was no significance both group, but penetration of the central packed navigation group very small, only just 6%, but standard group is 40%. And also peripheral screw is also same result. Navigation group only 23%, but standard group is 44% penetration. But functional score, ASC score and constant score, there is no significance both group. The female 83 severe deformity, the glenoid. In the cases, I'll choose the glenoid bony lateralization with bone graft and also augmented base plate. I always use the deltopectoral approach, and then humeral head cutting, and then glenoid exposure and coracoid guide fixation, and the glenoid GPS sensoring, synchronizing, and then during the surgery we have to find the central pin insertion. The defect is very severe, so in the case is central pin, the finding is very difficult, and at that time the bone graft and then augmentation together. After that, peripheral screw fixation also. So the preoperative X-ray and the post-op, the bone graft, and then this is a superior augmentation plate. But even though the navigation also have many drawbacks, learning curve and the time require the additional time, the additional step, setup and the calibration time, the technical issue. Sometimes the malfunction will be occurred, infrared cameras and tracker. Sometimes coracoid fracture occur. So we compare the both groups. Early follow-up period, the navigation and both group demonstrate similar improvement of range of motion and functional outcome score. But in navigation groups, there was less penetration of the implant comparing to the standard groups. In future, the longer follow-up and larger cohort size. But recently, in severe bone defect and revision case, I usually use hybrid techniques. I usually use the mainly PSI and then navigation is accessory. So this is a preliminary result. So preoperative PSI and navigation, I prepared both of them. The hybrid technique is more the decrease of the penetration of the peripheral screw, and then central pack penetration is 0%, and then penetration of suprascapular notch also is very low. But also OP time, comparing to the navigation only, the PSI with navigation hybrid technique, the OP time is shorter. Um, in summary, the hybrid the technique, the limited indication, more beneficial in severe bone defect for small gland in Asian groups, and because a hybrid technique have a mutual cooperation. The PSI gives some 3D printing guide, and also through that guide we find the proper direction. But using a navigation, we can prevent penetration and double check of PSI system. Thank you very much.
So in complex cases, in spite of your best planning with navigation and your PSI, have you had situations where you haven't had adequate amount of hold with minimum one screws, etc., and then you have had to do a staged procedure? So how do you plan for these complex cases where you have to be probably ready for a staged procedure where there is severe bone loss, and how do you do a good bone grafting and then come back? Can you elaborate?
Some severe cases we cannot apply to the PSI guide to the bone defect. At the time is uh, uh, we have to find some central point at first. So at that time I use the navigation. After that, apply to the PSI. Sometimes PSI is first and then navigation during the surgery, and then we have to check the length of the screw or something. But the guide give us some the proper direction, but we cannot check the length of the something. So at that time, during the surgery, the navigation system showed some correct length of the something. So uh, and also the sometimes the superior defect is very severe. At that time is uh, we have to inclination of 10 degree or 15 degree, and then more 20 degrees. We have to decide that one before surgery. Before we making a 3D printing guide, during the 3D simulation, at that time the check the 10-degree inclination and the 20-degree inclination, more big inclination, we have to remove the inferior bone. At that time, we have to bone graft more after that, and then the superior, the augmented implant or something is before surgery. We have to decide something. So anyway, we have to we have a two weapon. So it, according to the case at the time that we apply to the which one is the first or something. That is good.
Thank you.
Coracoid fractures using the Navi?
Fracture? No.
I'd like to ask. So I use navigation in over 90% of my cases. I've done a fair few. I've done over 1,000 reverses now. But I feel it makes me a better surgeon using navigation, and especially for complex cases, and it makes me easier to teach my fellows. I would like to ask a question to the audience here. If you had navigation available in India, how many of you would use navigation? How many of you would use navigation if it was for free? And how many of you would use navigation if you had to pay 25,000 rupees for it? Per case. So the problem with this is, the problem, and this is a real problem. Why did Exactech not come to India? The problem is the ASP of the implant is the lowest in the world. Okay, the cost of a reverse in India does not even meet cost of running a business for anyone. And then if you want to give navigation on top of it, Korea is not too far. You cannot afford, there is no way any company can give it to you there. So for a model in India, if you're going to get navigation by Medacta or Exactech or whoever else in the future is going to bring it, Akuna's got a navigation system. I haven't brought it to India right now because there's no cost model to it. So if the surgeons, firstly, there needs to be a need. If surgeons think that they will use navigation, then navigation will come here. But the second thing is patients have to pay for it. Because if no one pays for it, the system's not going to come here. I think 100% all my revisions are navigated, all my complex cases are navigated, And I think one of the things which people were discussing is there is no evidence to suggest how much of retroversion or antiversion is important. You can put something in 10 degrees of retroversion, they still function well. What we did in our study, we looked at 150 cases. We got CT scans post-op on every case, and we looked at the implant positioning. The biggest difference I found in my results is my superior tilt and my inclination. Even in experienced hands, just like Deepthi was saying, the patient's in beat chair, the scapula sitting in this position, what you think is right is not actually that right. So my implant positioning has gotten better, and it's made me a better surgeon, especially in complex cases like the case Nilesh showed today that needs to be navigated. It's such a complex case, and we get one shot at these complex cases for these complex patients. So as Professor O was saying, in those cases you throw the kitchen sink. If you can get PSI, you can get navigation, whatever you can get for those patients, use that. Don't try and tell this patient you've got such a complex arthroplasty, I'll be able to do it for 2 lakh rupees in you. It's almost better to say, do not have surgery, please, because I'm going to do harm. Because you'll break the glenoid, you will cause all sorts of problems. In the complex cases, you need technology. So sorry I'm going on about it, but it's a very important factor in terms of what Prof. O just said.
Thank you so much. We have one more
Thank
talk.
you, sir.
Dr. Purna is, was late on his flight. His flight had some technical issues, so he just landed now. We'll finish his talk before we go on.
Thank you, Ayappan sir. I'm glad that both of our flights got delayed, both mine and Sirish's. So there's no debate. To be frank, I have just learned a lot about this when Dr. Ayappan gave me this talk. So we all know about reverse. Gramont designed it. So what were the drawbacks of this design? Because we had to think of lateralization. We knew that there were few biomechanical challenges and clinical implications as well, which led to higher rates of dislocation, notching, decreased internal and external rotation, which then we thought of different concepts. The image on the left, we know that the different implant designs that today have the amount the amount of lateralization that we have. The main purpose of lateralization was to improve joint stability, restore deltoid and rotator cuff tension, maximize range of motion, and minimize notching and impingement in the longer term. So basically, what are these designs, LG, MH, and what are these concepts? Lateralized glenoid, the one on the left side, which I'll be talking about, is where you lateralize the system basically on the base plate and the glenosphere, and you kind of use an inlay type of design on the humerus. So basically, your glenoid offset is almost similar to your native this one, but the entire glenoid is lateralized. Whereas the medialized glenoid, you play around more on the humerus, where you keep the humeral insert above the stem and you lateralize more on that side. Basically, these two systems have a lateralized designs, but it's the way we play around with the humeral and glenoid components that dictates the philosophies. So why do we, what are the advantages of glenoid-sided lateralization? So basically, the most important thing is it reduces notching. So it can be done by using a bone or a metal interface, but using a metal interface, we have a limit, and if we have to do above it, then we need to use a bio RSA kind of thing. It increases the impingement-free arc of motion, reduces notching rates, and also it is shown to increase external rotation compared to medialized glenoid design. It also enhances the stability, and by increasing the deltoid wrapping around the muscles, which lead to an increased external rotation and significantly increases the range of motion as well. So what are the is this totally safe? No, definitely not. It has its own set of complications if we don't follow the principles, and if we just rely on this kind of design. It can lead to if we lateralize the glenoid base plate too much, then it can lead to increased shear forces, lead to bone implant interface loosening in the longer term. And if we increase the size of the glenosphere a little bit more than what it is desired, it can increase the acromial stress and lead to acromial fractures or stress fractures that the surgeons previously showed. Also, there are technical limitations. If we just rely on the implant to lateralize our glenoid base plate, the highest available, we all know that the highest in India, I think we're using the Tornier Arthrex, the highest available lateralized offset is around 6 millimeter, and if we have a glenoid defect and if we need to lateralize more, then we have to use a combination of bio and a offset kind of thing. So coming to the other side, humeral sided lateralization. It may be good in good cuff and tuberosity preserving surgeries. It can lead to tensioning of the cuff. It is also good in surgeries where a previous hemi or total shoulder was done and you need to convert it into a reverse shoulder. In these kind of designs, basically you can retain the stem and then do an onlay type of thing, because we all know that it is not very easy to extract the stem. So it is more suitable for onlay kind of designs. Basically, lateralization is done to decrease the notching, increase stability. But especially with the humerus, with the older type of poly cups where there is overhang medially, this might not lead to reduced notching, and it can lead to a increased notching because of the poly overhang medially. So definitely, if you're doing this kind of design, we need to have a very proper balance. Our positioning should be very good to avoid complications. So it requires a lot of more experience and technical skills. So next is the optimal degree of lateralization. In this, there is a very good paper by Stephen Bohr et al., where the preoperative humeral head size is a reliable predictor for required base plate lateralization. It has shown that if the humeral head size is less than 47 millimeter, a smaller base plate lateralization and a smaller glenoid spear would suffice, whereas if the head size is more, then we need to use a bigger one for this patient. So in conclusion, I regularly do this lateralized glenoid and a medialized humerus. Normally I use a metal interface with a plus 3 mm. If I need to use more than a plus 3 mm, I always use it to combination with if I need to use it more than 6 mm, I combine it with a bio RSA. Normally I use a 25 mm base plate with inferior position and a 36 millimeter eccentric glenosphere in most of the patients to have that subacromial space, especially in abduction and external rotation. A humeral site, basically with this type of design, so thank you, that's okay.
Thank you, moderators, for an excellent session. Now, change of moderators. Dr. Yashwant sir, Dr. Prahlad Kumar Singhi sir, Dr. Jyoti Prashant sir, Hemant Reddy sir, please. Naresh sir will be taking over, and he'll be speaking about cementing in RSA technique and long-term outcomes.
We have to switch Nagraj sir's preponderance talk because he has to fly to catch, and it is I really like to thank him because he made his time. He's coming in the afternoon and going back by night. It's pretty troublesome for him. Thank you so much, sir, for coming and gracing the occasion.
My pleasure, Ayyappan. So at the outset, thanks to Ayyappan for this invitation, and actually we have a common mentor, just like Ayyappan mentioned, Professor Yu Yonsik. I was his first international fellow, and we are very close to him, and thanks to him we have gained our skill sets. So I've been asked to speak about cementing, a very basic topic. Probably the beginners are going to benefit a lot. The entire idea of a good humeral implant is to match the anatomy, and the rationale is that if you replicate the anatomy, you can restore the cuff and the soft tissue tension. There will be early implant stability, and in the long term you want a good strong bony fixation. The other rationale is that you want to minimize the complications, so therefore the humeral head implant design becomes important. What are the common complications? Osteolysis, stress shielding, which leads to radiolucent lines, and proximal humerus bone loss. Each of these increases the risk of periprosthetic fracture. So therefore we want a fixation that must therefore be balanced, also keeping in mind that in the case of revision there should be ease of extraction. So these are the principles when you think about on the humeral side how you want to have an ideal fixation. Generally, the diaphyseal fixation implants, we have now shifted to the metaphyseal fixation. Generally, the diaphyseal fixation implants always had to be cemented. So there has been a transition to metaphyseal fixation, and let's go through the slides as to why that has happened. So in general, when you talk about reverse shoulder or shoulder arthroplasty, on the humeral side, there are not major issues. So aseptic loosening is not so common, and therefore the weak link has always been the glenoid side. Therefore, when we talk about fixation on the humeral side, there are multiple options, because at the end of the day, it does well on the humeral side. So cementing is one. Either you can do it proximally through and through, or only distally. And the second type is what is called as uncemented or press fit fixation. When you talk about press fit fixation, the principle could be an undersized reaming. So you ream less, you put a bigger implant, and therefore you achieve stability by hoop stress. So that's one way you get press fit. So what is the primary difference between in the biomechanics between the cemented and the press fit? The axial micromotion is the same. So the axial loading is the same, but the rotational micromotion in the cemented is less. This is the first biomechanical difference. When we talk about press fit techniques, which is more commonly done, you can have the third type where there is a surface is roughly coated, which allows a scratch fit and the bone to grow on and within the implant. So that's the third concept in terms of press fit. And the fourth concept in terms of press fit is impaction bone grafting. So you use bone graft from the humeral head along with the press fit to get that impaction effect. So the trend, the summary is that it generally has shifted to a press fit metaphyseal fixation. And we all see such dramatic results where a pseudoparalytic patient with appropriate principles, which we are discussing all throughout the day, achieves very good results like so. So why is that so? With the metaphyseal press fit fixation, you have better vascularity, which allows good bone ingrowth. It is easier to do a revision when you plan a removal. There is less stress shielding, so therefore on the X-ray you don't see much of loosening and bone loss in the proximal humerus. Therefore less periprosthetic fractures, and when, if at all it occurs in the press fit variety, it will occur in the metaphyseal region, which has got better healing potential. Now coming to the cemented stem, what are then the advantages of the cemented stem? Well, the first thing is it's easily you can overcome in a situation where there is an implant and a bone mismatch. So you find that your implant is extremely loose, you can easily circumvent that situation. If you feel that you should use a smaller implant for that particular patient because you want to have less stress shielding, you can do that in the presence of a cement. There is a less risk of an intraoperative fracture. So when you put a press fit implant, there's a big risk of causing stress rises and an intraoperative fracture. You can always add antibiotics. So for an at-risk immunocompromised patient, you can use the cement with antibiotics, which reduces your risk of infection. And you don't need to worry about bone ingrowth, especially if the proximal metaphysis has got compromised bone because of a variety of situations. So these are the predominant advantages. So indirectly, I'm telling you the indications for a cemented stem. And obviously in a revision scenario where the entire bony architecture has got altered, you need to have the cemented stem in mind. What are the disadvantages? It will take a bit more time. Technically, you need to be good enough to create a good cement mantle, and that's where I'm going to show you how to go about it. It is difficult to remove in a revision scenario, especially if you're doing it for infection, because there's going to be a biofilm on it, and therefore you have to be thorough in removal of the entire cement mantle, which therefore will cause perforations, fractures, extrusion of that cement, and neurovascular injury. So at one end there are advantages, at another end there are significant disadvantages, but that's something which is essential when you have a situation like this. Severe proximal humerus comminuted fracture where you have a very poor bone stock, severe osteoporosis cases where you've got a very poor bone stock and you're planning an arthroplasty. In a revision scenario, as I mentioned, as you can see here, a just unique has been revised, so you have to have a cemented implant. Sometimes you need to do a staged procedure where you should use a cemented spacer and then go back for your revision. So these are the important messages which I wanted to say in terms of difference between the two fixation techniques. Coming to the cases, if you have a comminuted case like this in an elderly where you're planning a primary reverse shoulder arthroplasty, obviously you're going to tackle the tuberosities, but you need to have a very good cementation technique. So your cement spacer comes in. You make sure you keep it dry. You can use a syringe now with a cement. Excess cement is then taken out. The prosthesis then comes in with the bone graft. So that's a dedicated fracture stem being shown here. You obviously are going to take care of the height and the version in a fracture scenario. and you can use the bone graft additionally in the proximal area. So fixation in the proximal area is primarily through the bone graft. So I've got two talks, I can take it back to back. Those are the images that you see. But here again you see there is some amount of osteolysis that seems to happen in the proximal area. So in the complications of these, we are going to discuss about what are the various stress shielding side effects that happen. What are the other ways you can do a cementing procedure? So this is, I just prepared for this talk. So that's the cement gun. You can use a cement gun. However, if it's not available, you can use the principle of rolling the cement and then using your finger to create a pressurization. You can coat the cement onto the polished portion of your stem. So this is a dedicated fracture stem. So distal cementation, and proximally it's a rough surface for the healing of the tuberosities. Second case scenario, a 64-year-old male who had a massive irreparable cuff tear. As you can see, he's got some pathological changes in the proximal humerus. So he had an enchondroma. To be sure, we did a CT guided biopsy. We confirmed that this was a benign hyaline cartilage and enchondroma. We were expecting the bone quality to be poor. That's its preoperative situation. He had severe pain, severe restriction of function. Intraoperatively, we had a significant complication in the form of a glenoid fracture because of over-enthusiastic retractor being placed, and we had to circumvent the situation. So obviously cement was used as far as the humerus was concerned because the proximal metaphysis was poor quality. We used a bone graft from the humeral head and grafted it. There was some compromise in terms of the fixation. That's his 1 year follow-up. So you can see that there's a nice cement restrictor there. There's a nice cementing principle that has been followed, and a good cement mantle has been there. He's overall happy in terms of his pain relief. Function is obviously not as good as other cases, but patient is overall good. So the principle is that if there is a poor bone quality in your proximal metaphysis, you should be adapt in making good cementation techniques. So what are the conclusion as far as the evidence is concerned? As far as you are using a metaphyseal fixed implant, you can choose either a cemented or a press fit, unless there is a specific indication or a contraindication for either of the technique like I showed. So if you've got poor bone quality there, if there's a fracture scenario, revision scenario, worried about infection, these are all the various situations where you would use a cemented implant. If you've got a very good bone stock, you can always use a press fit implant. Multiple studies across the spectrum over many years have shown similar clinical and functional outcomes in all the scoring systems. Again, reiterating, aseptic loosening on the humeral side is rare. So the revision, the reason for revision on the humeral side is rare, although we keep seeing X-ray findings of lucent lines, osteolysis, and stress shielding being a very common finding in many follow-up series. But the clinical relevance of these radiological lucent lines or osteolysis is still unknown. So when you see a lucent area, you don't know whether the implant is already loose because the patient is clinically doing well, or you can't even predict objectively that it's going to get loose. So we don't have evidence what is the importance of these radiolucent lines. Also, there is a theory that actually stress shielding might be happening because of systemic osteopenia, so a general defect that is happening in the patient, or the poly wear that is happening and that is affecting the cuff compression effect and therefore causing stress shielding. Few important studies, recent studies from a British study 2022 where they compared cemented versus uncemented reverse total shoulder arthroplasties as a primary treatment for proximal humeral fracture in the elderly. The conclusions were that compared to the cemented arthroplasty, there is not much of a difference in the clinical outcomes and in the radiological outcomes. Both the categories did well in terms of functional outcomes and low revision rates. This is a nice study. It's actually from the Australian registry, which showed 10-year data for cemented versus cementless in reverse shoulder arthroplasty. Again, for proximal humerus fractures, the revision and the mortality rates were same in both the categories. Therefore, if you have an appropriately indicated patient, you want to do an uncemented, even in a proximal humerus fracture situation, you find good bone stock, you can do the same. If you feel you want to cement only distally, you have that option also. So that's the conclusion. A very nice study by Pascal Ballot, where they compared the cemented versus press fit in general for reverse shoulder arthroplasties. Again, there was no significant difference in the constant Murley scores, meaning the functional outcome was the same in both the categories. However, Surprisingly, they found that the active shoulder range of motion was worse in actually the press fit group, and they attributed this to tuberosity resorption. So even in this category, the press fit group or in the cemented group, you do see some amount of osteolysis and some amount of stress shielding effect. My take home message: cemented versus uncemented humeral fixation, both are well accepted in terms of good functional outcomes. Uncemented metaphyseal press fit fixation is most often preferred unless there is a proximal humerus fracture, poor metaphyseal bone stock, you're dealing with a revision scenario, or an altered proximal humerus anatomy where you can't rely on the metaphyseal fit. And the ability to do a good cemented fixation with the either the syringe or with the cement gun or with your manual technique, keeping in mind that in case there is a future revision, you need to have a good cement restrictor which doesn't allow the cement to go outside through those stress holes that are happened and then cause neurovascular injury. So keeping in mind that future revision might come up, you need to know to go do a good cemented fixation. Thank you.
Wonderful presentation, Dr. Nagaraj. Are there any new cements which are going to come, which may be more efficient? Because from 40 years we are seeing the same cement.
True, true.
Is it something new which is going to come up?
Not that I'm aware of.
In South Korea, Doctor? Any new cements are coming up which may really form the bone? Not. Can you elaborate a little bit on the subscap fixation with the bone cement? You did not show any of the pictures or how to fix a subscap with when you are doing a cemented stem.
Nothing much different than how you would do it routinely, meaning I do a transosseous technique. So you drill your transosseous holes. I take about 3 to 4 transosseous holes. The sutures already passed through. You need to make sure, although that the sutures are railroaded well, they move well, because once your cement comes in, there's not going to be any scope for you to move the sutures. Otherwise, nothing much different. You need to keep in mind that with the cement there, and the risk of losing out on some of the sutures, so as many points of fixation as you can, you need to have it. So nothing much different than how you do a uncemented.
Are there any tips if we miss making the pre-drill holes before we put the cement? How do you fix the subscap?
That's a tough situation to handle, because then you have to rely on some sort of an anchor based fixation, and the proximal humerus metaphysis is already very weak, so very difficult to get a purchase with an anchor, but that's your only bailout then. So you can use knotless anchors to get a fixation, like how with the stemless system also it has been described, double row anchor fixations have been described, so one on the medial row, one on the lateral row kind of fixation.
Thank you.
Just one word of caution with the use of your cement restrictor, because most of our humeri are very thin. So every time if you have to have using a mallet on it, it's likely to burst. So please don't use it. If it is going easily in, you can push it in. Best thing is to cut as many fins as possible, one. But I stopped using it, I only use bone. I put bone in, I push it through your trial and then use your cementing, so that your cement does not go beyond.
Absolutely.
So just now Kapil was showing a case where the cement is right up to the elbow. Somebody did an elbow replacement and the elbow replacement is out of the back. So that's one thing you have to be careful
Absolutely. At the same time, we also need to keep in mind when you're using bone, you can't afford to keep it big enough that it gets stuck. So you need to make sure you take your stem size, make sure your whatever instrument you're using to push your cement restrictor in goes in easily. So these are the tricks which you have to learn to make sure it doesn't go too deep inside and doesn't remain too high up also. All right, thank you.
Thank you, Nagaraj sir. Thank you, moderators. The next set of moderators, Dr. Ashish sir, Dr. Chirag Tonse sir, and Dr. Subramanian sir, please, on the stage. Ashish sir. Next talk is on lower trapezius transfer in RSA by Deepti Nandan sir.
Thank you, Ayyappan, for this very focused, excellent meeting. Now, disclaimer, don't ask me questions on this. I have never done this. I'm just done research. Now I have an idea what this could be done to for an RSA. Okay. So lower trapezius transfer for reverse shoulder replacement. Now, what are the prerequisites for any lower trapezius transfer? You need a functioning lower trapezial muscle, obviously. adequately stable shoulder. That means the reverse shoulder itself should be stable enough so you can get a good forward elevation, and the rotation is done by the lower trapezius itself. And a functioning deltoid is required because it does contribute to some of the external rotation. A weak external rotation of the shoulder, that means there is a absolute lag sign and you don't have much of a teres and an infraspinatus function. So loss of external rotators, as Ashish had shown in his presentation, that external rotation is very important for our ADLs, and if you don't have a good teres and a good infraspinatus like on your MRI, is a good way of finding out if there is good enough external fixator or not, external rotator or not. That's when we consider a transfer to help in this. But we have had techniques or strategies in the process itself which can increase our rotation. That means like you reducing the retroversion of the humeral side. That's what we did traditionally for getting more external rotation. But studies have shown us that that is not going to help us. So we've gone back to using natural version itself for our humeral component. Lateralizing glenoid does help because it increases the deltoid wrap and it recruits more of your posterior deltoid and will help in external rotation. Offsetting the humeral stem posteriorly also is shown to improve our external rotation. I have never done this, but it is possible. Now with muscle transfers, we have two options. The LD transfer, like was shown earlier, and the lower trap. So anatomically, if you look at it, lower trap is more in line with the pull on the humerus. So when it's transferred to the greater tuberosity area, the direction of pull is similar to a posterior cuff. And if you look at the LD itself, it is not similar. So there's a lot of training required. That is what Ashish had shown, that there is a lot of physio required. If you're not targeting the LD to do that external rotation function, you're not going to get good external rotation. Biomechanically, line of pull and the movement arm is similar to the rotator cuff, so it's more useful. This is a study which is done by George Atwell's team, and they have done a biomechanical study looking at lower trapezius for RSA, and they have found that it restores the external rotation better and it has better torque when compared to LD. It also has better, with the humeral lateralization, there is more of external rotation itself. So component changes and the lower trapezius transfer itself helps in better rotations. But as the abduction of your arm increases, the rotation reduces. It is only more useful as an external rotator till about 60 degrees of abduction. After that, it does not function as an external rotator. Movement arm, if you look at cadaveric studies, the lower trapezius has a better movement arm. So transferring the lower trapezius gives you better movement arm. As in physics, you know, better movement arm will give you better efficiency of that muscle. Synergistic action, it is a more synergistic action to a rotator cuff external rotator. So that's a better transfer than a LD transfer. In patients who have a subscap deficient shoulder, like in a massive rotator cuff tear, lower trap is better. But if you take out the latissimus dorsi, like we have done in the last few cases, now you don't have a subscap, you don't have many of the internal rotators, and you have taken off the one internal rotator and using it as an external rotator. Like Prince had told us, you need internal rotation for our personal hygiene, so lower trap probably is a better idea. This is a paper on failed tendon transfers and then you go for a reverse shoulder replacement. They have found that you do a LD or an LT for cuff tear and it fails and you go for a reverse shoulder replacement, the outcome is similar. But if you do a latissimus dorsi transfer and then do a reverse shoulder, the outcomes are slightly worse and the complication rates are higher. This is generally to say that in rotator cuff, LT transfers work well. So if the arm can be elevated with your reverse shoulder replacement, a good alternative is a lower trapezius transfer. But a separate incision is needed and you need an extension to your transfer. So some graft needs to be taken as well. Thank you.
Can we have Senthil, please? So thank you very much again. So I'm actually, the work has been done, before itself. We've had, the master's talk on latissimus dorsi transfer. So this is more of a, reiteration of the point. So we know that posterior superior and also the tears, which actually, when you have loss of external rotation, especially when you have the teres minor involvement and also these massive tears, infraspinatus involvement, then you need external rotation for your day-to-day tasks, picking up a glass of water or even holding it or even to just brush your hair. So the latissimus dorsi transfer, it's been described as initially for the brachial plexus palsy and later has been adapted by Gerber, and this was the how he actually improved the external rotation. But we can also improve external rotation by actually increasing the momentum of the deltoid by lateralization. So, but there are specific indications for doing both. So these patients who have combined loss of elevation and external rotation is significantly debilitating. But your reverse on its own, can only, get active forward elevation, but cannot restore the external rotation significantly unless you do significant lateralization. But then that has its own problems of acromial stress fracture, and also deltoid fatigue. Because the challenges with the external rotation is that, especially if it's unpredictable if you actually are just relying on your implant alone. So you need a motor power to actually get your tendon transfer. So in a latissimus there's enough and more data now to support the use of latissimus dorsi in reverse shoulder arthroplasty to the effect of where you have to transfer them, especially if you're actually transferring them in the greater tuberosity. It has a significant external rotation torque, and also transferring them to just the lateral aspect is much less effective. So we have typically patients who have a significant loss. I think the video is not playing. Anyway, so who have significant loss and they have external rotation lag preoperatively, and this is quite debilitating for them. These kind of patients, the advantage is that you can actually go through the same deltopectoral incision. You do not need an additional incision. Identify the pectoralis major, and then there are two techniques. One is you can preserve it or just take off the superior aspect of it. Identify the latissimus dorsi. It's important not to go too medially to injure the radial nerve, and stay close to the humerus. And you do your tunnels, get your humeral stem prepared, and then do transosseous. I do transosseous, tunnels prior to inserting your prosthesis, and then get your prosthesis. Before getting your prosthesis inserted, you can whip stitch them and get your transfer. Then you actually insert your prosthesis, and finally you get your definitive implant. So the clinical outcomes, again, there are papers to suggest that there is significant improvement in the external rotation when it is combined with the latissimus dorsi. And again, different insertion points have been clearly described. And male patients actually tend to do much better. And so if you have to do only lateralization, that means that you need to have an intact teres minor, and if you have an active individual and subscapularis is intact, you can actually achieve lateralization with your implant alone. But if you actually need to actually have a significant teres minor involvement and infraspinatus, then you have to rely on a latissimus dorsi. But we know that it is not a synergistic transfer, and also they are not collinearly, it does not actually go in line with the posterior superior cuff. But to counteract the lower trapezius transfer, because there's only biomechanical studies right now available to look at lower trapezius transfer. There's not enough clinical data right now to actually use lower trapezius as a transfer. Obviously, you need a separate additional incision when compared to a latissimus dorsi transfer, because you can actually do it through the same incision. Obviously, we're using an allograft Achilles. Here we use an additional graft. You need additional like peroneus or even semi-TE2 for this situation. So there's a clear clinical reasoning to actually use a latissimus dorsi transfer if you have loss of external rotation. Thank you.
Any questions from the audience?
I think this is a question for both of you. How would you clinically choose which patient you are going to do LT transfer, and yourself, how would you choose clinically LD transfer?
So clinically, if you have external rotation lag sign, then that's one where you need an external rotator itself. So that external rotator can come either from a latissimus dorsi or from a teres. So from a patient who does not have even a subscap and your internal rotation is also weak, then I would go for a lower trap transfer. Is what I understood from what my reading.
Subscap is a differentiating point.
Yeah, I think so. Clinically, if the patient is unable to actually, hold something externally, that you ask them whether you are actually able to reach on to something below shoulder height. I mean, that itself will tell us that the patient is have. But more importantly, if the patient is able to get even up to 45 degrees and they can't actually, hold their arm up here and it drops, I mean, that would be a very clear sign that they have loss of external rotation. Beyond that, we cannot, because these patients are pseudo-paralytic, you cannot test them beyond that to have a clear testing pattern. But again, the MRIs, it's really, you can't rely on them because, even because most of these patients will have posterior superior and, superior elevation and also the teres minor atrophy. I don't think it's a very reliable sign to actually determine whether you would actually need a tendon transfer or not. It is more on a clinical external rotation lag positive.
So for the audience, you could not have a better panel than this. So what Deepthi said was quite right. The lower trap transfer will give you external rotation 1. So it will give you ER in this plane. Whereas a lat dorsi transfer will give you external rotation 2. A lat dorsi transfer will not give you ER1, it will give you ER2. So if you're like a patient like Senthil who has to shampoo his hair, you get a lat dorsi. And if you're Deepthi who doesn't need to comb his hair, a lower trap would work better because they both work a little bit differently. This is a very important, and jokes apart, this is an important reason. Second thing is what Deepthi has said is absolutely right. So I've been doing lower trap transfers for revisions for the last 6-7 years now. They're not many. There's like 1 in 2 years which I do. A reason to do a lower trap, most of the cases I've done a lower trap transfer are cases in which there's subscap deficiency. Okay, and they're cases of failed, these are all revision cases who have failed proximal humeral bone deficiency. So they have no subscap, they have no LT, they have no GT. So they have 4-part humeral fractures which have failed or have a reverse done which has failed and now they're unstable. In these cases, I use a lower trap transfer with an Achilles allograft and I put the bone block and create a lesser tuberosity from that bone block. So then this allows you to get external rotation and then the bone block helps you get bone proximally and then that pushes this backwards. But even having, Wakim and I had a big discussion about this, whether we should do lower trap primarily or we should do lat dorsi. And between, what Jean-Kenny, Wakim and I, we think that your primary transfer should be a lat dorsi transfer. Your primary transfer should not be a lower trap transfer. A lower trap transfer is a revision transfer or a transfer where your lat dorsi is not available because of proximal deficiency or it's been dissected before and the axillary nerve is stuck. So it should not be a knee-jerk reaction to do a lower trap transfer with a reverse. It's a secondary transfer. But if subscap is missing and you've got proximal deficiency and you can't do a lower trap transfer with a semi-T, because you need a big band of tissue and you need that bone block which is going to push it back. So akin to lower trap transfer for cuff deficiency, which we can do with a semi-T or a PL, for a reverse you need that big band of tissue and bone. But it does work. It stabilizes the shoulder immediately when you have proximal humeral bone deficiency.
To the panel and to Ashish, what is the lifespan of all these tendon transfers?
You mean lifespan of the
3
patient?
months, 6 months, or 2 years? How long is that going to be functional?
Now I've seen data with Ludwig for up to 10 years. If the most important thing is it's not the lifespan of the tendon transfer. The question you're asking is, if you did not do a tendon transfer, would this reverse dislocate? And the answer to your question is 100%. If you have proximal bone deficiency and soft tissue deficiency, this reverse will dislocate. So, and have the tendon transfers in the reverse worked? And do we have 10 years data on it? We have 10 years data on it. So if you execute the operation properly and the tendon transfer unites, you get a stable construct. Now the question is how much of external rotation you get from this. That is something completely different, because it's not just purely mechanical. You have to retrain the patient. You have to comply with the patient. As Dr. O has just shown, he got 13 degrees of active external rotation. And then are you checking external rotation here? Are you checking external rotation here? Are you checking external rotation there? No one in the studies mentions that. But for me, the key with this is, are they functional? So I say, is the shoulder stable? Yes. Can they get hand to mouth? Can they get hand to head? And for those who play golf, if their golf swing improves.
Thank you.
Just one to add. I mean, there's also to do with the external rotation torque, because we always talk about how much amount of whether we are restoring the lag and how much movements you get. But again, the strength, not only the rehab, it also depends upon the fixation point, it depends upon the length, and it depends upon the augment. And also, maybe time will tell whether the lower trap would be a better transfer if patient wants more strength to it and more length to.
I looked at it. So the torque, Senthil, is really variable, because Sean's here. His wife Anna is actually doing a PhD with us, and we're looking at kinematics in the Gate Lab on tendon transfers and soft tissue attachment. There is so many different variables in it. So for you to say the torque which is generated by the tendon transfer has a lot to do with how big the patient is, how small the patient is, how much you lateralize the joint line. Usually these are complex cases. So please don't put this in a biomechanical perspective. These are complex cases. They're not slam dunk cases. Often they're revision cases. All the rules of engagement are out. What you want in these cases is, do they get strength of rotation? Are they functional? So I've got strength data on all of these lat dorsi transfers and a couple of lower trap transfers which we've got. Are they giving you 5 kilos of external rotation? The answer to that is no. No tendon transfer gives you strength. A tendon transfer, even for cuff, does not give you strength. It gives you function. So all of these tendon transfers are purely done for stability and function. They're not done for strength.
Thank you for an excellent session there. Next I call upon Dr. Pratap Kumar sir, Dr. Sanjay Desai sir, Dr. Vinay Kumar Swami sir, and Dr. Rahul P. please on the stage. Next is a debate between short versus stemless design in RSA by Shirish Pathak sir and Kapil Kumar sir. Yeah. Starting with Shirish Pathak sir.
Yes. Can you hear me well?
Yes sir, you're audible.
Yeah. So when you have opponent like Kapil Kumar of that stature, I know that he's going to overpower me. But what I can say you can't strangle the truth. First slide, disclaimer, stemless reverse shoulder is not available in India. We have seen the design of humeral compound and in shoulder arthroplasty has evolved tremendously over the last 2 decades. We can classify these stems depending on neck shaft angle, onlay, flush lay, inlay, short, long, straight, curved, tapered, and now stemless. If we see the stem evolution, we are slowly moving towards uncemented and shorter and maybe stemless options. And to have a cementless fixation, we need a grid blasted porous coating, plasma spray coating, which will give in-growth, on-growth, and probably better fixation. We are aware of humeral side complication, especially of long stems, intraoperative fractures, stress shielding, stem loosening, periprosthetic fractures, and difficult extractions during revisions. What is need of short stems? I think there is significant increase in number of revision cases, especially with arthroplasty in shoulder. So we need bone preservation. We need less stress shielding, no diaphyseal stress riser. We have to have an implant which is easier to be extracted and less risk of intraoperative fractures. So how do we define a short stem? A stem which is less than 10 centimeter or which is metaphyseal only is defined as a short stem. This is a nice paper by George Atwal where he has, it's a finite element model, where he has compared the proximal humeral bone stresses and he has concluded that reducing stem length produces humeral stresses that are more closely matched with the intact proximal humerus. And more importantly, shorter stem which has got distal filling ratio up to 60% give better load sharing and less bone stresses. What are advantages of having short stem? You have improved load sharing with native bone. You have better proximal filling ratio. So you get a very good initial stability and it allows more anatomically accurate positioning. Benefits are definitely less complication rate, aseptic loosening, comparable functional outcomes to standard stem, and probably quicker recovery due to less invasive canal preparation. Radiological outcomes are also better, less stress shielding, and lower bone loss on long-term follow-ups. They are revision friendly, easier to remove, they preserve bone stock, and ideal for younger patients. Of course, limitations are if they are technique sensitive, you need good metaphyseal fit. There is some risk of malalignment, especially in learning curve, and still long-term data is still emerging. So short stems available in India, Biomed Comprehensive and Striker Perform, where they have got an option of 135, 145 metaphyseal fit collared stem and distal filling ratio, which is you can preoperative plan up to 50 to 60%. And if you go through literature, I think the short stems, they have done equally well like long stems uh, in all formats, in all neck shaft angles. And clinical results are also good, especially press fit. If we talk about stemless, they are more technically demanding. There is increased risk of scapular notching, probably because of the angle. And if you have subchondral cyst, broken metaphyseal ring, then it is very difficult to have a stemless designs. So to conclude, short stem is the gold standard in my practice. Would prefer cementing in osteoporotic bones or may go for longer or medium sized stems if required. May consider stemless in younger patient in future if my opponent can convince me. Thank you.
Yeah, I invite Kapil Kumar sir for his talk.
Shirish, I come offering peace. I will not be strangling you because, as you said, truth cannot be strangled. And a personal disclaimer, I have never done a stemless reverse. I've done stemless anatomicals for last 14 years nearly. And that is why I'm going to try and base that and probably try and present to you a nuanced view of the literature as to what is the future for stemless shoulder replacements. Pathology in shoulder arth problems is mostly in the articular surface. And unlike fracture situations, and we put in a long bit of metal in the humerus. This is not a hip replacement, this is a shoulder replacement. The forces are very different. So do we really need a stem going about 150 millimeters down the humeral canal? As Deepthi just said, I was showing him an x-ray with a cement right down up to the elbow. So do we really need it? And as Shirish just said, there are problems with stems. Revision is very difficult if you have to do it. There's a lot of stress shielding. That x-ray is within about less than 2 years if you see the x-ray from extreme my left as you see it, and the bone has just resolved because we were using a very chunky big canal filling stem. And then of course if you've got a periprosthetic fracture, a lot of these patients are older and you can have a periprosthetic fracture, or if you're a surgeon like me who does shoulder and elbows, if you have to do an elbow replacement, that's an issue as well. So why not just go stemless? And I agree, this is a lot of data that I'm going to show you is stemless anatomical, and the reason for that is there is not a lot of research on stemless reverses. But you get better anatomical alignment, the bone preserving, revision's much easy, and of course you avoid all the stem-related complications. And we've done a fair amount of work on stemless anatomical replacements. We looked at the restoration of geometry, and we had very excellent restoration of geometry with stemless replacements. And the question that everybody gets worked about is the stability of a stemless component. So we did a radiostereometric analysis where we put tantalum markers in the bone, and we looked at micromotion level movement of these stems. And apart from one, all of them had very little movement in the stem. So that shows that there is inherent stability in a metaphyseal fixed stemless shoulder replacement component. And that is why we've got good results, which we've published minimum 5-year follow-up on these anatomical stemless total shoulder replacement. The next question is, these patients are older, they've got osteoporosis. Is the bone going to be strong enough to take a stemless component? In our study, in our cohort, we had age from 52 to 83, and we haven't revised a single stemless component for loosening. And this paper by Baumgartner looked at patient under the age of 70 or more than 70, and there's no clinical difference. So the implant remains stable if you've got reasonably good metaphyseal bone. But there are concerns with stemless reverse, and I would agree with Shirish on that. The biomechanics are different. All through this morning, we have heard about the shear forces that are on the components, and the biomechanics are different. Building modularity in a stemless component is extremely different. And then you have to be very precise with your humeral dissection height. If you've got a very highly proximally migrated humerus, you may struggle to bring it down with a stemless component. And of course, you can't use it in fractures. But there is variability in design. I don't think this is a stemless component, although the literature calls this as a stemless component. This is not a stemless component. This is a short stem component. You've got a variety of fixation of these stemless components, but the literature will tell you that the results are very similar to stemmed reverse components. And the complications are similar. So there are similar functional outcomes. The blood loss is definitely less with a stemless component. And I can't explain why you get better in internal rotation with stemless components. That's what this paper looked at, that meta-analysis looked at. Maybe it's component positioning, but maybe. So in essence, stemless reverse is a bone preserving procedure which eliminates risk of stress shielding and stem-related complications. It is useful if you've got distortion of diaphyseal anatomy. We can argue till the cows come home whether this is a stemless, short stem, or whatever component. But if verso is a stemless component, then this is a stemless component. Yeah, but what I'm saying is verso in the yes, exactly. So the future is probably in metaphyseal fix components with slight diaphysis, but in younger patients with good bone stock, maybe stemless reverse has got some application as well. Thank you. So no fighting, Shirish.
Yeah.
That's nice. Yeah. That's nice. I don't have any experience of reverse stemless one, but as you said, I got a good experience of anatomical shoulder one, so I am extrapolating that one. Given a chance, I would like to do the stemless reverse. One question is not with the anatomical one, but with the reverse stemless. What are the chances of proximal resorption?
So I think what you're trying is the stress shielding, and I think the stress shielding with stemless designs depends on the mode of fixation, whether you've got a metaphyseal ring peripheral fix or you've got a big core suture screw fix. So we looked at stress shielding in our cohort, and George Atwal's group presented a meta-analysis of stress shielding, and this reported high rates of stress shielding. In our group, we had very significantly less stress shielding than that, and that paper is published. And I think primarily because our prosthesis, the Mathis one which we use, is a metaphyseal fix. It has got a peripheral fix. And we also realized that trying to undersize it by 2 or 3 millimeters, keeping it in the cancellous bone rather than just retting it against the cortex was probably one of the reasons we always undersize our prosthesis than oversizing them.
So is there any age limit you will do it?
No, we do it in all our patients in the last 14 years.
Stemless reverse.
Stemless, no, not reverses. I'm talking about anatomical. As I said, to start with, I have not done a stemless reverses yet because in the UK we just have, the test has been there for a while, but more recently Lima SMR have come out with the stemless reverse. And speaking to people who have done it, they report good results, but you can't do it in everyone.
Just one point, I think 2 points, Kapil. One, when we are looking at anatomical shoulder replacement, a little bit of varus valgus will not really matter too much in their functional outcome. So maybe stemless will work. But the whole design of a reverse is based on the angle of the humerus. So you go from 155 to 145, 147, now you're talking 135. Getting that control even with a long stem is so difficult.
Yep.
Forget about having a short stem or even a stemless. I think it doesn't make sense to, especially the Indian population, to have that. If you're looking at the recent components of Tonier which has come in, if I'm putting even the humeral component, the small one, proximally it doesn't fit well.
I think
but distally it is very narrow.
Yeah.
So it doesn't give you the varus angulation at all.
I think that is why metaphyseal fix with a small diaphyseal component is probably the best way forward rather than having pure stemless components. So even if the new striker performs stem, the diaphyseal component is very narrow and you're not relying on diaphyseal stability. You know, it's not a hip that you try and pull it out, and we'll do it in the live demonstration tomorrow. It is a rotationally stable component, but it's not a vertically stable component. I think that's the key that we have to realize, because we have seen that using big canal filling stems, you have got a huge problem with stress shielding. So I think this is probably the middle way forward. As they say, you know, truth lies halfway between virtue and vice. So this may be the forward.
Thank you.
So thank you very much, both the speakers. If I summarize this debate, both of them argued quite well with good literature search. But as far as our country is concerned, we still don't want to do so many reverses in younger population. And therefore, stemless we have to wait and watch. Maybe stemless is well established in anatomic shoulder arthroplasty, but in reverse, we have to hold our horses. Thank you.
Thank you, moderator. So next I call upon Dr. Raghunagaraj sir, Dr. Sendil Velin sir, Dr. Raju and Dr. John T. John sir for moderation. Next is a debate between Bio-RSA versus MIO-RSA by Dr. Nitesh Bhagwan sir. First will be by Adipti Nandan sir.
Hello again. Ayyappan chose the topics very well for me, but help me read a lot. Right. Bio-RSA and augments, why do we use it? To lateralize the glenoid is one, and to correct the glenoid defects. So Ashish's paper had clearly mentioned about how they can be rebuilt. The whole glenoid can be rebuilt with bone grafting. So bone is a good way of filling the defects and also reconstructing the glenoid. Bio-RSA and what do they do actually? They lateralize the center of rotation, increases the deltoid wrap, decreases the scapular notching, and more importantly, people talk about subacromial impingement, but the coracoid impingement also is less. So coracoid impingement is an important factor in reverse shoulder replacements. And enhanced rotations is what you get when you do a lateralization. You can do it with bone or you can do it with augments. So glenoid defects are a challenge because they come in various sizes. Precious real estate of the glenoid, so varying sizes and varying shapes and various angles. Most importantly, the Indian sizes. They're very difficult to match with our Western augments. Not few sizes will not fit everybody when it comes to the glenoid of the Indian patients. So small glenoids challenges you have are this. So this is one patient who had a very bad looking glenoid, but there was so much osteophyte, big lady, she was 5'4", I could do this for her. A similar one, 4'9", that lady has that much of glenoid, hardly any bone, the smallest component is piercing out everywhere, so very little margin for error, and very difficult to reconstruct that with a standard size fitting to everybody. So when I do the planning, only 19% coverage, but I managed to do it somehow. That is using my intuition, my surgical skill, I could just push it in, but still very hairy. Bio-RSA benefits: bone graft restores native bone stock, and once incorporated, it's normal glenoid. So you're actually increasing the normal bone on the glenoid. So if it fails, you still have some bone to play with. So conforms to the defect, better contact area, and it's good. So if you look at this example where there is a bit of a posterior slope, that's the contact area. The head has already conformed to that glenoid. So if I cut that bit of bone off, it will sit perfectly into the defect like that. You ream it and you get a normal looking glenoid, get the light version, the version is corrected, and you get a well placed glenoid component in. So we can customize it to the sizes, and it can customize it and it heals better. When you use augments, you need to ream it. If the reamer is in the wrong place, it reams the wrong part, and then you will not get the right seating. And then shaping it is difficult, and many a times once you have put this in, you cannot see the posterior part. So you cannot appreciate how much of it is actually sitting on the glenoid itself. So bone is better than augments when it comes to glenoid rebuilding. And if you unbalance it properly, the loading is bad, it fails. So don't tell me I didn't tell you. Two surfaces need to heal is what we all criticize the bone for, but shear forces on the base plate is what we criticize it for. But actually, because you have a wrap and you have a compression with torque coming onto the glenosphere, there is compression, so it actually causes better healing of the bone. So quality of bone is always a problem, but we get good quality bone from the subchondral area of the humeral head because it's sclerotic. So graft healing, if you look at it, 95% some series, 100% in some series, and graft non-union appears to be rare, and proper technique and secure fixation will prevent that. If you look at Ashish's paper, he used allografts, and he's also shown 92% healing, but a 50% rule needs to be followed. That means good contact of the bone onto the native glenoid is important. Systemic review comparing bone graft versus augments. Overall complication rates are similar. Overall revision rates are also similar. No major differences in the outcome. Randomized trial shows this, and Bio-RSA patients had significantly better external rotation. So real test for a technique is longevity. The highest follow-up is for 5 to 10 years, Pascal Boileau's, very good survival and good graft integration. It stood the test of time, and we are here to use it, a low cost, locally available substance which can increase the bone on the glenoid side, and it conforms to the defects and rebuilds natural bone. Thank you.
Can I get the other talk, please? Thank you. Good afternoon, and thank you for staying for the late afternoon session. I'm not going to discuss too much on lateralization. That's been talked about quite a lot. I can't challenge any of the results on the Bio-RSA, but maybe I think it's just important to introduce a few concepts when it comes to metallic offsets. So we know that erosion is common. Glenoid deficiency occurs in several common patterns, and there's many ways of achieving lateralization. Through the glenosphere, through lateralized glenospheres, Bio-RSA or metallic increase offset. Bio-RSA has been around for 10 to 12 years now, and the results are stunning. When you look at metallic lateralization, it's an alternative option to try and deal with some of the requirements for reverse shoulder arthroplasty, where it might give you some options is when the humeral head is not available for use, where there's osteonecrosis in the setting of revision surgery or where in the setting of fracture sequelae. This has already been alluded to in the previous talk. There's always the risk of bone resorption and stress shielding with a biological graft. Piolo is the developer of this technique, and his results generally show good graft healing. But if you look at other literature from independent settings, graft resorption may be in the region of 20 to 25% with the potential risk for base plate loosening. We know that to shape an allograft or an autograft can be technically challenging, and sometimes it might be difficult to find an appropriate bone source. What is quite important is that when you have using autograft, you get very good bone healing. But in the setting of using allograft, incorporation rates are much, much lower. So many options available for metallically increased offsets. You can lateralize using the base plate, or you can lateralize using the glenosphere. I'm not talking about necessarily increasing the size of the glenosphere. We know that increasing the size of a glenosphere, so if you go from a 33 to a 36, the amount of lateralization achieved is only 1 millimeter. So I think just keep that in mind. Upping the size of the glenosphere doesn't achieve true lateralization. So when you look at some of the advantages of metallic increased offsets, Atwal has shown that it can be technically challenging to shape an allograft. And if you use a metallic offset implant, you can have a faster operation and maybe less blood loss. Denard has shown, and this is a finite element study, that bone density may play a big role, because in patients who have, when you're adding a bone graft, there might be early micromotion. Again, age, larger patient females, your quality of bone graft may be not as good, and there's always a debate around healing and viability in these patients. Frankel developed this glenosphere where he lateralized a lot, and he built this lateralization into the actual glenosphere, and the idea here was to reduce the amount of scapular notching that you may get. But in his situation, the base plate still needed a lot of reaming. I'm sorry, that's gone off a bit now. But in spite of Frankel's design, where you may still need it to ream the good side to get good achievement, his clinical results have stood the test of time. There are some disadvantages to metallic offset. There may be a cost issue, but generally the base plates don't cost more. The only time where there may be some additional costs is they are coming, patient-specific or shoulder-matched base plates are coming out. These generally take a longer time to manufacture. They're available generally only in the US now, and they cost about 25% more.
Dr. Bhagwan, could I request you to conclude, please? Just
final thoughts on
Okay, sorry, my final thoughts. So in summary, the metallic increased offset eliminates the need for reduces the risk of graft absorption. There's fewer micro motions with metal. It's less technically challenging, reduced blood loss and operating time, and there's less concern where there's reduced bone density. So I thank you for your attention.
Thank you very much, Dr. Bhagwan. So one question to Dr. Bhagwan. So in terms of this pre-operative planning, I mean, you obviously mentioned, do you routinely actually use metallic augments even in your primary cases, all of your cases, or is there any specific, scenarios you would actually, use the, lateralization with bony augments, or is it only in revisions?
So our population size is a little bit different. We have our patients generally on average tend to be taller, and I will almost routinely use a base plate that offers 4 millimeters of lateralization, and the idea there is to try and reduce the risk of scapular notching. I also look at quite carefully on my planning software to look at scapular neck length. If the patient has about a reasonable amount of scapular neck length, then you can reduce the amount of metallic lateralization needed because the risk of notching is less.
Thank you. And question to, yeah.
Dr. Dipti, question to you. Just in case in those patients where we know that we do this for elderly osteoporotic patients, and if you're not happy with the quality of bone, like some of the x-rays we have seen earlier also, grossly densely osteoporotic, in these patients, would you still want to prefer to do a bio-RSA, or would you want to go with metallic lateralization?
See, however osteoporotic they are, if you look at the head, they are usually sclerotic because that is the part of the bone which is very hard, and that is where you could use that part of the bone. Obviously, if it is very soft, crumbly, like in an inflammatory arthritis, then you should go for a metallic augment itself.
Iliac crest, if in case you had, that's one question. And second is shaping even as you showed, in that case it was a slice of bone, but a lot of times if you have arthritis, you have a good chunk of bone. But I don't know, at least any company offers the core reamer what Pascal has. I don't think we have it here.
Tonier used to offer, but some of our surgeons here, they have got their own corers. They have created that, with the companies here locally.
So Arthrex is offering a core reamer, and they've actually got good reamers customized for preserving the high side of the bone, so you don't ream too much of the good bone away. I think the core reamer is available now.
Now it is, yeah. One question. If you listen to our knee guys, they moved away from bone to metal, and it's well established there.
So they use a lot of cement and they put the screws to hold the component and all. The biology and the mechanics of the knee are totally different from what the shoulder is. I think, like sir, for example, when you're doing an anatomical total shoulder, we don't put any cement behind your poly.
True. But in fact, the knee will be more load bearing. Therefore, the argument in metal augments in the shoulder is even higher. Because the knee people have moved away from bone and more of metal augments.
The advantage with the knee guys is they can see the whole knee 360 degrees. We cannot.
Okay. Thank you very much. I think in conclusion, from all the clinical evidence presently showing that actually the bio as well as the metallic augments, the results are similar. But again, in India, a cost factor would be actually even more significant.
Can I make two comments? So, in my practice, if someone is young and they're going to have a revision, they get bone. Because I want as much bone stock in real estate as Deepthi was suggesting. If someone is 85 and they're crumbly and you think that this implant's going to last them out and you can get away with a quicker operation with metal, use metal. The key bit here is I personally don't ever use the reamers which the company gives me. You need bleeding blown from the glenoid, so I use a hand burr. Sometimes what happens is if you use a reamer and it's really sclerotic and it jams, you break the glenoid in half. So whenever I bone graft, I always use a hand reamer. And that way you can get good pepper pot bleeding for bone graft or for metal, because you need bleeding for this to incorporate. So those are my two tips.
Thank you. That was an excellent debate. Now calling on Ashish Gupta sir for two more talks. This is on complications in RSA and fracture stem RSA.
Okay. It's not 5, it's 10. Yeah, I can't do in 5. Okay. So this is what's coming. Every possible known complication to man is going to happen if you're going to start doing reverses, and unless you can deal with the complications, don't do the reverses or send the complications to people who are happy to deal with complications. And my practice has become dealing with this now more and more. So we get x-rays like this. The screws were not put in properly just because there was significant glenoid bone loss. And they could not get fixation. Implant size was too big, and this failed within a year. And this is a glenoid which we've got now. The coracoid's broken apart, the acromium's almost breaking, and there is no glenoid left. So, I'll talk about planning and what needs to be done to reconstruct stuff. So this was one of my cases. We did an allograft for her, and I've allografted her, and I'm going to go back and revise her in 6 months. So what is the reasons for revision? The number one problem for revision for everybody is instability. So when you're going to start doing reverses, you are going to have instability, and surgeons who do less than 30 reverses a year have the highest rate of instability. Infection is a problem none of us can fix. Loosening is a problem if you're not doing this operation properly, like that case I showed you. Otherwise, loosening is not a problem unless your patient is on derazantinib. Periprosthetic fractures you can't control, but basically the fracture in a reverse is the humerus. This is what the Australian registry shows. It's not the glenoid. And the other big problem, in my experience for me now in a reverse, is neurogenic pain because of excessive lateralization of the glenoid. So I'm going to bring the same case again: acromial stress fracture, stress shielding, and notching. Okay, it's not a hip. These are some of the revisions from this year. The Tournier revision stem's not very good, unfortunately. People tried to do a short stemmed implant in this case, and that failed, and then left them with a girdlestone. You got tuberosity escape with an onlay with a huge lateralization. You see there's a huge bone graft here at the bottom. In a reverse case with a fracture, they've lateralized it and the GT is escaped. In the case on the right, kind of everything's gone wrong. So for these complex cases, that's why we build Reflect, is because when the going gets tough, you need all the help you can get, and preoperative planning will become more and more common once you start doing these revisions. And looking at humeral length is really important. The key is how to avoid it, and we need to stop talking about inlay and onlay. We need to personalize every patient. We need to talk about an anatomic RSA, which is going to preserve bone, going to restore joint line. You're not going to lateralize too much so that your axillary nerve's okay. As Kapil was just saying, we're going to use hybrid humerus, which is metaphyseal fixation with bone grafting. Look at my diaphyseal filling ratio here. It's less than 0.5. I'm going to repair the cuff. So I'm just going to show you how to avoid, if we can avoid this in a primary. So this is, I use the Medacta system, but you could use this with any system. I've been bone grafting now for 10 years. A paper is going to come out on this again, which is showing minimum 5-year follow-up. This is the smallest stem they've got. This is a size 6 stem. I use the humeral head. Even if I've done a bio-RSA, there's still enough there. We pull the head up, and we're going to pack graft into this like crazy. So I'm pushing that in. You can see my stem still sitting super proud. And then I'm using a Cobb's elevator, and I'm just going to pack the metadiaphyseus with graft. And what you want is, when you've packed it with graft and you push your stem down, I'm pushing my stem down with my hand. My stem is inherently stable. You see here, my stem is inherently stable. That means I've got enough graft there. And now I'm going to drive this home. And there's no force. I'm just using the weight of the mallet to bring this thing home. We're not trying to bash this. So it sits off like that. And I wait for a stress shielding. So there's a bit of stress relaxation, both for the bone and the surgeon. And then you get the stem in. What will happen is, and this was a very small patient, you see if I hit it too hard, I wanted to show you my complication. There, I broke the calcar. And if it's just a small calcar break like that, I'm going to leave it because it's a metadiaphyseal fixation. I'm going to put one circular suture and leave it. But generally, don't hit it too hard. If you're going to hit it too hard, you've packed so much of bone on this that it will break. So this is the kind of result you get. You get a significant, this is a bio-RSA with significant grafting both on the glenoid and the humerus. My biggest problem now in reverse is if you lateralize someone too much, they get axillary nerve pain. And nerve pain and brachial plexus stretch, especially in the Indian population and the Asian population, is a big problem with lateralization. And they're not infected. People will come and they say they can't get their arm above 70 or 90 degrees. And if they have persistent pain, that means the axillary nerve goes with the glenoid. The axillary nerve gets stretched if you lateralize too much. It's got nothing to do with an onlay humerus or if you're distalizing or lateralizing the humerus, because it goes under the neck and it goes to the deltoid. So I'm very, very pedantic about checking the nerves, especially in revisions and even in primary. The patient who really scares me is this little old lady who will come to you with a head rising up here who's got cuff tear arthropathy. That is one thing in life I'm more scared of than my wife and my mother-in-law, is this lady walking up to me in the practice. So axillary nerve pain, this is the axillary nerve. You need to do a neurolysis of the axillary nerve and you got to avoid excessive lateralization. Look at this case. Proximal humerus fracture, augmented base plate use, excessive lateralization. You never lateralize in a proximal humeral fracture because you want to repair the tuberosity. Look, the tuberosity is off. They tried to use a fracture stem. This was done by a very good surgeon. The fracture stem was too big. It didn't fit the population. Then they had to use an ascent flex. Stem's not in the right position. Tuberosities escaped. Tuberosities completely escaped. And now this is the situation in 6 months. Okay, a lot of this could have been avoided. Unfortunately, the implant size wasn't right. So the key here is to evaluate the glenoid and see where the joint line is. A case like this now, dislocation arthropathy in the elderly, use statistical shape modeling to figure out what normal is. I have access to femoral head allograft. So this is a femoral head allograft and this is a figure 7 graft. It's a very good get out of jail procedure. And you can get a very stable construct with this. Implant malpositioning is another problem which we can avoid. I've seen a lot of x-rays all over the world and base plates are being put too high. To me, this means that the surgeon hasn't been exposing this case properly if the base plate is sitting that far high up. This is completely an iatrogenic problem which should be avoided. We've talked about bone defects. I'm not going to talk about that. But basically, we got to reduce the normal joint line back. And in my hands, I would bone graft it. Does bone grafting work? You know, this is some of my work. We've got like 8-year outcome data. This is bone graft 5 years post-op. Look at the graft. It's completely incorporated. A case like this where I use this figure 7 graft, this is the stability you get on table. So for me, if it's a young patient and I know they're going to need a revision, and if I need a bigger graft, I would actually graft them because I can customize it to any shape or size I want, which you can't do with a metal augment. So if the implant is not in the right position, you need preoperative planning. That's why we built Acuna and Reflect, because we're the only company in the world which can do it with implants in situ. So you get defects like this and you can restore function. So to conclude, soft tissue reconstruction is the cornerstone for a reverse. Bone preservation and augmentation, please do that so that you can avoid a revision. Planning is really important, and avoid excessive lateralization in India to cause axillary nerve pain. I'll stop. Still have 1 minute to go.
You mentioned primary situation and also revision axillary nerve. So how do you test for axillary nerve tension? I mean,
yes. So a very good question. So the way I do my reverse is I will dissect, you peel off your subscap, you cut your SGHL, MGHL, IGHL, cut everything at the back. You've got your retractors. I release the triceps completely. Then when the humeral head's cut already, I will know if this joint's really loose or if this joint's really tight. I want to restore my joint line to 0. So if there is medialization, I would either lateralize based on bone or augment or the taper of the implant. And if this patient's a small person and the joint's loose, I'm not going to over lateralize it. If this is a 6'4" South African Boki rugby player guy, then they will need lateralization. Then you put your glenosphere in, okay? And when I put my glenosphere in, after that, I feel my axillary nerve. So I look at my axillary nerve in every case. I hardly ever trial. 99% of the times I don't trial. Then what I would do is, I've got my glenosphere on, and then I will bring my humerus back, which is cut. And if I can put my finger through that joint and it's loose, that's going to be an onlay implant for me. With my glenosphere there, if my humerus comes and I can't get my finger in, it's really tight, then in that case, it's going to be an inlay implant for me. Okay? Once my construct is finished based on onlay or inlay, at the final step, we're publishing on this. It's called the nerve glide test. So I put my finger on the axillary nerve and I flex the arm to 90 degrees. The nerve should be loose. Then you bring your arm back to 30 neutral. The nerve will get tight. And then when you extend the arm, the nerve goes under the subscapular neck and the nerve will be loose. And that's why if you have a long scapular neck, it's really important you have a long scapular neck because the nerve has to go down. So loose, tight, loose. If your nerve is tight throughout the range of motion, you've overlateralized.
And have you had any instances where you had to revise because of axillary nerve pain?
Yes, I have had everything go wrong on the planet which has, and I've had patients who are little old ladies and I've put 39 millimeter base plates in them, and stupidly some of them I used an augmented base plate which lateralized too much, and I've had to go down and downsize the glenosphere, and the pain within 24 hours disappears. So nerve pain is a very big problem in reverse shoulder replacement which is underreported.
So, thank you very much, Dr. Ashish. I think any questions?
Next talk by Dr. Ashish next.
Yeah.
Okay, so we have a defer concept. Majority of the reverses done in the world, I believe, are because of failed proximal humeral fractures. And a failed proximal humeral fracture reverse is not a primary reverse. It's like a revision operation. So, is a proximal humerus fracture, what is an acceptable outcome? So in this lady, this is how I started. I would do this operation and she's had a reverse after a proximal humerus fracture. And did I actually help her? I don't think I did. I think if I did a non-operative management on this patient, she would probably have a better result than what she's got right now. Then what did I change? I changed my way of doing it and I started getting outcomes which look like this time and time and time again. Okay, look at the external rotation. If you don't repair the tuberosity, you will not get external and internal rotation. So there's enough evidence to suggest that in elderly people, a reverse is the way to go, and we should not be fixing them above 65, and I'm very firm on this. And I'm happy to debate with Dr. Desai on this later. It's still amongst the top 3 causes of RSAs done in Australia. And actually, if you look at the revision rate at 10 years, the revision rate for a fracture reverse, if done properly, is same as osteoarthritis and lower than cuff tear arthropathy. So it does not have a higher revision rate. Similarly for younger patients as well. Okay, do you need cement or cementless? The jury's out there. Initial data, if you look at the 7-year data, it showed that the cemented stems were doing remarkably better than uncemented. I've always used a cemented stem, but now the data has suddenly changed. So what's my approach? I delay surgery. So I wait for at least 2 weeks. A proximal humerus fracture to me is like a pilon. You were not going to go and operate on an ankle fracture straight away or a pilon fracture straight away. You're going to wait. The tuberosity attachment in a fracture is completely different to what it is normally. And then we put them in a brace and then we start immediate rehab. So we're going to start with step number 1. I wait for 2 to 3 weeks so that we have better soft tissue healing in it. And this allows me to get my tuberosities repaired properly. So we delay the surgery. I want a little bit of callus to form so that we can attach these tuberosities properly. Second is functional tuberosity reattachment. And I use functional tuberosity reattachment not only for fracture reverses, but for all my revision surgery as well. So what needs to happen is your LT with your subscap needs to be repaired in external rotation. So I put my arm in external rotation, 40 degrees of external rotation, and I get my lesser tuberosity down with the cobs where it needs to sit. I don't pull it with the sutures. Then I put my greater tuberosity, I put my arm in complete internal rotation. So my arm's on my tummy when I'm doing this operation. and then you use a COBS, you elevate your GT and you push it down. You're not pulling the GT, you're pushing it where it comes. And this suture configuration, you always have to have sutures which go from bone to implant to tuberosity. And I will show you this in the live surgery tomorrow. And then what will happen with this is you've got the GT in complete internal rotation and LT in complete external rotation, and you will have a gap. You have to have a gap. Our tendency is to pull these tuberosities together so that we can see laterally they're back together, and we're over tensioning them. And then this gap, I bone graft the humerus. You do not want to lateralize the joint line. The glenoid is completely normal in a fracture reverse. If someone's fractured it, they don't have osteoarthritis, because if they have osteoarthritis, they'll have a humeral shaft fracture. You want minimum lateralization in the glenoid because you want the tuberosities to come back. So this is my fixation intraoperatively. This is what I want. I want my GT to be completely healed. I want my LT to be completely down. There's bone graft in between. And you see I've got full internal and external range of motion. You need to get complete range of motion. Then I put them in a brace. And what this does is weakens the adductors and so that they can get better scapulothoracic movement. And then we start immediate range of motion. So this is a case, 4-part fracture. This is it immediately. This is it in 3 months. This is her at 6 months. 90% of the patients in our cohort are all women compared to men. This is the tuberosity at 1 year. This is the tuberosity at 2 years. Complete healing, no stress shielding. If you look at our results of 50 patients now, our range of motion is one of the highest in literature, is 150, almost 150 degrees. And look at the external rotation, 44 degrees of mean external rotation. 100% of cases we've had tuberosity healing. So if you look at the difference between defer and no defer, I did the same operation to this other lady, but she could not comply with the rehab. And if you cannot comply with the rehab, your outcome is not going to be as good. Your elevation is going to be only 120 degrees and your external rotation is not going to be there. So the R part of the defer approach is really important and the rehab is really important. So this is the difference in outcome at 6 months following step number 1 versus not following step number 1. And there's multiple factors why some people can do it, can follow the rehab and why they can't. But you have to counsel your patients. If they don't rehab it, they're not going to get the outcome. So I'll stop at this. So our 2 predictors for poor outcomes was if you had a failed prior ORIF and you were less than 80 years old, your outcome was worse. And if you did not comply with the rehab and you were over 80 years old, your outcome wasn't as good. In these cases, we have the planning software and I use it a lot. Failed reverse proximal humeral fracture is a very complex operation. I did one last week. Took me 6 hours. I cut a branch of the axillary nerve. I had to do an intraoperative nerve repair. They're stressful operations. They're complex operations. And whatever techniques you can get to make this a bit easier, do it. So in conclusion, it's given very good outcomes in my practice. Rigid tuberosity fixation, early range of motion, and those who did not follow the rehab did not get the outcome. Thank you.
That's a great talk. One of your slides mentioned that at 3 months you had practically 100% tuberosity healing. That's fantastic. But in the post-operative period, when you follow them up, say 6 months, 1 year, do you feel there's some kind of resorption of the tuberosity or it just stays there?
No, so we've got. I haven't published this paper till date because no one will believe me unless I showed you 2 to 5 year results. We haven't had any tuberosity reabsorption.
Great.
Sir, excuse me. Sir, in a trauma RSA as you did, so what are the tips for a humerus placement? That is, whether it goes down, how will you calculate the level of
Very
the
good
humerus?
question. So I cannot use a trauma system where the glenosphere doesn't have a hole in the middle. So for me, the glenosphere needs to have a hole in the middle. And what I do is my stem, which is, it is not an onlay system. It should be a Grammont kind of a system, inlay system. My stem, the height of my stem sits at the circle of that glenosphere. So when I'm cementing my stem and I'm pushing my stem down and I have my retractors, the height has to be at that circle. And when you reduce this, it will be loose. because so the biggest mistake which people make is they keep their stem proud because they want to reduce this and they want it to be so tight that it doesn't dislocate. That's wrong. You're over lengthening your humerus and your tuberosities will not come. So I use the equator. Height is at the equator of the stem. I reduce it. It'll be an easy reduction, and then once you've repaired your tuberosities, it's solid.
Okay, thank you.
Question, Ashish. Nice work. So first is I have stopped plating fractures of proximal humerus above the age of 50. I've lectured across the country and overseas. I've published it. It's accepted last month. Now, question is, in what percentage did the tuberosities heal so beautifully? You have the number?
My case series, 100%. You won't believe me. I'm going to actually put all my cases online.
Is that published?
We're publishing it now because I wanted minimum 2-year follow-up.
Because that is not the percentage even with the French series.
I agree, but they don't do the defer. They don't do functional tuberosity reattachment. Everyone tries to push the tuberosities so that both the tuberosities meet. The functional tuberosity reattachment was taught to me by Seebauer, and it heals. And I bone graft a lot of it, and I'm not using an onlay system, and I'm not lateralizing excessively. So in our case series, we've had 100% tuberosity healing.
That's interesting.
So I will submit the paper because it's completed. JCS and JBJS will see where it goes, but we're going to put the whole database online so that everybody can see every X-ray and every case, so that everyone can openly see it.
Just one question. If you are using your onlay system, this one is what angle is your?
So all of them are Grammont.
Grammont, okay. That's why you have less tension on the cuff too.
Yes, you can't use an onlay system for a fracture. I firmly believe in this because you're lateralizing and then lateralizing more. Your tuberosities are not going to heal.
Because if you do that on a onlay, you cannot, because the tuberosity is not going to go back.
No, 100%.
So it has to sit this side.
Correct, and then they don't heal.
If you have the tuberosity on a more posterior part, it could impinge and cause a dislocation.
So that's the case of Ascend-Flex which I showed, which failed. Augmented base plate with Ascend-Flex onlay system with tuberosity, you have escape with it. And if the tuberosity is going to fail, it's going to fail within 6 months. Because if it heals, Nilesh, then it heals. If it's going to fail, it's going to fail within 6 months.
Just one final question. So you said bone grafting. You showed us that you actually bone graft the humeral stem. So do you actually graft in between the tuberosities as well?
Yes, put bone, tuberosity to implant, tuberosity to bone, and then put graft tuberosity to tuberosity. You just mulch the humeral head and in big chunks, and it just goes everywhere.
Okay. Thank you very much. Thank you.
I think, Ashish, just before we go, probably we've got very similar outcomes for fracture reverses with you. And I think the key point is using a specific fracture reverse prosthesis. We always use the Gramo, but also the ones that have got holes in them to fix it. So I think our results exactly like you. Great functional restoration in all our group of patients who are back living independently, which is very important in the part of the world where I work. With people living on their own, so restoring independence is a huge thing. So I think that's quite important.
Thank you for an excellent discussion, sir. Now we are in the era of preoperative planning. So moving on to preoperative planning, now I invite Dr. Kapil Kumar sir for his talk on blueprint planning. He'll be showing a case of how to plan. The moderators are Sandeep Birari sir, Tirthyas sir, Anil Patil sir, Preetham Nagaraj sir.
Thanks very much. I think as we near the close of play today, probably we need to keep everybody interested. So we've heard all through the day about the importance of planning. And I think I will not go through a lot of these slides. What I'm going to do is I'm going to jump onto a case just to take through for planning using the blueprint system. Yes, there are other systems available. But the bottom line is that when you are faced with a very complex case with a lot of glenoid wear, maybe a revision scenario, and which becomes a nightmare on Elm Street, you don't want to be getting lost on that nightmare on Elm Street that day. So you need to find your way. And that is where your planning comes. You fail to plan, you're planning to fail. So I'm just going to come out of this here, and let's see if I can just, so this is a 79-year-old lady who has got cuff tear arthropathy, significant glenoid erosion. Not the worst case that you're going to see, but you still want to plan as to where you're going to put your prosthesis in, whether you're going to use bio RSA, whether you're going to do metal RSA, what kind of glenosphere you're going to use, and where your screw is going to be. And if you just scroll through the, so those of you who haven't used this system, you just upload the CT up to the Stryker system, and then it appears in your own individual login. You open the case and you can scroll through the axial and the coronals, and this is where you have got the 3D implant. So on the left hand side you've got a menu of implants. So let's say we're going to use a standard base plate. And if I put a standard base plate as to where it is, I've got less than 10% bone contact, as you can see here. So either my options are that I ream significant immediately, which is not going to be ideal because you're going to lose a lot of bone stock, or I start putting some offset here. So let's say I put a 6 millimeter augmented base plate, which is a complete 6 millimeter, not a wedge, it's a complete 6 millimeter. My bone contact has improved to about 57%, which seems reasonable. If I use a central screw, and I've got a 25 millimeter screw, and I've got a screw length of 23.8 millimeters here, and I move it around, I'm just getting, and this is what Deepthi was alluding to earlier about bicortical purchase to get that compression. So if I just increase the screw size to 30 millimeters, I've got a slightly more projecting screw, but I've got better compression. So then again, it's for you to decide which one are you going to go with. My bone contact appears to be reasonably okay. Ashish told us that you should have about 5 millimeters of gap at the top to get a bit of inferior tilt. I've got that, but my inclination is still neutral. You can increase the tilt if you want to. With this system, I don't tend to put them in inferior tilt. I've got lateralization. I put in a 6 millimeter offset, and I've got a 135 degree neck shaft angle, so I don't tend to put them in inferior tilt, but you can do that. Now, you've got the ability to see whether you want to put let's go a little bit more medial. Okay, we ream half a millimeter more, we've got 61% bone contact. We don't have that gap between the upper edge of the base plate. And you may think that the screw is now projecting out a bit, so you can go back to 25 millimeters. And I put in a 36 millimeter glenosphere here, and you see I'm just along the lateral edge of the acromion, which should be the aim when you're trying to lateralize it. As Ashish said, don't over lateralize it, but you want a bit of lateral offset here to restore the joint line. So that gives you the glenoid, and if you're happy with it, you can keep it there. Then we can go on to the humeral side. Let's put in a size 1 component, which you can decide. It should give you the distal fill ratio, which is somehow, on this case, it's not showing up, but it should give you what's your distal fill ratio, but that again, you can look intraoperatively as well. And then you can go on to the joint articulation. If you ask me honestly, that's a bit of a gimmick that you play with because you don't have the soft tissues here. You cannot rely on what abduction you're getting, what adduction you're getting, but it will tell you if you've got a significant conflict. If let's say your adduction was about 0 degrees, that means you've got a huge conflict and you should probably maybe need to rethink. But all these things are good. They give you a nice little motion, but that is not real life. So don't rely on this too much. You can go back to your glenoid. You can look at where you're going to, the drill guide. If you take the component out, that gives you, and if you, as Deepthi earlier somebody asked the question, how do you execute this intraoperatively? And there's a little tool here. You can pick up a point here, and you pick up a point here, and you can measure the distance. Sorry. So it allows you, the system allows you to measure the distance from the front to back, and that gives you a rough idea where you're going to go. And sometimes you are faced with a very tricky case, like I was with this guy with severe retroverted glenoid, where I managed to plan that I'm going to use a big full wedge, but when I went in, I could not anyway put the guide in because the glenoid was just facing right the way back. But because I'd got my measurements, I could just put in a freehand drill pin in there and get my wedge reamer in. So that allows you to get to the intraoperative drill. Unless you've got a PSI, that's what you give you. You can measure the distance between the front and the back of the glenoid to the center point, and you can put your guide wire in. So I found it very useful. It is a guide which helps you to go where you want to. It is not, and when you put in the screw and you get the correct length as you would on a plan, you know that you're on the right path and you've got your positioning. We will share the experiences that we've had to perform in the next talk, but overall component positioning is really helped with pre-op planning. Any questions? Yes, sir. I would love to hear your comments.
Yeah.
And I fear as well.
My only grudge is that I need to have something other than a PSI to make sure that I don't have to eyeball. It's so difficult to measure, putting a scale inside that glenoid and measuring 6 mm and 5 mm. I wish I had a tool which allows me to execute that.
Yeah, I think you're absolutely right. I know where you're coming from.
And the PSI takes 6 weeks.
Yep. So I think you're right. It is the planning to the execution, which is a challenge. But till your system has got all the tools, and that is why we aim to get a utopian, all-encompassing tool, which will come, inshallah, one day. But at the moment, this allows you to do it. And as I said, it is really useful for when you want to plan whether you're going to use a wedge, how big a wedge you're going to use, where you're going to position the wedge. And once you've got the wedge, and then a man of your caliber can put a guide wire anywhere. So you don't need to say that. But jokes apart, I think, as I said, in that severe C glenoid, I was able to position the guide wire in the middle where I wanted to. And Deepthi and I were discussing this. You put your finger along the front of the scapula, you aim to get your guide wire in just there for your bicortical purchase. But the system allows you to measure from top to bottom and side to side as to where you will go. Yes, there are other systems available. No system is foolproof, but this is my experience with Blueprint.
One question, Dr. Kapoor.
Lateralization, the original glenoid level is very important, and also inclination. We have to choose the inclination. So trans-axis is very important. Which axis do you use, and then how do you the original glenoid level? How do you choose the glenoid level?
Yeah,
the lateral amount of the lateralization.
So let's say we are here. So you look at the axial and the coronal scans, and you're trying to look in the middle of the vault here. And that is what gives you the line where you're going to go. That is what my landmarks are on the axial and the coronal views.
The y-axis or y-axis or the supraglenoid level, which one?
Sorry, I didn't get.
In this program, how do you choose the axis, the y-axis or the supraglenoid level?
So that is my horizontal axis. So that is the middle. And from here, I draw my axis from the top to the inferior part.
I mean that y-axis.
Here?
Yeah.
Okay. So as to where should I put my guide wire in? So that the system is doing that for me, because I'm trying to find the best purchase for my screw. My central screw, Let me just put the prosthesis back in. So if you now look here, my central screw is just coming out in the vault. I have got no superior or inferior tilt here, and I have got neutral version. But I can change the version to get a better purchase of the screw if I want. And now the system decides for me where my central line is.
And does the system allow to plan for bio-RSA as well?
Yes. I was told not to do it because I think the BioRSA kit is not available in India, and I think I was told by the Striker guys that the blueprint software that is available here does not allow you to calculate the BioRSA wedge. But I can show a case where we have got, it allows you to measure the BioRSA wedge as well. And hang on, it must have. Yeah.
I think we are running short of time,
All
Dr.
right.
Kapil, so we'll move to the next talk by.
Thank you.
Thank you very much. Thank you.
Which one do I take?
Oh yeah, I think this one. Take it.
Thank you.
Thank you, moderators. Next set, Dr. Prem Menon sir, Dr. Rajiv Raman sir, sorry, he's not there, Dr. Kiran Chauka sir, Dr. Suresh Perumal sir. Dr. Nitesh Bhagwan sir is going to present about VIP planning of Arthrex for the next 10 minutes.
I'll try and go a little bit faster this time. I think the principles of the surgical planning is exactly the same as Dr. Kumar's blueprint presentation. I think the only difference we may have to offer, if the system has to offer, is that it does give you some option to translate your surgical planning into an intraoperative guide pin placement. So the idea is to try and optimize your positioning and fixation of your glenoid plate. Traditionally, we've eyeballed or relied on our own internal compass or experience to place that plate. I'll go quickly through this. There's many companies offering this sort of service, and there's many ways to enable your surgical execution. Off-the-shelf instrumentation, PSIs, augmented or mixed reality, or even the new kid on the block, robotic surgery. We know that there's definite benefits to surgical planning and navigation. It's highly reproducible and it's superior to previous methods. There's many papers that show improved results, and there's good agreement between surgeons in this regard. So we really can try and achieve the rule of 10, except 10 degrees of residual inclination and version, and we can correct 10 degrees without too much of bone loss. We know that if we just look at x-rays alone and eyeball the guide pin, we generally can get to within 11 degrees of where we want to be, and it improves significantly if you use a guide. So VIP essentially uses CT that's uploaded to Arthrex's server. This information then is transferred to the Arthrex technicians, and you get back some guidance which then facilitates your guide pin placement. After you've uploaded the data, you get a temporary plan from the Arthrex surgeons. You're not beholden to those markers. Ultimately, you can adjust just the way a blueprint is adjusted for final implant selection and placement. Once you accept the plan, you get some final markings. Originally, there was some option to produce a 3D model, but that takes quite long to develop. So there are other options out there: PSI, augmented reality, the robotic surgery. But with VIP, I think the big advantage is this transfer technology, where you're able to transfer your surgical plan into intraoperative guide wire placement. So this is what your picture would look like. I'm not going through everything, but essentially you can look at screw ends, you can move your base plate around, you can look at your backside seating. Sorry, will you play that video, please? And you can play around with all of these variables to try and get, if you really start to trust the system, you can measure your screw lengths, measure your central screws, and try and set up your implants as even prior to surgery. Something new that's been added to the system is humeral planning, but beyond sizing, there's no other advantage to the humeral side of the planning. Something that's also a new addition is the ability to map out your osteophytes and then surgically, digitally extract them. And that might give you it gives you a better assessment of the anatomy that you might have to deal with when you are doing the surgery. So that can be done on the glenoid side and the humeral side. And as alluded to by Dr. Kumar, will you play this video, please? The system also now allows you to do some range of movement, but I don't know what the true value of this, because it might not translate into real-time values, but certainly is able to identify some conflict between bony surfaces and possible conflict between the implant and bone. It really becomes useful if you really become au fait with the system for easy cases. Then when you now start to use augments, whether metallic or bony of implant augmentation, that's where the real value of the system comes into place. I think once you agree, you are able to print out that, put it up on the wall, your 5D targeter, and that's the key thing. To allow guide wire placement, you decide on your playlist, and then you're good to go. So your targeter, really, after you agree on the plan, you get 5 values back from your from the technicians. You're able to use these 5 feet to place your implant, your targeter. Some of the arms may sit on the periphery of the glenoid, some of them sit on the surface of the glenoid, but then you are now able to translate that digital plan into an intraoperative plan. What the system hasn't allowed, but it's soon to be released, is that you don't really know how deep to ream. So you can place your guide wire, but if you over ream, you might upset your plan completely. I think the Arthrex system now allows you to put a stop on your reamer so that you can ream to a pre-planned depth. So we know that the results are there. So hopefully with time, the entire surgical team is more consistent and confident when they're doing the surgeries. And it really, the VIP offers you a tool to translate the digital plan into a reality in the OR. I thank you for your attention.
Thank you, sir. Yeah. Next, thank you, moderators. Next is Soumyadeep Dutta, sir, Raghavendra Kembabi, sir, Rahul P, Sridhar Gangavarapu, sir. Yeah, the presentation is by Dr. Ashish Gupta, sir, on Acuna Reflect.
So, I have a conflict of interest. I developed this system. Am I going to say this is a Me Too system? Is absolutely not. I'm going to show you what artificial intelligence can do to you. And our aim with this by next year or the year after would be that based on your surgery, based on what you do, you will generate a plan with AI based on what's the best implant position for this patient. Some of my team. So this number is actually almost 300,000 now. And 80% of surgeons are doing this who do less than 10 per year. There's a lot of work which has been done on preoperative planning already. I'm not going to go into this, but this is some of our body of work which we've published, and you can look at it. So what happens with our software is we can do primaries, we can do revisions, we can do trauma, we can do fracture, we can do Latarjet, we can do stuff which nobody else in the market can do. And it's not linked to one implant company, it's agnostic, so you can choose any system. We give you joint line restoration, which is really important to figure out what your lateralization is. All day today, we've been talking about lateralization, but no one's actually shown me how much they measure lateralization and how much lateralization they're getting per patient. You know, a 4 millimeter graft does not mean anything to me if the scapula is really short. So I've published a lot on this, on native joint line restoration and medialization of the joint line and restoration of the joint line. And usually for these traditional methods, most companies either use a contralateral scapulae, but what if that's defective? You can use a mathematical model, or you can use 3D landmarks. And what we've done is we've used every single thing of this and then added statistical shape modeling to this. So this is a really nice slide. When we were in Kathmandu, all individuals come in different shapes and sizes. No one is the same. And so the aim here is to find out what is the best scapula for you. And this is what artificial intelligence does. People ask me, how many data points have you chosen for this? To build an SSM for a particular patient, almost over 1 million data points are calculated. So the era where you needed 1,000 or 500 or 600 CT scans is finished. Is every company's SSM the same? And the answer to that is no. Because you need good quality data to go in to build this artificial intelligence model. You need a really good process, and then you need good data. If the data is not really good, you can't build a trustworthy model. So one of the important things in building this is you need abnormal on one side and you need normal on the other side, because that's the only way you can build a model and teach the computer how to do this. So the data set needs to be representative. When we got our FDA approval, it took us 18 months because we were the first company globally to get SSM FDA approved. And one of the key requirements was that this is racially diverse data. Then you need to be measuring the right thing. And I've talked to engineers from every other device company all over the world, and basically engineers just sit there and point on things and they say this is where the guide wire needs to be. Some of the planning softwares over-represent the superior tilt, and then your measurements are all off. So for us, surgeons and doctors need to be involved in the labeling process. And then you stratify this. So what happens is all this data is put in meshes. It's verified first by the engineer, then it's verified by the surgeons, and then it's verified by the engineer again. And we went through a very complex process to get this through the FDA process. And what our database showed is that less than 20 modes of variations represented 95% of shape variability. So we looked at multiple different modes. This is all AI stuff. I'm not going to go into the detail of this. And we did validations for this. So I'm going to show you the software. So there's automatic. You don't have to wait for crappy internet. It's on your desktop, which was a prerequisite for me, because if I'm in theater, most of our operating theaters are nuclear zones. We do fracture, we do arthroplasty, we do hemiarthroplasty, we do revisions, deformity corrections. One of the key things for us is we have over 900 permutations and combinations of implants which you can use. So you can use an augmented base plate, a non-augmented base plate. Of course, there's interactive planning and stuff. This is stuff which was developed 10 years ago. This is not rocket science. You can create your graft, you can measure your graft so that intraoperatively you can measure your graft. Senthil, I've never used the core reamer which Tonier has. I just cut the graft intraoperatively with a saw. So don't let a core reamer stop you from doing a bi-RSA. But the key bit here is we can customize the graft. And with the bone bank in Australia now, I send this to them and they actually pre-make the allograft for me if I need it. The key bit here is measuring your net lateralization, which has to do with your scapula. It's not just to do with your glenoid neck. So unless you're measuring the scapula, you don't really know what your net lateralization is. I still do not understand how any other planning software in the world can tell you what the humeral version and retroversion is if they don't have the epicondylar axis. It's complete garbage. Just because you've got the proximal humerus and you put a stem in it and you say it's 20 degrees, how can you calculate that? Do people think I'm a complete idiot? Like, do they think orthopedic surgeons? How can you look at only the proximal bit of the humerus and say this isn't 20 degrees aversion? That just because they're giving you a number, it's flawed. So for this, it's very important that when you as surgeons do preoperative planning, you scan the whole humerus, because that's the only way you can plan your length. That's the only way you can plan your resection height and then know what your filling ratio is. Then the other thing which the software now does, it calculates your distalization and lateralization ratios, which is much more important than this gimmickry of range of motion. So we're going to move into a situation now where we're going to look at center of articulation for the anatomic reverse and see how much your lateralization and distalization is, and the software will be able to calculate this for you, so that we can start talking about how much did we distalize in different constructs, how much did we lateralize, and what was our net distalization and lateralization. The range of motion animation is just an animation. It doesn't really make any difference to the outcomes. We published a paper when I was using Blueprint, which showed that the static range of motion, the difference between clinical range of motion and static range of motion, the difference was 90 degrees of elevation, 90. Blueprint underestimated my range of motion by 90 degrees, and especially rotation was grossly different. All the data is collected by you. It comes to your Akuna platform. Your data doesn't go to a device company. It stays with you so that then you can look at how you're going to plan. But the most important thing with AI is this will help you with your revisions. So cases like this, where you need to plan your revisions and figure out whether you need a bone graft or whether you need an augment, whatever I can get to do the best for the patient, I will do that. In cases of humerus, we can plan all of the humerus, we can plan your length, we can do single stage revision. So this helps me plan my APCs and deal with periprosthetic fractures. Thank you. Any questions?
Do you use for only RSD or all our shoulders, like any particular?
I plan everything.
Okay.
You have to plan everything you do.
All shoulders. Thanks.
Thank you.
Thank you, moderators. Next, I call upon stage Kaushik Reddy sir, Vinay Kumar Swami sir, and Naveen Kumaran sir. Now the talk is by Dr. Kapil Kumar sir on tornia, scientific evidence of RSA. Yeah, 5 minutes. Oh, come in right now then. Kapil sir. Yeah.
I think the audience is now dissipating more than faster than radium goes, half-life is. This was supposed to be a talk with the Stryker engineers to give you a bit more about how they've developed it, etc. And I'm supposed to share with you some scientific evidence about the prosthesis that I use. I use the Stryker Perform, which has been out in the market for not long enough to have any scientific evidence on its use. So I'm going to share with you my experience, our data from the last 2 years, once we get the slides. So the prosthesis that I've been using for the last 2.5, 3 years is a 135-degree neck shaft angle, an inlay prosthesis, or flush lay as it is called, and a lateralized glenoid design. And I will show you what our experience has been. So since October 2022, when we started, we were one of the early adopters to use the Striker Perform system in the UK. We've got data on 70 cases, predominantly female, as you would expect, and predominantly in their 8th decade, as you would expect. The vast majority of indications were cuff arthropathy, and the reason there are no fractures here is because we use a fracture-specific stem for our reverses. We don't use this stem, so all our data is non-fracture elective reverse arthroplasty. The vast majority were cuff arthropathies, some osteoarthritis, and some irreparable rotator cuff tears in the older population. If the stem, as I showed you pictures earlier on, it is a metaphyseal fixed stem with a small diaphyseal component. And the vast majority were again what we call, it was size 2, so not a big canal filling stem. And most of them were uncemented, and I'll show you why we had to cement a few of them. This stem can be used for both cemented and uncemented use, but the uncemented use was cemented was in some cases. So these are some of the cases we had to cement them. So this is a infected anatomical shoulder replacement, 2-stage revision. We did not have the courage to put an uncemented prosthesis, which would have been probably catastrophic if we had gone for that. There's another case which my colleague did. It's a malunited proximal humeral fracture. Ideally, we would have used the fracture prosthesis, but due to some technical reasons, non-availability of the prosthesis that day, he went with this, but again had to cement the stem in. That's another malunited fracture with a very, very wide canal, and that's why we went for a cemented prosthesis here. So now it is quite important, and what we have heard all day is soft tissue balancing, neck cut, soft tissue releases. And if you look at it, in vast majority of cases, we've gone with the smallest insert, which means that the soft tissue balancing in the neck cut have been absolutely spot on, perfect. That is why we've managed to get away with using the minimal poly insert. These were all mainly women, so that is why the most common used glenosphere was 36, and we were not lateralizing on the glenosphere. That is why most of the glenospheres were standard, maybe 1 or 2 eccentrics, because most of our lateralization is happening at the base plate. So 25 plus 3, the base plates come in 2 sizes, 2 diameters, 25 and 29 millimeters. Most of them were women, so 25 millimeters. And we were lateralizing mainly on the base plate rather than on the glenosphere, and a fair number of wedges used for the cases that I've shown you earlier. There is a problem with this, especially when you start using it, because the bone is porotic, you don't get, sometimes you can put it in varus or valgus. And 2 things that I've learned in the last 2 years is how to avoid that is, one is get your entry point perfectly, which is right on the top of the humeral head. When you come from the other systems, you tend to sort of go just medial to the cuff insertion. I think in this system it's like an intramedullary nail, so you need to go right up at the top. And the other thing which I've started doing more recently is that put a longer stem trial component that sort of creates a channel, and then you can put the definitive component in. The definitive component is slightly bigger than a trial, so you are okay, you don't mess around with the fixation. The other thing which I'm going to show you tomorrow is how to assess the stability of it is not a hip where you put a stem in and you try and rock it up and down. It is not a diaphyseal fix. You put the stem in and you hold it with 2 fingers and just try and see whether you've got rotational stability. So we looked at the neck shaft angles. Most of them were within 135, which is the accepted. We look at the lateralization of the distalized shoulder angles, which are again what you would expect from a lateral offset stem. We can argue about what's the value of these angles, but I'm not going to go there. We had 2 acromial stress fractures, and both were very incidentally interesting. They both had it at about 6 weeks when the physios increased their exercises and gave them 1 kilo dumbbells to start elevating and abducting. So just be mindful of that. One I have fixed about 4 weeks ago because she had an outer end clavicle and a spine fracture. I shall probably report later on whether it's a disaster or what. So just This is a young lady with severe inflammatory arthritis. She's a hairdresser. She can't work because she's got severe pain. This was the pre-op planning. I saw her last, and this is her range of movement, which is reasonably good with good external rotations. I don't have the time. This is a guy. Okay, that's fine. Thank you very much. So just to summarize, I think bone preservation is great with this prosthesis, using a 135-degree angle with lateralization on the glenoid side. And it's a flush lay or inlay prosthesis, so you're avoiding too much lateralization. And if you understand the prosthesis, then you really don't have the problem with instability or soft tissue. We've had no dislocation in this group. Thank you.
So the industry engineer from Stryker is online, so we'll have a discussion with him.
Also, thank you guys very much for allowing me to join this evening. I hope the meeting is going very well. I'm very mindful of time tonight. I'm going to provide a quick design overview for form humeral and perform reverse base plate. So at Stryker, we start every presentation with our mission and values together with our customers, which are trying to make healthcare better. And I think kind of these two technologies that we've created for an upper extremities perspective, I think definitely kind of focus on this mission. And I want to provide a couple minutes here to review kind of the design rationale behind these two systems. So for those of you I've not met, my name is Doug Garvin. I have the opportunity to lead our upstream marketing team based in the U.S., and we're solely focused on new implant neck technologies from a shoulder arthroplasty standpoint. So we kind of are bucketed from a implant kind of team standpoint, a digital, and then we also have another segment of our upstream marketing team that's working on new technology developments with the Mako application as well. So we'll kick off with really the design rationale there was a transition to provide an inlay or flush lay option as part of our portfolio. We obviously have a flex system that provided an on-lay system, but wanted to provide some additional system offerings for those physicians that preferred an inlay or flush lay design. We believe too that the methodology that we went for a design perspective does allow for expandability from a patient access standpoint with the smaller diameter holes compared to some of our competitors in the marketplace. And then really, we're looking to streamline our offering up the humeral side. So really kind of building off this Perform family with the stem. The stemless implant is currently cleared in the U.S. as well as our factory stem. And then also looking at the transition of our HRS, so our modular humeral revision system, transitioning to Perform compatibility in the near future as well. We really drive scalability from an instrument, but also a shared implant standpoint as well. So look at some design features of the stem. It is a 135 neck shaft angle. We do have the ability to use a 10-degree poly insert as well. There is proximal coating, and the stems from a standard standpoint will come in a standard size, but there's also a plus size that does add some additional porous proximally for additional press fit stability. The stem is polished distally, and the construct is titanium from an overall manufacturing perspective. If we look at Perform Reverse, really I think what's made this system so special is that it's kind of rolled out in the U.S. in 2016 in combination with Blueprint, and really providing an alternative for physicians to identify kind of deformities in 3D. From a system perspective, it is modular in nature with the base plate leveraging either a 6.5 or 9.5 central screw at various lengths, as well as two press fit posts, a short post and a longer post. Both of these will provide alternative fixation options, and really you're leveraging kind of either surgeon preference and or bony anatomy to provide kind of what that central fixation approach could be as part of that clinical application. From a material perspective, these are 3D printed. So this was kind of the legacy Tournier's first, I would say, foray into additive 3D printing. We created a unique porous structure that we have branded as Adaptus that has elasticity similar to bone. We have done some animal studies that basically show bone ingrowth in as short as 4 weeks. And these are 3D printed at our manufacturing facilities in Montreal, France, but also Angrove, Ireland. And this is a baseline technology that we've started to leverage for several other new solutions that we are deploying commercially, one being that perform stemless nuclei are 3D printed as well, in addition to our shoulder ID patient matched base plates that we're rolling out from the US and some other global geographies as well. And then looking at kind of the base plate options as part of the system, they'll come in two different diameters, 25 and 29 standard. And then there's also lateralized +3, +6. And then we have our half and full wedges in both diameters as well. I think we have noted with our US transition to perform humeral a significant increase in the number of lateralized and full wedge base plates that are being consumed in combination with perform humeral. And I think it's obviously with the reduced I would say build up on the humeral side with the tray and poly. It's not a surprise that we've kind of seen that broader transition from a U.S. perspective to these alternative or more metallic base plate designs. In addition to obviously having bio-RSA available for those physicians that do prefer a bone augmentation compared to the metallic augmentation. And then lastly, central fixation. Just going to provide you kind of some visualization here around the various lengths of 6.5 and 9.5 screws we have available. So very robust from a portfolio perspective. These are delivered to be able to leverage if you need to potentially transition from 6.5 to 9.5. That will be available as part of your instrument tray. And then obviously the press with posts are all sterile packed and open kind of at the site of care. From a Glenosphere standpoint, standard, eccentric, and lateralized are available. We have a compatibility matrix that, depending upon which of the legacy base plates or base plate you're using, there is a compatibility matrix around kind of a range of motion assessment we've done with the Glenosphere. Peripheral screws, how it's built out from a base plate perspective is you have free orientation with the flat base plates, standard and lateralized, to orient your peripheral screws from a compression locking standpoint as where you would like rotationally. And then with the augments, it's basically one compression, and that's going to be at the thickest portion of the augment is where that screw will always be oriented, with the remaining being the three locking screws. And then we have a myriad of peripheral screw lengths that can be consumed based upon patient bone that's there to be drilled and filled with the corresponding peripheral screws. So that's all I have for today. I appreciate very much the time to join this evening, and hope you have a successful remainder of your meeting.
Oh yeah. Thanks a lot. Next up, we have the Arthrex industry engineer, and the moderators are Jamin Jasalpura sir, Dr. Nataraj HM, Dr. Amit Jha, and Prince Shanawaz Khan. Welcome.
Good evening, everyone. Yeah, thank you for having me. I'm not the industrial engineer. I'm a business manager out of the Dubai branch, but I am from Arthrex, so they've asked me to just give a little overview of our reverse that we have. So please do not ask me any difficult questions while I'm here. As I said, I'm just going to give an overview. So I'm going to start in the medial components of our reverse glenosphere. This is our new modular glenoid glenosphere. And the benefits of our glenosphere is obviously it's designed to accommodate varied glenoid anatomy. It comes in two sizes, a 24 millimeter and a 28 millimeter. It comes in a central post and a screw option, varied between 15 and 35 millimeters in length. Coming to glenosphere sizing, we have a small 33 millimeter, which obviously is designed for your Indian and Asian market, up to 42 millimeters. Soft tissue tensioning, of course, standard lateralized by 4 millimeters and an eccentric option available as well. Your glenoid vault fixation, as I mentioned before, we have a screw and a hybrid post. All of our implants are now coated with our new BioSync matrix ingrowth material, which is interconnected porosity and enduring fixation through bony integration. So our peripheral screws, we have a 4.5 non-locking and a 5.5 locking option. They can be used interchangeable in any of the screw holes. A 20-degree variable angle on our non-locking screws and a 10-degree fixed angle on our 5.5 locking screws. Then we have lateralization options on our base plate and up to 8 millimeters of lateralization with our glenosphere. Organized in a easy to follow surgical sequence. And then, of course, when used in combination with our preoperative planning with our VIP, we've had very, very good results from our new prosthesis that's available. So, some of the clinical articles are out. We've got a lot of scientific updates throughout the years. As I mentioned, our reverse has been launched in 2012 already, so it has been around for quite some time. This specific clinical article is from the SHARC, which is your Shoulder Arthroplasty Research Committee. And the SHARC group recommends that up to 6 to 8 millimeters of lateralization with a non-augmented base plate and 4 to 6 with lateralized with an augmented base plate to maximize your range of motion, particularly internal rotation. Most SHARC surgeons decrease lateralization for women as opposed to men, and of course in fracture settings 2 to 4 millimeters of reduction. So just a quick remaining on the reverse, I just want to play this. Can you play this? Can you play that video for me, please? So we do have two stemmed options available. We do have a shorter apex stem and the standard reverse stem. And then our humeral components have two optimal inclination angles with the same implant. So we do have the 135 neck shaft angle as well as the 155 angle available. And then all our stems are rectangular shaped angled for rotational stability. And of course they are grit blasted and calcium phosphate coated. So our shorter stems obviously have multiple options for different pathologies. The standard reverse stems, which are 11 different stem sizes available. And of course we have longer revision stems. Then looking at your cup sizes, we've just launched the new size 33 cup in India now, which has just become available. So they range from a 33 up to a 42, and you'll see that they all come with these new suture eyelets as standard. And then we've got a different offset, a central and a 2 millimeter offset on either way. And then of course our humeral inserts come with your standard and a thicker option with constrained options. And of course we have combination humeral inserts as well. So just the takeaway that I'd like to just sum up is we currently have the smallest, most versatile base plate on the market. We have more lateralization options. We've got the smallest glenosphere, best bony growth and bone sparing solutions, and we have a unique 135 and 155 neck shaft angle. Thank you very much.
That was an extensive opinion of the implant. Next is Dr. Nitesh sir is here. Okay, next talk. Thank you, moderators. Next is Dr. Jai Prasad sir.
Yeah, one question.
Yeah,
just
yeah,
for the
yeah, of course. Yeah.
Yes. Particularly the surgeons who are using Arthrex, I would like to ask the question to the house. You need to push the stem quite in because it's a inlay system, and you need to have a reamer, and you need to remove the bit of proximal bone as well. So in particularly the female patient, short stature, what we have observed, the canals are small, osteoporotic bones, and in follow-up, our observation is that there is a stress shielding effect and osteoporosis, particularly with this stem. So any in the proximal part.
First of all, Arthrex system is neither inlay nor onlay. It's half lay. It's half lay, and therefore you don't try to bang it in to make it an inlay. Otherwise, you might fracture the proximal humerus. And honestly, I haven't seen stress shielding in the proximal humerus so far. Nitesh, what do you think? Nitesh Bhagwan is here?
He's not here.
Not
Yeah. So next I request Dr. Sandil Velan sir, Dr. Jayaprasad sir to moderate the session. This is the Zimmer industry engineer talk as well as the scientific evidence by Dr. Nilesh Kamath and the industry engineer.
So last man standing, there's no industry engineer here. I'm not here to advocate for Zimmer. I'm going to give you a surgeon's perspective. Well, I moved to Zimmer Biomet around 5 years back post-COVID because Exatech moved away. And what I want to emphasize on this is whichever system you use, you need to understand the nuances, you need to understand the design. Without that, you can't go ahead using any particular system because one of the key opinion leaders from the audience is using that system. And I think that's something I'm going to overemphasize. So whichever design you use, you need to understand the classification, whether it's medialized glenoid, lateralized humerus, or medialized humerus. So this is the rationale of whichever reverse you're going to use. You heard the previous speakers talk about this, not going to go into this, and you will have all design systems which are available in market. You need to pick up your choice and then go ahead with it. So if you look at the construct with the ZB system, right, you have all these parameters which are there. And how do you work on this? So we'll try to break this down, keep it absolutely brief, and then talk about some of the scientific data which is available. So let's start with the base plate. We know the Indian glenoids are small. We need smaller glenoid base plates. The earlier base plates would have a significant overhang. Now what you have is a 25, and probably more than 99% of my cases, I would be using a 25. Very rarely, if there's a big build guy, I might use a 28. You have, look at this on a plasma porous coated spray that allows for better integration. You got these 4 holes. More importantly, it is circular, so you can change it in whatever direction you would want, rather than few of the other systems which have an oblong ones where you're fixed or you're committed to the direction. Now you also need to understand that these screws which are there will give you a 4.75 mm screws, but most important is the central compression screw, which is 6.5 mm. And why is this important? Is because for osseointegration, whatever material you have behind the base plate, more than that, micro motion should not happen. If there is micro motion, that's where integration is going to fail, that's where it's going to cause loosening, and this is something which is important. So your 6.5 mm are right from 15 to 30 mm, and if you're looking at a 4.75, that's 15 to 45 mm. If you can put them in a locked form, or you can put them in a non-locked form, and you have a 6-degree angulation to it. So what is the advantage of the augmented base plates? We have been talking about glenoid deficiencies. In fact, some of the key opinion leaders for ZB talk about the fact that even if you want to get the inferior tilt, you use a superior augment. So that invariably will give you an inferior tilt, will allow you to work in that direction. Now when you're looking at this, you have various augments. So you can have a small wedge, you can have a large wedge, and I'll come to that. And we don't have this in India, but I'm told in the next 6 months, the vault reconstruction system is something which is going to come in, and I think that's going to be a game changer altogether. But when you're looking at these augments, you can have a small, medium, large, which may be a 3 mm, 5 mm, and 7 mm. And the instrumentation is very simple to calculate your augments. And with your pre-op planning, you can look at the amount of contact. And we won't go into that because I think previous speakers have spoken about that time and again on how the amount of contact between the base plate increases. But what about the glenosphere? The glenosphere is a press fit with a Morse taper. So when you're looking at a glenosphere, you're either having a 36 or a 40 mm. What is great about this? Because it has a versatile mechanism. That means you can dictate your eccentricity which is there. In the 36 mm, you have a variable offset of 0.5 to 4.5, and in the 40 mm, you have from 1.5 to 4.5. You can look at lateralization of a +3 or +6 mm, but don't get too excited. And you have heard Ashish Gupta speak about this, that lateralization is not what something you're looking for, because again, as you keep lateralizing, the forces at the interface keeps increasing. It also allows you to change the center of rotation, and that's something you need to be aware about. If you look at the tray, you're looking at a 40 tray and you have an eccentric offsets which are there. And this is something which is really helpful. And let me explain this to you. That many times you might see that when you put in your neutral tray, the humerus is lateralized. There is uncovering of the tuberosity, and that's why using an offset tray allows you to medialize the humerus to a certain extent and makes your reduction easier. So you can see that's a 0 lateral offset. The tuberosity might be slightly uncovered. If you feel that the reduction is too difficult, you can probably get in a plus 3 and medialize it further. Very rarely do you have to use a plus 6 Effect of range of motion, because you are medializing it to a certain extent, it allows a better free arc and does not cause any impingement. Looking at the neck shaft angle, it's a 135 but gets converted to a 147 because of the poly which is built up on the medial side, and that's something which is helpful from notching perspective. Just a few more slides, and if you look at the sizes which are available, you have a micro stem to a standard stem that's from 50 the mini which is routinely available in India at 83, or the standard at 122. All the fracture stems which are available are at 122 and again, you've heard about impaction grafting. You don't need to go like a hip to keep on increasing the size, and that's something that I learned from Ashish. That I remember his talk where he said that never ever does he go beyond 7 or 8, and that's the max that he goes, and he relies lots on impaction grafting. If you really are in doubt, well, this is a smooth tapered, polished distally. You can cement it, but I don't really think the need for it. The fracture stem has these tuberosity holes which allows you to fix the tuberosity the way you are looking. I'm going to skip all of these slides for your planning, but what I want you to see is evidence-based. And if you look at the data from the Australian registry, they have compared all the designs which have been used in Australia, and I'm sure more than me, Ashish would be the right person to talk on this. The comprehensive reverse has the lowest 7-year revision rate for a primary total stemmed arthroplasty as compared to any of the other data. And not just that, whether you're looking at it for a primary OA or whether you're looking at it for a cuff tear arthropathy, again, the survivorship of a comprehensive reverse is something which you have data with you. And I would like to believe what I see. This might change in the years to come, but at this point of time, I know that I have this data with me which allows me to go to bed peacefully knowing that yes, I can assure my patient a good outcome. Is it only the Australian data? No, even the New Zealand data talks about something similar, and the highest or the largest registry in the world, the UK data again talks about the lowest revision rate with a cumulative revision rate of as less as 1.82% over 7 to 10 years. So I think data is something which really drives us all forward. So at this point of time in my hands, I feel that this is a prosthesis that I can rely on, but mind you, it's not necessary that this might be the same statistic another 10 years down the line. So keep your mind open, understand the design, understand the nuances, and then offer the best to your patient. Thank you.
Thanks all. It was a great discussion we had, starting from the patches to I think we have discussed almost everything in shoulder replacement. So this is the kind of talk and discussion we wanted. And if you can see, at least half the hall is full. And these are people who are really interested in this, really want to know about it. And from bottom of my heart, I would really like to thank everybody. Faculty dinner is ready. The banquet is on. Please join. Thanks.
Hello, there's one announcement. For those who have a presentation tomorrow, you can upload your files, presentations at the desk